Ben ne yapsam, şey mi yapsam? Sen al diye aşağı. Oradan biraz.
Hangisini seçeyim?
Bulanıklaştır yazıyor. Sende şey yok mu planlar? Ha, onu sonra yaparız. Yüklemen lazım.
Hiç uğraşmadığım için böyle şeyler.
Good morning, Dr. Epson and Dr. Topkan. Good
Good
morning
morning.
from India.
Good morning, Dr. Agrawal. How are you?
I'm doing fine. How are you?
So do I. Thank you very
Thank
much. It is
Great.
still dark in our country.
There is a echo.
We are in the early morning. We are still in the early morning.
I think there are the two devices working simultaneously. That's why we are, hearing echo actually.
Şurada oturayım.
How is it now?
No, it's fine now.
Okay.
Yeah, it's fine.
I hope we will start at time and finish at time.
Yes, yes. We'll take 2-3 more minutes to, start actually.
Okay, okay. Dr. Agrawal, as you know, this is really a regrettable discussion subject. However, somebody has to talk about it. There are many problems.
Yes, yes, of course.
Statistics is a very, very difficult, and many of medical doctors do not know enough statistics, and we are always reading articles with great amusement, but there are many problems, as we will see soon. I hope.
Yes.
I hope it will be a productive presentation for everybody.
Yes, of course. It will really a productive one actually. So to all audience uh, here in Delhi, we have a nice sunshine. I am joining from the capital of India, the largest democratic country in the world, and our capital is electing legislature today. So there is a polling happen a day after day before yesterday, and the counting is today. So the population of the capital is electing their representatives and legislators. So they are choosing their MLAs, and it's a nice sunshine. We have 15 degrees centigrade temperature here in Delhi. So we are a bit of say end of the winter here. So I hope the weather is in Istanbul. From where you are joining, Dr. Topkan?
I am from Başkent University, and we are in Adana. However, we have many Başkent University sites in Ankara, Istanbul, Antalya.
Yeah, Ankara.
Yeah. Ankara is the capital of Turkey, you know.
Yes, yes.
We, I and Dr. Somay and Dr. Selek talked on Thursday about osteoradionucleases from the same team, study team or the group.
No, I saw, there are many, papers. I think you published jointly as a, co-author and all.
Yeah.
So it's 9:31. We just take 2-3 more minutes. Let more people join in. We have there's a two process of watching our program, Dr. Topkan and Dr. Epson. One is that we are webcasting it on our website called IOCCON.org. And the audience, those who want to ask question or interact with the speakers, they are coming into Zoom meeting room as well. So we have, I think, 8 to 10 people who are in the meeting room, and slowly and gradually we will be getting more person. But most of them are watching live on the website. So we are not 9:32. So without wasting much time, because you guys are particular about time and all, and you have to rush somewhere as well. We are really thankful that you have spared your time and joining, and I'm really thankful to Dr. Epson as well. She helped us to bring you in the board actually. So I'm really thankful to Dr. Epson, and Dr. Epson is a very energetic, very speaker and all, and he keep on guiding us, patterning us, joining from Turkey. We are India, and he is a part of our many programs actually. So she would be joining in the International Pink Dental Congress. So she was with us with last our three editions of International Oral Cancer Congress, as well as she is in our team in Pink Dental Congress. There is a very customized program for dentists we are doing in India on occasion of World Can this International Women's Day. We are giving a get together of women dentists across the world. So they are joining and discussing what they are doing in their field actually. So over to you, Dr. Efson. You just introduce your country colleague, and then we'll start the sessions for the today.
Thank you, Dr. Anwar, for your kind presentation and for your kind thoughts about me. Good morning, everyone. As our Congress progresses with great momentum, it's my distinct honor to introduce Professor Erkan Topkan, a highly esteemed expert in radiation oncology. Let me introduce him. Prof. Topkan earned his medical degree from Hacettepe University, Faculty of Medicine, in 1996 and completed his radiation oncology residency program at Hacettepe University. He subsequently held key academic positions, serving as assistant professor and chairman of Department of Radiation Oncology at İnönü University Medical Faculty. Then he joined Başkent University Medical Faculty's Department of Radiation Oncology, where he was appointed associate professor and later chairman of the Department of Radiation Oncology. Professor Topkan further specialized in gamma knife radiosurgery, obtaining certification from the University of Pittsburgh Medical Center's Departments of Neurosurgery and Gamma Knife Radiosurgery. Since 1910, he has been serving as a professor of radiation oncology. With an extensive academic background, Prof. Topkan has made significant contributions to field through over 100 peer-reviewed journal articles and book chapters, co-editing for textbooks, and serving as a reviewer and advisor for multiple international journals. He is an active member of several national and international oncology societies, including his role as an associate director of the Turkish Oncology Group's Head and Neck Cancer Subdivision, and his involvement with the Turkish Science Academy's Palliative Care in Cancer Subdivision, the Turkish Society of Radiation Oncology, the Turkish Society of Neuro-Oncology, and the Turkish Society of Lung Cancer, and the European Society of Medical Oncology. And it's both an honor and a privilege to introduce Professor Erkan Topkan, a distinguished scholar and guiding force in our research group. Professor Topkan, the stage is yours.
Thank you very much, Dr. Somay. for your kind presentation and invitation with Dr. Anwar to me to this stage, providing the chance to talk about this very important subject. Now I am going on with my presentation. Here it is. I have problems with the sharing. I am banned from sharing my presentation. Could you please open it?
Yeah, please, just wait.
Problem.
Dr. Erkan, your
Thank you.
slides
Thank
are
you very
visible.
much. Thank you very much. Now we are starting with the presentation. Good morning, everybody. Good morning, my friends. I would like to thank the organizing committee for their kind invitation to me and providing the chance to share my thoughts about statistical problems in head and neck oncology. This is my conflict of interest. I have nothing to declare. Let's go on with my presentation plan. I will, after a brief introduction, we will discuss five specific topics about the very common mistakes in statistics in head and neck cancer research. These are presenting and comparing data problems, using unadjusted p-values for comparing multiple groups, applying statistically invalid cutoff values, defining survival endpoints in an incorrect manner, and conducting multivariate analysis with omission of potentially significant factors. Then I will present my concluding remarks and my presentation will be at. Then let's go. To begin with, what is statistics? It is a branch of applied mathematics that involves the collection, description, analysis, and inference of conclusions from quantitative data. It is also an art besides being a science. It calculates the actual conditions, like it's always it may calculate the probabilities like the game of heads or tail, or reveal the actual conditions. For example, in a head and neck study, what are the frequencies of males and females, or it may guess something in future, like the estimation of the survival times at 5 years, 10 years, whatever you want. However, there are also some problems with statistics because it may be used as a very useful tool to lie about the research findings. As Mark Twain said, there are lies, there are damn lies, and then there are statistics which can be more harmful than the damn lies. However, it is easy to lie with statistics, but we have to know that it is hard to tell the truth without using statistics. We are talking about the frequently encountered statistical mistakes in head and neck oncology research, and the first fact subject is presenting and comparing data in a statistically invalid manner. As the rule of thumb, data presentation should adhere to the standard methods, whatever you are searching about or whatever the subject of your research is. Data presentation should enable comparisons between different studies to reach solid conclusions about the related topic that you are dealing with. It means you have to compare apples with apples, not apples with oranges, to be not biased. However, many people compare apples and oranges and then go to bananas over the statistics, as you will see in my further presentation. The first study I will talk about is from my country. Dr. Aral and friends explored the efficacy of radiotherapy versus chemoradiotherapy in salivary gland tumors. In this study, the chemoradiotherapy is, as you know, is now experimental, not the standard of care for this kind of tumors. What did authors do? The study is very problematic. As you can, let us compare something. What was the primary between the radiotherapy alone group and concurrent chemoradiotherapy groups? The authors declared the parotid tumor was the most common tumor type in the radiotherapy alone group with a 79.5%, but it had only a frequency of 20.5%. However, as you see, there are 34 patients in a radiotherapy alone group and 31 is parotid tumors, which makes 88.8%. And there are the 8 of 13 patients in the concurrent chemoradiotherapy group accounts for 61.5%, not 20.5%. What is the problem with this study? The authors compared the rows. It means, what I mean is that the authors research for the distribution of the radiotherapy and chemoradiotherapy for the tumor types. However, what the authors have to deal is the distribution of the tumor types in each column. What I mean is the treatment groups, then compare them with each other. As you see, most frequent tumor is well calculated with the in a right manner. Parotid tumors become the most common tumor type both in the chemoradiotherapy and radiotherapy alone groups, which is in line with the literature that we can easily achieve. The data that primarily in this study is also, according to the author's data, presents the female patients, which is not right. I know these sentences are somehow harsh, but I have to say such studies will unavoidably lead misleading results. I think it is better to stop reading them once you examine such tables. They can add nothing to the literature. They just lead to misinterpretations and probably erroneous treatment decisions that will harm the patient's treatment and probably prognosis. The wrong path cannot guide you to the right destination. Please don't forget it. We have to protect the unaffected patients in such conditions. We have to warn them. Another study from our country, Dr. Jajina and her colleagues examined the surveillance promoter, which is the regulator of the cell cycle and apoptosis. The aim was whether the variations what was the frequency of the variations in oral squamous cell carcinoma patients and about prognosis. Please note there is prognosis here. Then we will come back to this subject. When we go on to the tables, we see that, for example, for smoking status, the author said that in the control group, there were no smokers, 0%. However, it was 63.9%. More than nearly 2/3 of all patients were in oral cases active smokers. However, the p-value is 1 here. To be 1, let's go to the definition. In statistical terms, a p-value of 1 indicates that there is a 100% probability that the difference between the two groups is 0%. In other words, that the characteristics or outcomes being examined are exactly or nearly identical. Then the question arises, how can those p-values be 1? Let's go further. When you go further, you see that, for example, for the T stage, for the lymph node status, let us check it. In the one group, it is 62.5%. In the other group, it is 20%, and p-value is not significant, although it is more than 3 times than the CC group in the GG plus GC group, guanine cytosine or guanine group. These are not valid. We know that for this for both of the previous and this article, we wrote 2 letters to warn the journal and the readers. The authors, as they said, they will talk about the prognosis. However, they didn't present any data about the tumor control rates or patient survival data, but the author said or concluded that we are in the opinion that survivin 31 gene variation may be have significant effect on tumor aggressiveness and prognosis. How did you reach this result? Probably they reached this result because previous studies declared some such kind of data, but we should not do that. We have to discuss what we are researching and what we have in our hands. These are just subjective conclusions which are not valuable. We have to focus on what available data when we are discussing about this data. The second subject, another common problem, is the unadjusted p-value usage for comparisons in multiple groups. And when I say multiple groups, it is like the Arabic language. In Arabic, you know that multiple is not 2, multiple has to be 3 or more than 3. Let us give 2 examples. In the tip extreme study, there are 2 groups. One extreme and the other group is the tip experimental arm. In keynote study, there are A, B, C groups. You see, it is not important. It is not important what you're about for us because we are talking about their statistics. We know that for binary comparisons, which means 2 groups, p-value is usually 0.05 and it is valid. However, when it comes to the 3 or more groups, is it valid to talk? We have 3 possible comparisons, as in the keynote study, A versus B, A versus C, and B versus C groups. Is a p-value 0.05 is enough, or is it valid for comparisons? Does it indicate significance between the group? If it is not, what we have to do? We are going on with the subject. A p-value, or in other words, alpha value, may be appropriate for each individual comparisons. However, it is not for the set of all comparisons. In that point, Bonferroni correction comes in action, although alternative methods are also available, like Sheffield's test or Taki-Kramer method tests. They are more complicated than Bonferroni's corrections. Then what is Bonferroni's correction? Carlo Bonferroni's correction deals with such problems and says that if we are comparing all possible pairs, you have to correct the p-value with the formula given below. Well, how many? It is a combination. We need the alpha prime value beside the alpha. In other words, p prime value. For this, we use combination formula, like in the K, where you see the K. In brief, if we have 3 groups, we have 3 possible comparisons, then we have to divide our p-value 0.05 to 3. If we have 4 groups, there are 6 possible groups, we have to divide it to 6. And if we have 5 groups, we have 10 possible groups, then we have to divide the p-value to 10 for significance. For 6, it is 15 groups. We have to do it. Although there are many such studies in the literature, the most striking and probably the most regrettable but illustrative study comes from the prostate cancer. Everybody knows that McRoach is a very well-known prostate cancer author. He planned to compare the whole pelvic radiation therapy with the prostate-only radiotherapy, then go with the neoadjuvant and concurrent hormonal therapy and adjuvant hormone therapy. As you see that the study design is 2x2 format, but the analysis was performed, everything was only 2-arm, and the authors reached a significance level of only 0.0 for the borderline significance of 0.048. This was a very harmful study for many years because of that results. Whole pelvic radiation therapy and the adjuvant plus concurrent hormonal therapy was regarded as the standard of care until the studies corrected this notion. If confirmatory correction was used in this study for significance, as you can see, we have 4 groups to compare. Then there are 6 probable comparisons. The p-value should be 0.0083, smaller than 0.0083 was required for a significance level, which is 5 times more than the author's significance of 0.048. This is the unforgivable type 1 error that probably harmfully affected the patient's health status. Another subject is the statistically invalid cutoff values. Let us go, what is a cutoff value? When we look to the Cambridge Academic Content Dictionary, it is a fixed point or level at which you stop including people or things. For example, in Turkey, if you get a monthly salary less than 81,000 new Turkish liras, it is the cutoff for poverty. You are in poverty in Turkey. What are potential cutoff values then? There are modes, mean, medians, cutoff finder, software, rock curve analysis, related cutoffs. Let me give you an example and then go on with it. Let us think that we have 5 oral cavity cancers, 8, 19, 7, 27, 67, 72, and 81 years. The mean of this group, as you see, it is 53.2 years. But where is this patient in this group? It does not represent any of them. Mean, because the mean is the average of the given numbers and is calculated by dividing the sum of the given numbers by the total numbers. In brief, it is the center of the mass. Median, the median value is 76. The median is the middle value in a set of numbers and is equivalent to the 50th percentile, which is the central position in data space. As you see, 67 years of a median is too far from 19 and 27. If it is a cutoff, is there a better cutoff at 40, 45, 50, 55 years? This is a question. The mean and median are, don't forget, that are always mandatorily present within any numerical data sets. They are not true cutoffs and should not be regarded as a definitive cutoff points because of their mandatorily obligatory presence in any set of numbers. But if this measure exhibits significance, it may indicate that existence of a more robust cutoff at an alternative value, rarely that matches the mean or median values. Cutoff finder is a method to find the cutoff, as Badier and his colleagues created in 2012. However, although this is a comprehensive tool, it necessitates the re-entry of the data and it is time-consuming. There are challenges in interpreting the results if users lack familiarity with the software's functionalities. Although it is useful, it is really a comprehensive, sometimes difficult to interpret. In that point comes the receiver operating characteristic ROC curve, which is readily accessible in SPSS and easy to calculate or compute, whatever you say. What is a ROC curve then? A ROC curve is a graphical plot that illustrates the diagnostic ability of a binary classifier system as its discrimination threshold is varied. We have area under the curve, which is 1 or 100%. We have a random classifier or the neutral line, where the area under the curve is 50% below the curve and above the curves. What does a ROC curve represents? It in the y-axis through positive rates. In the x-axis, it represents the false positive rates. Don't forget it. These are formulas. These are not important. I talked about it. I just talked about it. This is how we can find the cutoff value. I will go on with it. There are some ways of finding the cutoff values: analytical methods, maximum weighted methods, or using the J-index, or the largest rectangle method, or the minimum distance method. Two ways are easiest. One is the shortest distance between the 1 point in y-axis and the ROC curve, as you see in the first graph that is shaded with blue color. If you read the y-axis, you will get the sensitivity. If you read the x-axis, you will get the 1 minus specificity. Another one is the J-index. We will go with it. J-index should be the highest in this study. An important study about the subject was the Locke and his friends study. In that study, the authors dealt with whether the gross tumor volume in clinical studies of IMRT could affect the prognosis of patients. In this study, probably by chance, the median value acted as a cutoff value. However, could this phenomenon be attributed to statistical chance resulting from the significant impact of pathological gross tumor volume? Or was there another cutoff that would have provided a more robust dichotomy between the two groups? We cannot say anything about it because we do not have the data from the study, but in another example, we can solve this problem. Lin and colleagues similarly designed a similar study and said that mean or median values did not act as a significant cutoff, as you see. But ROC curve identified 38.15 as the operating cutoff that dichotomized the patient into two significantly distinct survival groups. This means that we should never use the mean or median values, because these are not that may hide the significant or more robust cutoff. If you don't have any cutoff in mean and median values, please go on with ROC values and don't use these as the exact cutoff values, what I can say in this stage. Another important, probably one of the most important problem, is defining survival endpoints incorrectly. It is a common practice, mostly coming from the China. Such studies are coming from China, but also other countries also publish like that. On this stage, two consensus recommendations have been published at last last year in the Lancet Oncology, both for the metastatic patients and curatively treated head and neck cancer patients, I think, which are also valid for other sites. We have progression-free survival, or in other words, interchangeably used disease-free survival, although they are not exactly the same, which is the interval between the diagnosis, treatment initiation, treatment completion, depending on the author's choice, and any kind of disease relapse or progression or death. Another one is the overall survival. It is just interval between these points and death of any cause. local progression, regional progression, local regional distant metastasis free, biochemical free survivals always lays between them. As you see, progression free survival is always smaller than local regional progression, distant metastasis all lay here. And at that point in between the overall survival and progression free survival, overall survival should always have the greatest value with its median or any time point estimations. A specific exception is the cause or disease or cancer specific survival, whatever you call in your research. It does not count for the deaths, for example, from a traffic accident or heart attack. It counts just for the cancer as the cause, so that except for this cancer specific survival, none of the survivals can have values higher than overall survival. If they have, the statistical method or data coding is problematic in such studies. As an analogy for radiation oncologists, we have GTV, CTV, and PTV. As you see, these are representative for it, but the others, this may not deal with it. I will go on. So that's. Let's turn back the Aral and colleagues study. In that study, the author said that the median disease-free survival of the patients was 48 months. However, when we go on with the disease-free survival graph, we see that even at 150 months, it is about more than 70%. However, to reach a survival like that, the event number should exceed more than 50% of the cases, but the authors have more than 70% patients at that point. The same is also valid for the overall survival. It is a 58.5 months, the median is, but it is nearly 60%. And interesting, so that it is not reached. These values are not right. They are not correct. As you see, regrettably, overall survival is smaller than disease-free survival. But how? You can see from the lines, this is the 50% event line, none of the survival endpoints reached, and this is the green line is the overall to compare line is the line for comparing the data from between the disease and overall survival, disease-free and overall survival. We wrote a letter about this to warn the authors and their readers. Another study comes from the UN in France. In the study, the subject is not important, but the authors used metronomic S1 as an adjuvant chemotherapy to improve the nasopharyngeal carcinoma prognosis. However, the problem is again the same. Overall survival is shorter or has values at time points lower than local regional progression-free survival. This is not acceptable, and this is statistically not possible. What is the main problem with these studies? This table is from my letter to this article. For local regional free, distant metastasis free, and disease free survival, the author takes the events as the main point and that as the events. In standard definition takes always that as an event. However, you et al. Didn't take this deaths as an event, just local regional, any kind of relapse or distant metastasis were the events for them. But let's go on with the definition. Distant metastasis-free survival. We have two components. First, to be distant metastasis-free and to be a survival. Then you have to meet both conditions to be free, to be distant metastasis free, but as you see, this is not the case in these studies. Another study comes from a highly esteemed radiation oncology biology physics journal, which is the holy journal for radiation oncologists, for me, in other words. It is regrettable that this was a randomized trial that might affect patients in the study. As you see, local regional failure-free survival was had values greater than overall survival. How it can be scientifically, it is not possible. What is disgusting for me or regrettable for me is that we wrote a letter to the journal, but the journal rejected it after a long time. The reason was it will negatively impact the journal's reputation, which means that sometimes the journal's reputations may become more important than the patient's life or the research societies to achieve rights to achieve the right decisions or right data. Another example is that you see that overall survival is 90.5%, but the other survival points are 96.8 and 93.6%. These are not possible, my friends. Another study comes from our country and our radiation oncology group. There are 25 researchers in that study. As you see, 3-year disease-free survival. At 3-year points, overall survival have values or estimates lower than local regional recurrence-free survival and distant metastasis-free survival. This is also not possible. A recent one comes from another highly esteemed journal, Oral Oncology. In that study, 3 chemotherapy regimens were compared in nasopharyngeal carcinoma. This is very interesting because the authors said that the primary study endpoint is overall survival and defined it at the time from the treatment initiation until the death from any cause. Don't forget, it is death. Another primary endpoint was progression-free survival. Again, time from the treatment and the progression of patient death. In primary endpoints, the authors use that as event. But when it comes to the secondary endpoints, they included recurrence-free survival, which measures the interval from treatment initiations to disease recurrence. Why not that? And distant metastasis-free survival, time from the treatment start to the occurrence of distant metastasis. Why not that? Again, we wrote a letter for this. Thanks for the journal. They accepted and published this. Another problem in the study is that maybe we can discuss it. Can there be more than one primary endpoint in a study, overall survival and like progression-free survival? Does it decrease the value if we put the progression-free survival in the secondary endpoints? This is an important question in research. You know, Sai and his colleagues are they are highly esteemed authors in head and neck oncology, and they, in a large, extensive study, they compared the hypopharyngeal squamous carcinoma patients' prognosis after primary surgery and after primary chemoradiotherapy. Regrettably, this is an illustrative study that some statistics cannot be like that. Don't forget that survival curves cannot start below 100% at the 0 time point because it means that some of your patients that are dead before the start of the study, you see, it begins from the something between 60 and 70%, and in the other group, something somehow about the 40%. These are not possible. All of them has to begin with 100% line. And the last, I think it is my last 3 slides. Conducting multivariate analysis while omitting potentially significant or established factors is a great problem. And I will give only one example for this because there is a regrettable but illustrative study by Watson et al. That has been recently published in Journal of Clinical Oncology, which is a highly esteemed oncology journal. Though in this study, more than 3,500 patients were included, and the authors found that 8% of them had osteoradionecrosis in that study. The authors stated that oral cavity or oropharyngeal primaries and IMRT dose more equal or more than 60 gray were factors, significant factors increasing, elevating the risk of osteoradionecrosis. The question is that is there any solid biological, radiobiological, metabolical, or any any other kind of solid data that says that, for example, inflammation, these tumor types are inherently more prone to osteoradionecrosis, or is it just a game of the dose received by these organs? There is no solid evidence to support these results. So we wrote another letter to this. And thanks for JCO that they accepted and published this data. After this letter, let me say that the upcoming recently published consensus didn't cover these subjects, unfortunately. It also deserves another letter. Multivariate analysis may erroneously suggest independence among certain factors if these factors are influenced by more substantial variables that have not been considered in the analysis. For example, in this study, doses, the established doses, 50 or 60 grays, can be controlled so that the real difference between the tumor sites, for example, a group of oral cavity cancer receiving mandibular doses less than 60 grays and nasopharyngeal carcinoma patients less than 60 grays will reveal what I am meaning. I think there will be no difference between these tumor types in terms of osteoradionecrosis incidence rates. You should remember that multivariate analysis cannot create new data. What is your input will be your output at the end of multivariate analysis. In other words, as you saw, so shall your reap. This is my last slide. My take-to-home messages are numerous types of statistical issues frequently arise, as you saw in the presentation in head and neck cancer research. In that point, experienced journal statisticians must truly review all manuscript and exercise grade questions before sending them to the review process. Reviewers also should have a solid understanding of the fundamentals of medical statistics. Statistics should not be viewed as a simplistic game of zeros and ones. At that point, I think that every medical academicians should know at least the basics of medical statistics, including survival analysis, cutoff finding. Data must be presented in a clear and appropriate manner. Statistical methods should be selected based on their suitability for the study. Survival endpoints should be adhered to the established standard definitions. We should not create new definitions because it will render our ability difficult to compare our results with others. Results need to be interpreted in the light of the observed data, not with our hopes. Journals should allow letters to the editors or commentaries. Sometimes they say, write it to the authors. I can write it to the authors, you can write it to the authors, but this will be a discussion between us. But the old world, all the academical society should know this data or corrections to go on with that data to not harm the patient's prognosis. To protect future research and patient welfare, please consider writing letters or correspondence in such studies, but I advise don't build your career solely on them. Always try to write original manuscripts. Thanks you for patience.
Thank you, Professor Topkan, for your valuable and important presentations and for sharing your knowledge about statistics with us. Any questions? You can ask with chat.
Dr. Epson, if anybody want to ask question, they can put on a chat box.
Okay.
And if Dr. Topkan has time, he can stay with us another say half an hour is possible. Otherwise, we'll go with this our next speaker with the permission of Dr. Topkan, and we will be putting he would be answering on the chat box only.
Thank you.
Should we move to the next speaker, Dr. Epson and Dr. Topkan, with your permission?
Thank you very much for your kind invitation again.
It's a very important actually topic you have selected, because there are n number of papers we are going through on a daily basis, and there are so many research papers is being published, but they are not considering the statistics well actually, so they're not presenting, and there are many errors and all. So you have highlighted those errors. So those are the authors who are in the meeting room today, and those who are the oral oncologists who are viewing and watching us, they would understand that whenever they are publishing their papers, they take care of these errors in account.
Thank you very much for
Thanks,
your
Dr.
kind feelings.
Topkan, joining across from Turkey.
Thank you very
Thanks.
much.
Yeah. Okay.
Thank you very much.
Yes. So with the permission of Dr. Epson, thanks again joining you. And we are moving to our next presentation. Our next speaker is Dr. Ravi Kannan, and this is the conversation of an oncologist who has given his life to caring the patients suffering from cancer. He shifted from Chennai to yes. Could you please stop sharing that so that yes. So there would be a conversation between Dr. Aparna Dave and Dr. Ravi Kannan. Both are there in the meeting room. Dr. Aparna Dave is a head of the Department of Oral Pathology in Faculty of Dental Sciences in SGT University, Gurgaon, India, and she would be interacting with Dr. Ravi Kannan, Padam Shri Dr. Ravi Kannan, and let's see how his he changed that the scenario of the statistics of this oral cancer or general whole cancer patients in northeast India, across Assam and all the northeast states. Over to you, Dr. Aparna.
Yes, thank you, Dr. Nurul. Sir is there so that I could start the discussion. Good morning, sir. So
Dr.
I would
Kannan,
like.
could you please unmute your microphone?
Yeah. Good morning. How are you?
Yeah, I'm
Sir,
doing
I'm
good.
absolutely fine. It's an honor to meet you, to talk to you, sir.
The privilege is mine.
Yes, sir. Sir, so today I'll just begin a session with an informal talk with you. Good morning, all. Today we have an eminent surgical oncologist, Dr. Ravi Kannan, with us. Welcome, sir. Let me take this opportunity to introduce him. Dr. Ravi Kannan, sir, is a surgical oncologist based in Assam. He is the director of Kasher Cancer Hospital and Research Center, Silchar, a non-profit hospital that provides free cancer treatment. Dr. Kannan hails from Chennai, where he earlier worked at the Cancer Institute, Adyar, before moving to Silchar in 2007. Sir has graduated from Kipluk Medical College in Chennai and holds a MS degree from Maulana Azad Medical College, New Delhi, and MCH Surgical Oncology from Cancer Institute, Chennai. He is credited with revolutionizing cancer treatment in Assam through people-centric and pro-poor health care. He is a recipient of Padma Shri, one of the Indian's highest civilian honors in 2020, Ramsay Magsaysay Award, the highest award in the Asia, Mahavir Award in Medicine in 2013. Under Sir's leadership, the Kachar Cancer Hospital and Research Center in Assam has become a full-fledged comprehensive cancer hospital. He has taken a lot of efforts to establish a center that provides cancer care to those who cannot afford the treatment. Sir, it has been a long journey. Can you share your journey from Chennai to Assam and what motivated you to pursue your current field of expertise over there, sir? Our viewers would like to know more about you, sir.
So whatever, uh, all my thoughts, all my philosophy of medicine is what I learned from my mentors, from my teachers. Uh, and the core philosophy of about cancer care came from the Cancer Institute, from Dr. Krishnamurti and Dr. Shanta. I think very rarely will we come across individuals of that mold. And the hospital in Silchar has a very interesting story. In the 1980s and 90s, there was no cancer hospital here. And the incidence of cancer is high because of several reasons. And lay citizens of the region, see, Assam has two river valleys. In the north of the Garo Khasi Jaintia Hills is the Brahmaputra Valley, a very large rift valley. And in the south is the Barak Valley, a much smaller valley. And and the distance between Guwahati and Silchar is 350 kilometers. But 350 kilometers in the northeast is 10, 12, 15 hours, as opposed to 4, 5 hours in the south or in other parts of the country. And and so people would find it very difficult to go and access cancer care in Guwahati or in Kolkata because cancer care takes a long time. It is expensive. Results are often uncertain. And most of the people here work for daily wages. And so it is not viable for them. And so they would defer treatment or they would not have treatment. So lay citizens of the valley, farmers, engineers, lawyers, businessmen, got together and formed a cancer society. And then they went about seeking support for a cancer hospital. And then they managed to put the cancer hospital, after which their then director, Dr. Chinmoy Chaudhary, went about visiting different cancer centers to see how a cancer hospital should be organized. Imagine how a group of committed people can bring about so much of change. It's really something that amazes me even when I think of it. So anyway, when I used to be working at the Cancer Institute in Chennai. I was there for a very long time. And in 2000, Dr. Chaudhary came and spent 6 months with us. And at the institute, we had a policy that everybody who needs care must have that care, irrespective of their paying capacity. And Chimada was very taken up by this. And so after he went back, he was in constant contact. He would keep calling the referring patients. And when I left the institute in 2006, he called for some patients, and one thing led to the other. And we found ourselves in Silchar.
Yes, sir. So finally, you have been in Assam for a pretty long time.
Yeah.
And sir, what are the challenges you faced while during this time? Was it a comfortable journey, or you had to really struggle to start up with the center? You were from South, and you had put up a center in East.
So
How was the
on a
response from the
on a
people?
personal level, I would say it was not difficult. Apart from the initial decision of moving, once we see India as a country, you go to any part of the country, nobody will ever ask you why are you here. We are Indians, and
Correct, sir.
that is the beauty of the country. So you live for 25 years in the US, and one day some president will send all of you back home.
Back home. True, exactly.
So in all these years, nobody ever asked us why we are here. Everywhere we've gone, we've been received with utmost kindness. The society has played a very crucial role in the growth of the organization. But then on a professional front, as far as patient care goes, the regular challenges that are there in other parts of the country, patients are unaware, patients present with advanced disease, there is malnourishment, they're afraid of going. They have several thoughts, about biopsies, about surgeries, about alternate medicine, about homeopathy, about and then in coupled with all of that, in the northeast there is also the problem of geography. There are areas which are difficult to travel, and then the weather. It rains so much several months in a year, and so as an that these are the problems. But I think these problems are there. Poor people are there across the country. Ignorant people are there across the country. If we have hills and forests and rain, there are areas where there are deserts and deserts and deserts. And so every part of the country, people have their own unique set of problems. It is how we deal with them that ultimately helps the country grow forward. And so we now when I think back, so we adopted pro-poor, we see whole lot of cost reduction strategies, but we learned very quickly just providing them no cost treatment, boarding, lodging is not going to make people. I actually thought, because at the institute, that's what we were doing. And we realized that after 3-4 years that not even 30% of patients were completing treatment. That's when we realized, they are daily wage earners. They have to travel. So we put in place measures to reduce cost of care. We put in place, we stopped multiple charges. We said everybody will pay the same rate. We resorted to generics. We resorted to fast forwarding diagnosis. All our pathology works on frozen sections. See, if you take the conventional paraffin section route, every biopsy will take 2-3 days, and processing major specimens will take several more days. Whereas if you use frozen sections, take a biopsy in the morning, by the time the patient reports to the clinic in the afternoon, the report is ready. And so our whole thing is to fast forward diagnosis and treatment. And then we started satellite centers, we started visiting patients nearer their home. And so we put in place measures to improve access to care. And then I think one of the most important things that we did was to constantly project a pro-poor image. We had to brand ourselves. Like ultimately, if you have a new toothpaste in the market, what do? They do a market survey and say this, and then they hype up the process. There's this toothpaste with salt. This toothpaste comes with this. They can come with all sorts of things. So like that's so everywhere, the way the hospital is presented, nothing clean, but nothing fancy. The way the staff talk, the way so poor people, one harsh word and they will withdraw and run away. They won't come back again. So every time we have to prove ourselves that we will walk the talk. And then using technology, we don't have an intensive care. We don't have intensivists for the intensive care. So we put in place high definition cameras. We teamed with a group of intensivists sitting in Bangalore. And we have what we call as a cloud ICU, 15-bed ICU, 24/7. A team of physicians, nurses watches over patients. And believe me, you have to see it in function to believe this. Cloud ICU save lives. Pathology, we don't have enough pathologists, so we've resorted to digital pathology. We scan images, work with a set of pathologists in Hyderabad who interpret slides for us. So like that, using technology, when we visit home visits, we use a video camera for conversation with patients. Home visit, the whole home visit program is nurse driven. And so over the years, we have done several things to try and ensure that compliance improves. So from the initial 30%, now about 70% of patients complete treatment. But what is more heartening is those who initiate treatment, most of them complete treatment. But we still have to work on about 20-30% who don't have treatment. It is a heartbreak for us.
Sir, that is a great thing. Actually, you have used technology in such a simplified manner, but at the same time, like you have made the facility available. I did see your pictures where you had sisters working and the cameras being placed. So I just went through the net and I had a look at it. But it's such an innovative idea, but that has helped to actually give treatment, provide treatment to the patients. So this you are using generic medicine to reduce the cost. This can be adapted by multiple big corporate hospitals also. A section of the patients can also be given this kind of a treatment. This is
So
one
we are,
area where you're catering the needs of the patients.
so we are
There could be
part of the National Cancer Grid. National Cancer Grid is a loose conglomeration of about 360 cancer centers, patient support groups, research units, and as a group, one of the activities, the aim of the National Cancer Grid is to make sure that there is uniform standards of care for cancer patients across the country. There are also other goals, but this is one of the most important goals. And as part of that, what we do is we group negotiate for drugs. So if I, as a hospital, negotiate for the cost of chemotherapeutic drugs or antibiotics, I may or may not get a certain amount of discount. But when 300 centers negotiate, the drug companies come on their.
That's a very good idea, sir.
There's strength in numbers, So, and
Alan.
the good thing is across the country there's a lot of camaraderie now. All the cancer centers, there was a time when we were all competitors. Now the spirit of collaboration is very strong, and as a nation we are trying to bring about this change.
That's Sir, in your opinion, what is the most important issue in healthcare that is often overlooked?
I think the most important aspect of healthcare that is overlooked is good quality communication.
Okay. I
See,
think that would resolve a lot of things. The more you communicate, probably you'll come out with many answers. You're absolutely right, sir. So what changes would you like to see in the healthcare system in the next 5-10 years in India?
I would like healthcare to become all inclusive. We as a community of doctors, we should ensure that nobody is denied appropriate healthcare for any reason. And also, as a community, I think we should focus on health promotion, on preventing diseases more than treating. It is important to treat diseases once they happen, but more importantly, I think we should all become proponents of promoting wellness, of promoting health. And then, of
So
course,
what-
we must, sorry.
No, sir, please.
And we must focus on providing good quality palliative care.
True, sir. So what do you want to tell the young professionals who are passing out? We have huge number which is coming out with more number of colleges and all.
Yeah, I think whatever reason they became doctors, I think they've chosen the best profession in the world. Next to a teacher, I think the doctor's position is near the top of the social pyramid. We, as doctors, can change the way people live. We can change the way community lives. So basically, as doctors, we are healthcare providers. As doctors, we are scientists. We look at numbers, compare data, see what treatment is better, as doctors, we are teachers. We teach our residents, we teach our communities. But I think the most important role of a doctor is that of a change maker. We can change the way we treat sickness and sick people.
True, sir. So you have been treated a huge number of patients, and there might be so many that everybody must be a unique. Do you recollect any case or anything which had a great impact on you, or something which probably we all should also know? Probably it will give us some kind of
See,
will change our outlook.
the the the patients that we treat and they get cured and go back are good, but where we learn most is from our failures. The failures may be because our treatment did not go the way it should have gone. That is a medical failure. But the bigger failures are where we have made judgment errors. Judgment errors can also be medical, but even more important are the errors that we make with regard to the non-medical, the social parts of it. We picked last about 3-4 months ago, we ran a short survey among head and neck patients that we have treated. And out of 100 patients that we treated, nearly 80 patients have not gone back to productive work. And that is something that is bothering us enormously. See, when we treat somebody and we cure them, they must be cured of the illness, but they must also be going back to active work. They must become productive. And if they've lost their most of them are daily wage earners and they've lost their livelihoods. By curing somebody, we've actually created one more mouth for the family to feed. And that is it's a major concern. Our current realization, our greatest errors in judgment are when we forget to assess the needs the patient has. Apart from, and we just look at healthcare as a disease, and we don't look at what are the other needs the family has, whether they need logistic support, whether they need monetary support, whether they need psychosocial support, whether they need support for livelihoods, whether their kids are dropping out of school. Some of those, often when an adult falls sick, the first casualty is the education of the child because many of them are daily wage earners. And so when these things happen, they leave a very big impact on your mind.
True, sir. Sir, but there is a need, what I feel is there has to be a system where these people, when they go back, they have some sort of employment. Somewhere they can be incorporated. Physically, they might not be that fit, but yes, if somewhere we have a system where they can get some kind of a work to do, probably they can get back because financial burden is a big burden in case of cancer treatment.
Right.
And we don't have that support system for patients actually and patients' family members.
What I think we need to, as doctors, we need to realize is providing health care, we should not think of ourselves as the only people who provide health care. In healthcare today, we have to involve several people in several other disciplines, people who are engineers, people who are uh, in the social sector, people, economists, every specialty that is around us can contribute to the way we take care of sick people. And if we look at health, if we look at sick people, care of sick people as a community activity. Community meaning I don't mean the society. I mean everybody in society, every profession in society, we will probably end up doing much better by our people.
Okay. So you have been working for a long time, and definitely feel you might be working for a very long time in your work in the hospital, giving a lot of time. How do you maintain a work-life balance, your family and your profession? Which every third person is going to ask you, sir, that how do you manage that, and your family must be very supportive. Ma'am is, I think, also involved in with the work with you.
So work-life balance as a terminology is a recent thing. See, when we were residents, we never spoke of work-life balance. For us, our work is our life. But younger people very often talk of this, and I'm not ridiculing them. I think it is important. What they feel is important for us to address. Just because we work a lot doesn't mean everybody does the same thing. If they want time to do other things, they should have time to do other things. And this is something all of us have to have to figure out for our own selves. We have to, and as an institution, if you are administering institutions, as an institution, you have to, make sure that your people have, when they work, but when they are off work, they have fun, they are able to spend time with their families, they are able to have a life outside of the hospital. I think it is important to preserve that to reduce burnouts.
So one thing I had to ask you, like, why did you choose Assam? Because is it something like we have more number of cancer cases over there and less in the rest of the part of world, or is it something to do? I'm just inquiring, like, whether
At,
the condition, the social status has made some kind of a difference.
no, when I left the institute in 2006, at that point of time, if somebody from Bihar had called me or somebody from, I would have probably gone there. It is just that the society in Silchar called me, invited me, and I joined them.
Okay. No, I mean to say, do we have more number of cases in that belt, or
Yeah.
is it somewhat almost parallel, like similar kind in Andhra or maybe in Gujarat, the same number of cases are being reported?
The incidence of cancer in the Northeast is much higher than other parts of the country.
Okay, sir.
The good thing is the population of the Northeast is much smaller than the rest of the country. And so in terms of absolute numbers, the numbers are not what it would be if the population was as large. So the whole of the Northeast sees about 50,000, 40 to 50,000 new cancers every year. Whereas the rest of the country sees about 13, 14 lakh new cancers.
Okay, sir.
But the
So,
incidence, different areas in Mizoram, incidence of cancer, some cancers is as high as 250 per 100,000. So different in Kamrup district, incidence of esophagus. So different areas have a higher incidence of different cancers.
so
In
what
general,
are your...
sorry,
No,
please go
sir,
ahead.
please continue.
No. In general, the numbers, the incidence per 100,000 numbers are much higher.
Much. So what do you plan? Anything more? Like you have already opened up such a huge setup. What are your future?
No. Our current focus as a team, we are looking at decentralizing cancer care and democratizing access to care by opening cancer facilities in the districts around us. We're trying to use a mix of hospitals, daycare centers, and home care centers. The second thing we are trying to do is we are trying to see how we can create a link between healthcare, providing livelihoods, and ensuring education of children. This is something we're very much bothered about. And the third thing is we're looking at affecting, how do we hand over leadership of the organization? How do we transfer values to newer people? How do we propagate the current philosophy of the organization to the next generation of people who will lead the organization? And these are three areas that we are agonizing about.
And sir, what about insurance sector? Like, they have some kind of an access to it, or because they are actually daily wage? Because definitely they might come under Ayushman Bharat or some other scheme, but not under other scheme.
Yeah.
Can something be done in this?
So Ayushman Bharat is a very good step in the direction of providing inclusive healthcare. In our own hospital, about 60-70% of patient support comes from Ayushman Bharat. But there are also other agency avenues for support, both with the government and also from civil society, from a lot of non-government organizations like Indian Cancer Society, Mahesh Modi. There are several organizations that support us. Insurance in our patient population is a very, very, very small proportion.
I know, sir. It's difficult actually. Even a person who is probably in a city has difficulty managing with insurance. It's
See,
not
the problem with insurance is they have to pay monthly premiums or annual premiums, and when they are sick, especially with something like cancer, which the treatment which lasts several months, that is the time when they will not be able to pay their premiums.
and
And
that might
yeah,
affect.
yeah,
So there has to be some, these people should make some modification in the rules regulation somewhere, which probably the insurance industry might not like it, but
I don't understand all of this too much, so I won't venture into giving an
no.
advice.
No, but
This is
what I meant is from a patient point of view, he needs
uh,
money at that point of time.
right.
So he should have an easy access to the flow
Yeah.
of, that is what I feel.
Yes, yes, yes.
Yeah, Dr. Kannan, one means a question that in India, the doctors are skewed, their presence is more in urban areas, and the multi-specialty hospitals and all are, the tertiary care centers are in, metros and bigger cities and all. And that our country lives in villages and all, they are in rural areas. So what should the government as well as the players who are into the healthcare sector, they can reach out to, I'm not talking oncology per se, the general healthcare, that you are the leaders in healthcare sector, what government should do, because the doctors who are spending a lot of time in their getting their degrees and all, and they are spending a lot of money and time into it, so they want to get benefit out of it, and with the living standards and all, they are not much keen to work in deeper areas. So what we should do so that we can reach out to the underprivileged patients who are living in rural areas of India?
Right. Two things, two observations I have. One is, I think healthcare and education are two sectors where the government must have the upper hand. Unfortunately, a lot of healthcare in India is by the private sector. I think that, see, when I was a student, everybody used to come to the government medical college. When I was an MBBS student also, private healthcare was very minimal. And it would have been good if the public sector could have expanded its reach in the community. And I think it is still not too late to reverse that trend. I think the dominant force for both healthcare and education should be the public sector. The second thing is, I understand everybody wants a good living. I understand they want decent earnings. But it is a myth to say that there is poverty at the bottom of the socioeconomic pyramid. The amount of effort that one needs to put in, the kind of effort one needs to put in for people at the bottom of the pyramid is very different and in some ways more intense. But even at the bottom of the pyramid, there is enough money for people to earn a decent subsistence. So I think people who are inclined to work in rural communities need not fear poverty. They will never be poor or unhappy.
Yes, yes, yeah. You are in you are at airport, I think.
Yes, yes, yes. I'm
Is
in
it
I'm in transit.
okay? So we are, utilizing your time, and we are not leaving you. Yes. So I think have your flight announcement is being done.
Yeah, in 10-15 minutes I will have to board.
Okay. Okay, so you can leave, sir, because you are in a rush and all, and we have catch you on your airport as well.
Thank you.
Yes.
Thank you, Dr. Aparna.
Sir, it has been a privilege to hear from you. Thank you for taking out time for us. And we appreciate the wisdom which you have shared with us. Thank you, sir. It has been an honor to speak to you, sir. It's my one of the
thank,
best
thank,
day, I think.
thank you very much. Thank you, Dr. Lul.
Thanks, Dr. Ravi. Yeah.
Thank you,
Bye.
sir.
Yeah. Okay. Okay. Yeah. Safe journey, sir.
Thank you.
Happy journey.
Thank
Yeah.
you.
Okay. Okay. Thank you.
So next is Dr. Punita Vora ma'am, Head and Professor of Department of Oral Medicine and Radiology, SDT University, Gurugram, India. She did her BDS from Himachal Dental College, Himachal Pradesh, and post-graduation from Swandeep Vidyapeeth Deemed University, Gujarat. She is a senior consultant in Fortis Hospital, Gurgaon, and is a director of Go Dental Multispeciality Health and Aesthetic Clinics. With a total experience of 15 years, she was awarded Sarojini Naidu Award for Working Women in 2023. She was also awarded with A.K. Bovar Award for Best Review Article in 2019 titled HIV Negative AIDS, Idiopathic CD4 Lymphocytes in Journal of Indian Academy of Oral Medicine and Radiology. She has also won Best Faculty Paper in New York, and in 2022 October in PGI Chandigarh, she was invited as a guest speaker in international conference on revolution in healthcare with ICMR. She has also computed her implantology course from international teams, and apart from all of this, she has also some national and international publications also cited credit to her. With this, I would like to call Dr. Punita Vora ma'am to give her insights in role of antioxidants in cancer prevention.
Thank you so much, Dr. Yashna. Am I audible? Thank you so much, Dr. Yashna. Just a second, actually. Am I clearly audible to everyone? Okay.
You are audible.
Okay. Thank you, Dr. Noorul Anwar, for keeping your faith in me, because not only a speaker, you have given me a very great opportunity to be a collaborator for your Cancer Congress. I'm thankful to you, and I'm sure so far it is going very well. We have such great speakers all over the world, and it has been a great session till now. So I'll start with my session today, and thank you once again.
It's all about you.
Thank you so much. Is my screen visible to everyone?
Not yet. We are just waiting for it.
Now?
No, not yet.
Okay. Just check screen visible. Hmm? Screen. अरे यार Just a second, I'm trying to share it. There is some.
No, you take time, Dr. Punita. It happens.
Yeah, it was happening with others
Yeah,
now.
not to worry at all. You just take time and try to share your slide.
Yes. तो शेयर पॉइंट है ना, ये रहा ऑप्शंस, ठीक है.
Yes, Professor Punita.
Sir, I've shifted it onto another desktop and
Okay,
then.
okay, yes, ठीक है. Okay.
हो गई ना, और इसको कुछ भी ये वाली.
Yes, it's visible. On the top, you would able to see the slideshow.
Okay.
Between record and animations, there is an option of slideshow. You can just click and you can.
I'm so sorry. This was happening with others, but today something went wrong with my desktop. So I hope I'm audible to everyone and you can see my slides now.
Yeah, you are audible and your slides are visible.
Thank you so much. Thank you so much for your patience, everybody. So I'll be taking my lecture on a very warm good morning to all of you. So the topic is role of antioxidants in cancer chemotherapy. So when I talk about this topic, we all have been listening to a lot of things regarding cancer, regarding radiotherapy, regarding chemotherapy. Now, antioxidants is something which is going to mop up all the free radicals which are present in our body and which are the main causative agents of so many diseases which happen to us on daily basis. Not only cancer, but as simple as fever, lack of immunity to fight various infections, and as big as cancer, which leads to death. So I belong to this university, SJT University, Gurgaon. I've been working here since last 10 years. It's a beautiful campus in Haryana, and I'm a part of this university. So starting straight away with my lecture. So let's all join hands. It is not going to be a single person cannot fight against this menace of cancer. These all are my patients who were diagnosed with cancer at different stages. You can see the first stage till the last stage, almost stage 4 cancer. So when the patient comes to you, the patient is so helpless. He is so much in confusion that now what next? They are scared of the treatment itself. The word chemotherapy and radiotherapy, these are the words actually which almost kills the patient. It is not the cancer, because cancer cells, we all know, they are the same cells which are there in our body. It is just a matter of fact is that it is just a cell cycle which has gone into haywire, and it is a uncontrolled growth of those normal cells which has taken place. So, to fight against cancer, every step will matter. And every small thing, a smallest thing as antioxidant, can also play a very crucial role in fighting against this menace. So, that is what I'm going to talk about. That antioxidants will not only do the chemo prevention, but they can also be a therapeutic agents in cancer treatment. And the best about part about antioxidants is that they are completely harmless. But yes, the overdose of anything can be harmful. So let's all join hands and fight against this cancer. The content of my lecture is basically the sources of antioxidants, where to get these antioxidants from basically exogenous antioxidants. We all know that there are certain endogenous antioxidants which are there in our body. The God has already provided us with powers to fight against the infections, and that is our immunity, and that is done also by antioxidants. The antioxidants, various enzymes are there which are endogenous antioxidants, but sometimes those are not enough. We need some exogenous sources as well. Then I'll be specifically talking about glutathione, lycopene, and the role of antioxidants in cancer chemo prevention, and also a bit insight of antioxidant overdose. Now, starting with simple statements where you should understand what are antioxidants and what are these free radicals, how these free radicals are going to act on our body. The antioxidants are basically free radical scavengers. They are the chemicals that interact with and neutralize the free radicals, thus preventing them from causing damage to the cells, to the normal cells. So they are mop up. They are basically going to mop up these free radicals and eradicate it from our bodies, because these free radicals are going to cause oxidative stress in our body, which is further going to cause diseases like cancer in our body. Now, what these free radicals do is that they are very unstable molecules. Anything which is unstable will always look for stability, be it a human, be it something as small as free radical or something which has been created from cell at cellular level also. Every molecule, every cell needs a stability. So whenever the molecule becomes unstable, I call it as free radical. Now this free radical, in search of stability, keeps on bombarding here and there in our body. When it finds a normal cells, it goes and fights with the normal cells, creates a stress on that cell, and further creates various kind of diseases. Now when this unstable molecule is combined with an antioxidant goes and it scavenges, it mops up that free radicals by combining itself with the free radical. So a combination of free radical and antioxidant works great. It decreases the load of diseases and cancer in our body. The reaction of free radical in our body occurs mainly because of the stress. The stress can be caused because of the environmental factors, because of the outside pollution, and sometimes we ourselves are become the enemy of our own body. We create so much stress, so much negativity in our mind, in our mental health, in our psychological aspects, and we create free radical through those stresses, through those hormonal changes and chemical changes in our body, which leads to formation of free radical. So a lot of things also depend on how we are combating with day to day in our life. Now, what this antioxidant is going to do is it will remove the free radicals efficiently and it will decrease the oxidative stress, which results in harm to the cells and the functions of the body. Free radicals, in my further slides, you will see the word as ROS, reactive oxygen species. So they are also known as ROS. Now, free radicals, when they are attacking the cells, when they are creating oxidative stress on our cells, they are damaging those cells either in a very initial stage. We all know we have a cell cycle in our body. Either they are damaging it at a very early stage, or when the apoptosis has to take place, they are not allowing the apoptosis to take place. There is a life cycle for each cell in our body. We have to understand that every cell has a life cycle. Now, if that life cycle, if that stage of life cycle is disturbed in our body, it is going to cause damage to the overall health of our body. Now, we should also understand here when we talk about reactive oxygen species or we talk about free radicals, there is something called as a cell cycle within a cell cycle which is taking place, which is happening because of ROS. This is known as redox control of cell cycle. So it's like there is a car on a highway, there is a driver, and there is a conductor. So, for example, the driver is your ROS, which is going to drive, which is going to take you to a destination. Now, this ROS has to be stable because this ROS is going to decide your cell survival. This is going to, now cell can be replaced by car. Cell survival, cell proliferation, cell growth, cell differentiation, also the apoptosis, when actually the cell death has to take. Everything is being decided by this ROS. This is something which is there in the cell, which is there in the body. Now, in case this ROS system, this redox control of the cell cycle is disturbed by the free radicals, this cell cycle which has to be taken place at the right time, when the right time of the cell death has to take place, it has to take place. If this all system is disturbed, then ultimately the diseases occur. A loss in the redox control of the cell cycle could lead to aberrant proliferation, a hallmark of various human pathologies. Now, this is the line which tells us that if the control of the cell cycle is disturbed, leading to further various tumorogenesis, cancerogenesis, all of these things, then ultimately we are going to have DNA damage, we are going to have mitochondrial dysfunction. Everything will happen at cellular level, but will be seen very evidently
through various symptoms, our body is going to signal it out, either in the form of an ulcer, either in the form of white striations, pre-malignant lesions. So all of these things, the body is giving signals, but it is actually happening at a cellular level, with an emphasis on how this control relates to the proliferative disorders, including cancer, wound healing, fibrosis, cardiovascular diseases, diabetes, and various neurodegenerative diseases. So the free radical oxidative stress, which is being created by the free radicals, damages our brain, causing Alzheimer's, Parkinsonisms. It damages our heart. It damages various systems, the complete body, starting from top of your head till the feet. All the systems which are involved for the functioning of your body are being affected. It is your brain, your heart, your kidneys, your skin, your joints, your immune system, your blood vessels, your lungs, your eyes. Everything goes into a degenerative state whenever there is an oxidative stress. So now these antioxidants, when I say all the systems get involved in the oxidative stress, which is being created by free radicals and which is affecting the ROS, the redox control of the cells in our body. These antioxidants are going to join hands with these free radicals. They will completely eradicate these free radicals, and they will have various effects on our body, such as anti-cancer effect. They will support the kidney function, maintain the dental health, improve the nervous and the immune system functions. They will also act as anti-obesity and anti-aging, and antimicrobial and anti-inflammatory. They will maintain the vision and sleeping. Also, they will give protection to your liver. So they will decrease the oxidative stress of your body. The exogenous sources of free radical, other than I said that there can be endogenous sources of free radical in your body is producing it on your own, because there is no pollution in people living in a very in an atmosphere where there is no pollution. Still you find cases of cancer, still you see free radicals in their body. How are they being generated? Then that is being caused because of the stress, because of the problems which they are creating for themselves by having a poor mental or psychological health. Now, the exogenous sources, which are your smoking, the deleterious habits, the alcohol, the water pollution, the forest fires, the air pollution, the UV and the microwaves, then X-rays and the gamma rays. Now, these are the outside factors which are creating these free radicals in our body. Now, the sources of antioxidants. Then we know that these are the sources, these are the exogenous sources of formation of free radical. We know what are the endogenous sources of free radical. Now, we should also know, then I told you that only the antioxidants, which is going to be the conductor of that car, which was being driven by a driver who basically lost control, who didn't know how to drive. There was some problem with the driver because of the free radicals. And now, if the driver is not driving properly, the accident is going to happen. Similarly, that compounder, which is the antioxidant, is now going to take control, will make the driver sit on his seat and will take the car further ahead to prevent any kind of accident. The accident for me here is cancer. Now, the various sources, all the colored foods which you see in the environment, everything which is colored has antioxidants in it. Now, tea in the form of polyphenols, the green tea, the black tea, the red tea, they all have antioxidants. The olive leaf, the grape seeds, the apples, these are the fruit extracts which are very rich in antioxidants. Then there are some oils like palm oil, argan oil, geranium, and pomegranate seeds. They are full of antioxidants. We'll be talking about vitamin A, E, and C. 3 vitamins which are potent antioxidants, which can be consumed either through food or can be taken as multivitamins on daily basis to combat this effect of formation of free radicals in our body. So antioxidants, when they are in food, they block the lipid peroxidation. This lipid peroxidation also leads to formation of, so whosoever is obese or whosoever is taking lot of fatty food, they also have lot more formation of free radicals in our body. So because the metabolism of your body is haywire. Whenever the metabolism is not proper, there will be formation of free radical. In food, these antioxidants, they also, if you're taking some food which has antioxidant, they block the lipid peroxidation. They keep the freshness of that fruit or that agent. In biomedical field, now when we talk about antioxidant per se in cases of cancer, they serve as antioxidant, first of all, removal of free radical. Now, there is a word being used here. They also act as pro-oxidants. Now, what is this pro-oxidant? Now, pro-oxidant are basically, they are again a complete opposite of antioxidants. When the antioxidants start behaving in a completely different manner, specifically in cases of cancer. Now, what happens in cancer? There is uncontrolled growth of the cells. Now, to prevent this uncontrolled growth, if the antioxidant starts working as only antioxidant, it will not be able to promote it will not be able to stop that uncontrolled growth. So, the antioxidant behavior converts itself into pro-oxidant. Now, what it does is it will create an oxidative stress. It will create an environment where that it will identify that tumor or cancer cell, and it will create an environment where they will increase the oxidative stress to those tumor cells for the chemo prevention. It will produce more amount of ROS. It will activate the NRF2 cellular defense system and produce oxidative stress and toxicity towards those cancer cells. So antioxidant here will act as a double-edged sword. If you want to prevent cancer, you can take antioxidant. Once the cancer has occurred, now these antioxidants act on your body. It is not going to help the cancer cells. It is not going to remove the free radical from the cancer cells. Rather, it will create the free radical in those cancer cells and will lead to apoptosis. It will lead to cell death of those cancer cells. So this is what an antioxidant is doing in cases of cancer patients. Now, a brief classification of antioxidants, as I've been telling you, that they can be endogenous, they can be exogenous. Endogenous within your body, enzymatic and non-enzymatic, and exogenous outside the body sources, which can be taken in the form of vitamins and carotenoids and polyphenols. So this is the antioxidant, just a picture which is representing the healthy cell membrane, because they are acting at a cellular level and they are neutralizing the free radicals, and the human cell is happy after the damaging radical has been removed. Now the various exogenous antioxidants, because endogenous is something which is there in the body. So we'll discuss the exogenous antioxidants briefly. Vitamin C is there, which is also known as ascorbic acid, which is present in your all the fruits which have a little bell peppers, strawberries, kiwis, broccolis. So vitamin C is present in these things, and vitamin E is present in something which is because it is a fat soluble vitamin. It is present in the fatty components of the food, vegetable oil, nuts, all the nuts, almonds and nuts. Then carotenoids, which are present in the orange and red vegetables and fruits. Polyphenols, which are flavonols, anthocyanins, isoflavonols, and phenolinic acid. These are also present in fruits, vegetables, wine, tea, coffee, and also your chocolates. Then trace elements such as selenium and zinc, which are also well studied these days, present in seafood, meat, and whole grains. So a complete list of all the exogenous antioxidants is here. Other than this, we are going to discuss lycopene and glutathione, which are also exogenous antioxidants. Now, vitamin E, as I told you, they are fat soluble vitamins. Now, what exactly these vitamins are doing, how they are acting as antioxidants, they have some typical structure. They have a OH group of tocol is responsible for antioxidant property of vitamin E. The structure of vitamin E is such that whenever it finds a free radical in your body, this OH group of that vitamin E goes and attach with that free radical, and it will get oxidized to quinone and protects against the polyunsaturated fatty acids from peroxidation reaction. Peroxidation reaction further leads to formation of free radicals. So it is basically blocking that chain reaction of one free radical converting to another free radical and further causing multiple damages in your organs or cellular system. It helps to avoid the cell membrane damage through its antioxidant action. It stimulates your immune response, inhibits the conversion of nitrites in smoked, pickled, and cured foods to nitrosamines in the stomach. So it has a lot of role in stomach. And nitrosamines are the strong tumor promoters. So it is inhibiting the conversion of these nitrites into nitrosamines. So this is the structure and this is the chain reaction which is taking place, and it is inhibiting the inflammation process is not being occurring because of the eradication of the free radicals. Now carotenes, these are vitamin A. Again, they are fat soluble vitamins. They are precursors of vitamin A. They are basically the precursors. The most common forms are alpha carotene, beta carotene, lycopene, canthaxanthin, and zeaxanthin. Beta carotene is most widely studied. It is composed of two molecules of vitamin A which are joined together, retinol. Then dietary beta carotene is converted to retinol at the level of intestinal mucosa. Ultimately, if you are taking dietary beta carotene, it is also converting into retinol. Carotenoids have been reported to have a number of biological actions. They will do the immune enhancement, inhibition of mutagenesis, and transformation and regression of pre-malignant lesions. There are so many pre-malignant lesions which come down to our clinics, such as leukoplakia, oral submucous fibrosis. In all these patients, a specific dose of vitamin A, if it is given, or lycopene, if it is given, it is supposed to decrease the activity of free radicals and the conversion of these pre-malignant lesions into frank malignancy. So this can be a life-saving thing, especially in cases of pre-malignant disorders. Now we come to vitamin C. This is a water-soluble vitamin which is present in all your citrus fruits, potatoes, tomatoes, and green leafy vegetables. This also scavenges the free radicals and reactive oxygen molecules which are produced during the metabolic pathways of detoxification, and prevents the formation of carcinogens from precursor compounds. More potent in inhibiting the oxidation of LDLs in your body. They are also supposed to be very good anti-aging agents. So this is briefly that vitamin A, C, and E. So we know three vitamins which are very good source of antioxidant in our body, which can be taken from outside sources. Now talking about glutathione, which is supposed to be a fat these days, which is being taken by a lot of people on regular basis, is actually a great agent which is synthesized intercellularly from cysteine. So this is basically it is endogenous. It is already there in your body, which is being formed from cysteine, glycine, and glutamate. But sometimes the GSH levels in your body are not so much because your liver is not so healthy. So even the outside sources are available these days. In addition to its role as a substrate in GSH redox cycle, the glutathione is also a scavenger of hydroxyl radicals and singlet oxygen. So not only it is a free radical scavengers, even the hydroxyl radicals, which can further convert into peroxide in our body, and the singlet oxygen, which also has a fate of converting into peroxide and finally damaging your cells. So this glutathione will go and neutralize these agents. The majority of glutathione is being synthesized in liver, and approximately 40% is secreted in the bile. The biological role of glutathione in bile is believed to be defense against dietary xenobiotics, which are carcinogenic agents, and protection of the intestinal epithelium from oxygen radical attack. So how glutathione works in the body, it helps in breaking down the nutrients to carbohydrates, proteins, and fats. So it actively participates in your metabolism. It will increase your metabolism, regulates your immune response towards various diseases. It protects you against the oxidative stress which is being caused by free radicals. Now, in cases of increasing and recovering from glutathione level improves the marker of liver health in patients with liver diseases. All patients of liver carcinoma, from there it is a agent which is protective towards your liver. So even the liver cancer patients till date, along with the chemotherapy agents, are being given glutathione in IV form. So one special thing about glutathione is that the absorption of glutathione is maximum if it is given in the fluid form rather than being taken through, because the intestine, they are not able to absorb the glutathione particle if it is taken orally. So normally it should be administered in the IV form. It supports the health, growth, and repair of every cell of your body. It also improves the insulin sensitivity. Higher levels of glutathione appear to be important for insulin sensitivity, and it will break the insulin resistance in your body. It reduces the oxidative stress levels, which is the main function in patients of cancer. It reduces the inflammation and risk of any chronic diseases. It has an anti-inflammatory, it decreases the inflammation of your body, because this inflammation is also being caused by your free radicals. Now, talking about lycopene, this is a bright red carotenoid hydrocarbon found in tomatoes. It is basically a lot of lycopene is there in tomatoes. So if a cancer patient, especially in onco units, they in dietary basis they are specifically told to take a lot of tomatoes in their diet, and other red fruits and vegetables such as red carrots, watermelons, grapefruits, and papayas. It is not present in strawberries or cherries. It is a myth that it is that their vitamin A is present, but not a pure form of lycopene. Lycopene per se is mainly associated with tomatoes. It has no vitamin A activity. So these are the sources of lycopene, which we all must know, and we must tell our patients. Watermelon is a good source. If in case the patient wants to know more about what are the sources, your passion flower fruit, carrots, and tomatoes are basically, these are rich in lycopene. Lycopene has been efficient in ameliorating cancer insurgence, diabetes mellitus, cardiac complication, oxidative stress mediated malfunctions, inflammatory events, skin and bone diseases, hepatic, neural, and reproductive disorders. So it has multifunctions, and it leads to your function of normal artery also, and the vessel protection also. Now, a few more which are left are coenzyme Q10 is also known as ubiquinone. It is found almost in every living cell. It is essential to energy production by mitochondria. When we breathe, we think only our lungs are the system of absorbing the oxygen from outside, but there is something also known as cellular respiration, and the main organelle which is involved with cellular respiration, formation of free radical, decreasing the oxidative stress, lipid peroxidation, oxidative phosphorylation. This goes back to everything which is involved with TCC, glycolysis, glyconeogenesis. All this is happening at the cellular level, and this is known as cellular respiration, in which the main function is being done by the mitochondria. Far beyond producing energy, coenzyme Q10 can protect the body from destructive free radicals, and it enhances the immune systems. Albumin is a protein which is present in a lot of food. This also scavenges the free radicals, and thus can be considered as one of the primary extracellular defense system. Plasma proteins, namely ceruloplasmin and transferrin, they also have shown in antioxidant activities. Now, some drugs, some pharmaceutical agents which have been found by the experts, such as xanthine oxidase, allopurinol, folic acid, then NADPH inhibitors. These all act in the mitochondria, and they will help in the proper cellular respiration. Adenosines, calcium channel blockers, albumins, then inhibitors of iron redox cycling, defruxamine, aptotransferrin, and ceruloplasmin. Statins, even the anti-cholesterol drugs, which are given prophylactically in patients who have high LDL levels, they also act like antioxidants, and they prevent the further complication of any disease. Now, role of antioxidants specifically in cancer, very shortly I'll explain you. In cardiovascular diseases, it will prevent the arterial fibrillation, heart failure, and valvular degeneration. Then in Parkinsonism disease, if somebody has a Parkinsonism, then antioxidants will increase the dopamine metabolism, and this will decrease the oxidative stress in the neural system of your body, and it will help in early recovering of those patients. Then a primary mechanism of many chemotherapy drugs. Now, this is when till now the slides showed that in none of the slides I have told you that the patient was on chemotherapy or radiotherapy. Now, once the patient is on chemotherapy and radiotherapy, now how these antioxidants will act, that I'm going to tell you. The primary mechanism of many chemotherapy drugs against the cancer cells is the formation of free radicals. Now, why these free radicals are being formed by the chemotherapy drugs? Uh, cause apoptosis, basically prevent the further cell division and further growth of that thing in your of that cancer in our body. The radiotherapy is based on the fact that ionizing radiation destroys the tumor cells. Radiotherapy induces direct lesions in the DNA or biological molecule, which eventually affect the DNA. Free radicals produced by oncology therapy are often a source of serious side effects as well. So, now in this slide, we will understand that when there is a normal cell, there is normal metabolism which is taking place, there is decreased lipid oxidation, there is increased antioxidant enzymes, there are decreased copper and iron levels, normal mitochondrial function, which I told you because the mitochondria is going to help in the cellular respiration. So there is a balance between the ROS scavenging, which is your reactive oxygen species scavenging, and production. This balance in the normal cells prevents the diseases in the body, prevents the formation of further spread of cancer cells in our body. But in case this whole thing is disturbed, then what happens? The rapid metabolism takes place, increased lipid oxidation is taking place, the antioxidant enzymes in the body are decreasing, there is increase in level of copper and iron, and the mitochondrial dysfunction takes place. And hence there is formation of cancer cells. So body is in oxidative stress. Now, what these antioxidants are going to do in normal cells, there is chemo prevention of the malignant cell transformation. But as I told you in earlier slides also, in cases of cancer cells, the antioxidants are going to act as now pro-oxidants. Now, they are going to create oxidative stress to the cancer cells. They will increase the ROS in the cancer cells and will act as chemotherapy of transformed malignant cells. Now, excess of everything is bad. If there is a head, there is a tail. Antioxidants may have a lot of benefits in both health and diseases, but that doesn't mean that specifically people who suffer from health anxieties, who suffer from cancerophobias, they take blindly lots and lots of antioxidants. And over the counter drugs are available, so they don't know what dose has to be taken, they don't know from which route it has to be taken. And ultimately, antioxidants should not be consumed in excess, as numerous studies have shown that they boost the metastasis mechanism in our body. So it has to be taken under proper, it's not that somebody is advertising it on a TV or social media and you start taking that antioxidants just by listening to those people. You should meet your oncologist, you should meet your oral physician, and then only you should take a proper dose of it. We are giving lycopene in cases of leukoplakia, so there is a dose that we can't exceed that dose in the patients and cause them harm. Then there is a link of antioxidants overdose to cancer. Then there have been studies that increase in dose led to lung cancer, it led to prostate cancer, it led to melanoma, which is mainly a skin cancer. So there was a National Institute of Health that they had warned the high dose of antioxidant supplements, it can be harmful. The high dose of vitamin E was related to prostate cancer. Then the antioxidant supplements was linked to greatest risk of tumor growth. So lung cancer in smokers if the dose of beta carotene was very high. And there was again documentation that there was formation of antioxidant which will boost the metastasis mechanism in the body. Vitamin E, we hope those findings help to dispel the myth that vitamin E, it helps to prevent every type of cancer, but in cases of lung cancer, it helped in metastasis of the disease. So the thing is that we have to take it in proper dose. Now, also in cases of melanomas, antioxidant that they can promote the cancer progression, and at least in melanoma by promoting metastasis. So it can promote the metastasis and it can further spread the disease from skin. It can go to various other organs. Also, in cases of prostate cancer, the dietary antioxidants have been reported. There is a review which has been published. So, hence, I conclude that we must pay attention to our health. Our health is our real wealth. The use of antioxidants in your daily diet decreases the stress levels which are being produced by your own self and also through the environment. And you should enjoy life and be happy, because even one smile a day or a feeling of happiness, it will align all your cells and it will itself decrease the free radical formation in your body. So, have a great day. And thank you all for hearing me patiently. And this is our team of oral medicine and radiology. We all work hand in hand to diagnose the patients of cancer who are coming to us from even the peripheries. We have National Cancer Institute by AIMS. We have a lot of patients who are coming who are already diagnosed, taking chemotherapy, radiotherapy. Then many pre-malignant lesions, they report to our clinic. We have a red and white lesion clinic along with Department of Oral Pathology. Then we also have a good oncosurgeon team here who are dealing daily basis for the oral cancer patients. So whatever best we are trying to do. So thank you one and all. If you have any questions, you can ask me.
Is it a mandatory option to have a nutritionist consultation prior to any cancer therapy? And are there
Yeah.
any protocols for that? If so, kindly let me know the links for that.
Yeah, it is. I think it is mandatory to take a call on what kind of nutrition your patient is taking. There is no protocol as such, but obviously, the diet of a patient who is suffering from cancer cannot be same, because he will not be able to digest everything and take all, because the body is not going to absorb all the nutrients which you are prescribing to the patient. So it is definitely very, very important. You must include a very good nutritionist, and specifically who has been, who has done some specialization in the patients of cancer and prophylactic cancer therapy, so that you can help your patient to your best, because diet will definitely play a very major role. And antioxidants you can prescribe by, especially in cases of pre-malignant lesions, by following specific protocol of how much mg of lycopene you should give for, because doses are different. For OSMF, we give different dose. For leukoplakia, the dose is different. For erosive lichen planus, the dose is different. So you should refer to what doses have to be given, and accordingly you should manage your patients. So I think I'm done with my lecture. So the next speaker of our day.
Dr. Anand Ramanathan is the next speaker, Dr.
Sir, has he already joined?
Yeah, he is there.
Okay. Sir, just give me a second. Dia, are you there?
Yes, ma'am, I'm there.
Yeah, Dia. You please introduce the next speaker of our day,
Yes,
and
ma'am.
go ahead with the sessions.
Okay. So the next speaker for the day is Dr. Anand Ramanathan. Saurabh graduated with the Bachelor of Dental Surgery from Savitha Dental College and Hospital under the Tamil Nadu Dr. MGR Medical University, Chennai in 2002, and his Master of Dental Surgery, specializing in oral and maxillofacial pathology at RMDC, Annamalai University, Chidambaram in 2009. So then migrated to Malaysia, where he did his spouse program at the Faculty of Dentistry, University of Malaya, to obtain his practicing license in Malaysia. And from 2009 to 2011, during his spouse program, he was actually involved in the research of. Okay, I'm sorry. There is a. Am I audible?
Yeah, you are audible, Dr. Dia.
Okay. So, Sir's passion for teaching and research led him to join the Faculty of Dentistry here at University Malaya, and he has since become a valuable senior lecturer and clinical specialist in the Department of Oral and Maxillofacial Clinical Sciences. He has been the module head of various integrated modules, such as oral malignancy and potentially malignant disorders, tumors and tumor-like lesions of the jaws, and undergraduate discipline coordinator for oral medicine and oral pathology. He has been a member of curriculum review for undergraduate and postgraduate programs in oral pathology and oral medicine at the Faculty of Dentistry, University of Malaya. He is also a trainer of the Oral Detect, which is a training and calibration program for early detection of oral cancer and oral potentially malignant disorders. So, has successfully conducted Oral Detect programs in Malaysia, Indonesia, Cambodia, Nepal, and India, training undergraduate students, general dentists, postgraduate students, and various specialists in dentistry. He is also an adjunct faculty member in Faculty of Dentistry, University of Bodhisattva, Cambodia, Tagore Dental College and Hospital, Sri Ramachandra University Dental College and Hospital, and Sri Balaji Dental College and Hospital, Chennai, India. He is an ardent researcher. He has 77 papers in indexed international peer-reviewed journals with an H index of 17. He has 9 book chapters to his credit. He is also involved in numerous research projects and has supervised PhD, master's, and graduate research students for the past 10 years. Sir has been awarded the Outstanding Researcher in Oral and Maxillofacial Pathology at the 3rd Venus International Healthcare Awards 2020 by the Venus International Foundation. He has also received the Certificate of Excellent Service by University of Malaya in 2021. He is currently an active member of OCRCC, Malaysian Association of Oral Facial Diseases, and Asian Society of Oral and Maxillofacial Pathology. His research interests are oral cancer, oral potentially malignant disorders, oral pathology, oral medicine, immunohistochemistry, adjuvant diagnostic tools, natural products, and drug toxicity, oncoimmunology, homeobox genes, and odontogen lesions. So today's lecture, sir, for the topic prognostic significance of blood and tissue inflammatory markers in oral cancer. We welcome you, sir.
Thank you, Dr. Dia, for that kind introduction. Can you hear me?
Yes, Dr.
Yes, sir.
Anand,
Sir, you are audible now.
Okay, thank you very much. It was a few years ago when we had the multidisciplinary team meeting with the oral surgeons, oncologists, and the ENT surgeons. We usually present the oral pathology side of the patient, the surgical specimen, and I was listing out all the histopathological features which we had seen in one of these patients. And once I finished my talk, after the MDT, one of the surgeons pulled me aside and asked me, Anand, it's fantastic. You have given me a lot of histopathological features present in this patient. But what is in it for me? So what is the take-home message for me? So that actually put me to think. So how can I help the surgeons as such? How can we actually create a crystal ball and put in informations and such that that crystal ball will help the surgeons to actually see whether the patient is going for a good prognosis or bad prognosis. So this whole study was in search of that crystal ball. So I would like to thank the organizers and especially Prof. Ruan from University of Padnaya, as well as Dr. Anwar for inviting me to give this talk on prognostic significance of blood and tissue inflammatory markers in oral squamous cell carcinoma, and Dr. Anand Ramanathan from Department of Oral and Maxillofacial Clinical Sciences, Faculty of Dentistry, University Malaya. We all know the burden of oral cancer as such in the world, and it is quite high. And in India, it is quite high, whereas in Malaysia, it's not that very common. And we all know the risk factors for the oral cancer, and it is more common in men. And the treatment which is present for the oral cancer surgery, radiotherapy, or a CCRT as such. At present, we have the best prognostic indicator is the 8th edition AJCC TNM staging. We can actually divide the prognostic factors into three: the patient-related factors, the tumor-related factors, where you have the TNM, and a lot of histopathological factors as such. So there are a lot of risk models already available in the literature, and these are all the risk models which is available right from 1920, and the latest one is in 2014, apart from the TNM staging as such. And we know that cancer-mediated inflammation is considered as a 7th hallmark of cancer. It acts both ways in avoiding immune destruction as well as tumor-promoting inflammation. So these inflammations can be pro-tumor or anti-tumor as such. And there are many studies which have looked into the host immune cells in the tumor microenvironment. With varying results, the ones in the greens are actually destroying the tumor. They have the anti-tumor effects. Ones in the red have a pro-tumor effect as such. So we were looking for the crystal ball, and then we conceived this project where we have published it a few years ago, where we looked at the pre and post-treatment inflammatory markers in the blood for oral squamous cell carcinoma, and we came out with a stepwise modeling. These were the inflammatory markers which we actually looked into in this project. And when we put the model as such after the univariant and multivariant analysis, definitely the stage, we took into consideration the stage, which is actually the gold standard now. And the other factor which was significant in the univariant analysis was whether the patient had undergone surgery or not. And for pre-treatment, we had the lymphocyte monocyte ratio, which was significant. And post-treatment inflammatory markers, we had the platelet count as well as the platelet lymphocyte ratio, which was significant. So when we put these parameters into the model, and our Herald concordance came as the estimate of about 87.87%, we were able to predict the prognosis of the patient. So this was the estimate, and the conclusion for this is high pre-treatment levels of lymphocyte monocyte ratio and the inflammatory index, systemic inflammatory index, and high post-treatment levels of platelet count, platelet lymphocyte ratio are independent prognostic markers in oral squamous cell carcinomas. These findings provide further evidence on the potential of inflammatory markers as a prognostic indicator. And this would help in risk stratification and improved prognostication for patients with oral squamous cell carcinoma. So with this study done, we were looking at what other parameters do we have. And we definitely have the socio-demographic parameters for these patients, the clinical parameters, a very detailed histopathological parameters could be taken. And we combine these parameters with pre-treatment and post-treatment inflammatory markers and ratios as the previous study. And we added the tissue inflammatory markers in this study as such. So these are specific objectives. And we looked at the tissue inflammatory markers at the invasive front as well as the tumor center in the study. Yeah. And finally, we actually compared this novel risk model with the existing risk model to obtain the best risk model for oral squamous cell carcinoma patients, the overall survival for oral squamous cell carcinoma patients. This is the study methodology as such. And we obtained the ethics. We had patients from two centers, University of Purdue as well as University of Malaya. So we obtained the ethics from both the centers. And this is the study design. It's a retrospective study with convenient sampling. And we started with 713, but the final model came up to 118 after taking out those cases which did not have the data as such. So these are the inclusion criteria and the exclusion criteria for this study. And we obtained the socio-demographic clinical treatment and survival data from the patient's records in Malaysian Oral Cancer Database and Tissue Bank System, which is actually managed by Oral Cancer Research and Coordinating Center, as well as we've got the other data from the Center for Research in Oral Cancer at the Faculty of Dental Science, University of Purnea. And we also obtained the hematoxylin and eosin stains slides to do detailed histopathological evaluation for these cases. And we also obtained the pre-treatment and post-treatment inflammatory markers values for these patients as such. These are the socio-demographic data which we teased out. And these are the clinical data which we teased out. And for the histopathological data, we did a the grading of the tumor, degree of keratinization, extent of differentiation, Broders classification, extent of nuclear pleomorphism, the number of mitosis, and we graded the mitosis into grade 1 to 4. And we looked at the greatest, we measured the greatest dimension of the tumor in millimeters. With that, we were able to give the pathological tumor size based on 7th edition AJCC. And then we went on to look at the lymph nodes, whether there is a metastasis within the lymph nodes or not. And we were able to evaluate the pathological lymph node status according to 7th edition AJCC. And we also got the data for metastasis based on the 7th edition AJCC. And we came out with the staging for the 7th edition AJCC. Further, we actually evaluated and got the depth of invasion for each case. And based on that, we reclassified the pathological tumor size based on the 8th edition AJCC. And we also looked at whether the lymph node metastasis had extranodal extension or not. And we were able to get the pathological lymph node status based on the 8th edition AJCC. And of course, we already had the distant metastasis. With these, we actually got the staging of the 8th edition AJCC as such. We also looked at other parameters, histopathological parameters like pattern of invasion according to Anirudh et al., as well as modified pattern of invasion according to Bryan et al. And then we also looked at the pattern of invasion according to Royal College of Pathologists 1998 first edition and second edition 2005 and 2013. We also looked at the worst pattern of invasion for each case, which actually had the type 5 pattern of invasion where the satellite tumor is present 1 millimeter away from the main tumor. And we looked at the number of tumor buds at the invasive front. And we counted the number of tumor buds and we divided that into either low activity or high activity based on the number of tumor buds. We measured the perineural invasion, and we also took into the consideration whether the perineural invasion is at the invasive front or at the in the tumor center as such. And we also looked into intraneural invasion and measured them. And again, we classified whether the intraneural invasion is at the invasive front or at the tumor center as such. And we also looked at the lymphovascular invasion, and wherever we could, we did measure the lymphovascular invasion. And we took into the consideration the bone invasion, the type of bone invasion, whether it was erosive type or the infiltrative type. And we also noted the surgical margin status, whether they were clear, close, or involved. And we also did the scoring for the dysplasia at the margin. And we used the 3-tier system here. And we also graded the lymphocytic host response. The tumor infiltrative lymphocytes also were graded. And we also looked at the tumor-associated tissue eosinophils, whether they were present or not. And the stroma at the invasive front were also graded. And we also looked at whether there was muscle bundles at the invasive front, whether they were intact or they were degraded. Degradation of the muscle bundle, and we also looked at the sarcolemmal spread as such. We also took into the consideration whether there was invasion of the tumor into other structures, also as well as the salivary gland as such. We collected the treatment data, and we also collected the overall survival status for the patient in durations of months was calculated from the date of diagnosis to either the date of last visit or the date of death. These were the only, when you compare to the previous study, in this study, we only selected 4 pre-treatment inflammatory markers, that is the absolute neutrophil count, absolute lymphocyte count, and absolute monocyte count, and absolute eosinophil count. The reason why we did this was we wanted to look at these cells in the tissues too, as such. So these were the pre-inflammatory ratios, pre-treatment inflammatory ratios, which we calculated. And these are the post-treatment inflammatory markers, again, the 4 markers after the treatment we measured. And these are the ratios which we actually looked at for the post-treatment inflammatory markers. And then comes the tissue inflammatory markers. Here we actually used multiplex immunohistochemical staining procedure, where we used 6+1 marker. The markers were CD66B, CD15, CD3, CD20, CD68, then the cytokeratin, and DAPI for the nucleus. This is the protocol we use for the multiplex immunohistochemical staining. It is the same as the immunohistochemical staining for IHC. Only difference is instead of DAB, we actually use the TSA fluorophore incubation. And once that is done, we go back to the step of step 2, where we did the antibody stripping at 100 degrees Celsius for 20 minutes. So it actually strips off the first primary antibody. Then we follow these again till the steps of fluorophore, and then we go back to the second step for the third antibody, and such way we actually repeated the process for each marker up to 6 markers. And finally, we did DAPI counter staining and imaging. The imaging machine which we used was the Vector 3 pathology imaging machine. And we looked at the invasive front. At the invasive front, we marked certain 5 regions of interest, and 1 millimeter into the tumor, we took another 5 regions for the tumor center as such. So altogether, there were 10 regions of interest, which we actually took into the scoring of these cells. So if the cells express CD3 plus, we consider them as T cells, CD20 as B lymphocytes, CD68 as tumor-associated macrophages. Whereas when it comes to CD66B and CD15, there were 3 types of population. One population had both, which were positive, and that was the tumor-associated neutrophils, and it encompassed all the neutrophils. Whereas the activated neutrophils were those which had CD66B positive, but then they were negative for CD15. And CD66B negative and CD15 positive were either considered as tumor-associated tissue eosinophils or myeloid derived suppressor cells. It can be either of that. Okay, so this is the photomicrograph showing the DAPI. Then the CD3 cells are actually highlighted in magenta color, the CD68 cells in yellow color, the CD20 cells in light blue color, and the cytokeratin actually in orange color. So when it came to the double staining as such, you can see that CD66B cells are actually green in color, and CD15 positive cells were sort of red in color. When we combine these 2 photomicrographs, then we can actually see the yellow color expression. Those cells were actually positive for CD66B as well as CD15 cells. Okay. From this, the counting of these cells, we actually looked at the tissue inflammatory marker ratios at the invasive front and the tumor center. And these were all the ratios which we actually calculated. And it goes on quite a bit. And this slide actually shows you the DAPI stain, the CD3 cells staining, the CD20 cells, CD68. Then you have the double positive cells, CD66B and CD15 positive cells. And here only the green, which is CD66B positive cells, whereas here you have the CD15 positive cells, which are red, and this cytokeratin tumor cells, which took cytokeratin, and this is the composite image. To give you a better perspective of the composite image as such. So this is another case where I'm just showing you the same. And we also looked at the multifactorial grading system and all the other risk models which were graded according to the literature. And these were the risk models which we actually graded in the H&E stains. And the data were entered into SPSS. We actually used the SPSS for descriptive analysis, for univariant analysis, univariant Cox regression, as well as multivariant analysis. We used the SPSS. For construction of the nomogram, we actually used the R software, where we did the model fitting, survival function, as well as the nomogram was created. And we also did the construction of the nomogram and the plotting of the nomogram as such. The survival estimates or concordance index or Harrell's concordance was actually done in another software, the SAS software. And we estimated the 1 year, 3 year, and 5 year estimates for overall survival for the various risk models. And I'm not going to go into details of the results, just I'll just highlight a few because of lack of time. Our 1 year survival, overall survival was about 90%, but the 3 year survival was about 75%, and the 5 year survival was about 65% as such. And this is the Kaplan-Meier graph which shows the survival. And this is the range and the mean SD of the pre-treatment inflammatory markers and their ratios. Then the tissue inflammatory markers at the invasive front and their ratios. And tissue inflammatory markers, again, the ratios of tissue inflammatory markers at the invasive front. And then coming to the tissue inflammatory markers at the tumor center and their ratios. And the post-treatment inflammatory markers, the range and mean, and the ratios. Okay, we did the univariant analysis, and these were the pre-treatment inflammatory ratios which were actually significant. And these were the post-treatment inflammatory ratios that were significant for overall survival in univariant analysis. These are the tissue inflammatory markers at the invasive front which was significant for overall survival. And again, tissue inflammatory ratios at the invasive front, which were significant in univariant analysis. And furthermore, and this is at the tumor center, these were the markers which were significant. Okay. Now that we have got we have done the univariant analysis, we went on to the multivariant Cox regression analysis. In the first model, we actually put in the sociodemographic, clinical, histopathological, pre-treatment and post-treatment inflammatory markers, which were actually significant in the univariant analysis into the multivariant analysis. And we saw that the gender, risk habits, the stage, size of the perineural invasion at tumor center, the pattern of invasion according to Royal College of Pathologists 1998, and the pre-treatment neutrophil lymphocyte ratios were actually significant in this model. Then we went on to do a model for sociodemographic, clinical, histopathological, and tumor inflammatory markers at the invasive front. Here, the risk habits, previous history of cancer, pathological staging, surgical margin status, and one of the ratio at the tissue inflammatory at the invasive front was actually significant, and this is for the tissue inflammatory markers at the tumor center. We had one of the marker which was significant and two ratios which were significant as such. So combining these three models, we actually came to a final novel model for overall survival, where risk habits, whether the presence of risk habits showed actually poor survival. Pathological staging actually showed, the greater the pathological staging has showed poor survival. If the margin was was involved, then it showed poor survival. And the pattern of invasion, you have the type 4 pattern of invasion showing the worst survival. And when it comes to the inflammatory marker, tissue inflammatory marker ratio, the CD66B minus and CD15 positive cells, those are the activated neutrophils. Sorry, not the activated, either the eosinophils or the myeloid derived suppressor cells. With the T cells ratio was, if it is high, then the patient had poor prognosis. Then on the other marker ratio, which was significant at the tumor center, was the T cell B cell ratio. If it was high, then it was the patient had poor survival as such. So let's see the multiplex immunohistochemistry. Here you can see that the CD3 cells are actually very less, and the CD66 minus and CD15 positive cells, which are the myeloid derived suppressor cells or the eosinophils at the tumor, if the ratio is, you can see a lot more of them, and if the ratio is high, then the patient had poor prognosis as such. And this is actually showing a low ratio, and the patient had a better survival. And this is for the CD3 T cells, which are pink in color, and the CD20 B cells, which are bluish in color. If the ratio was high, it had poor prognosis. And if the ratio was low, then they had better prognosis as such. So coming to the construction of the nomogram, we actually put these parameters into the nomogram and constructed the nomogram, and this shows the 1-year overall survival. And this is the model for the 3-year survival. And let's go on to see our model with the other models. And we estimated the various risk models for overall survival. And the lowest was for the grades of multifactorial grading, Anirudh et al., as well as the recurrence and overall survival probability of histological risk model, Brandwein-Gelser et al., 2005, in our cohort as such. And you can see that the pathological staging 8th edition AJCC had a good estimate of about 78%, but this can always be improved. And that is what our model actually achieved. Here we have, for 1 year, we had an estimate of 93%, and for 3 years, we had an estimate of 91%. And this model actually used the PTNM staging, the presence or absence of risk habits, the surgical margin status, the pattern of invasion, and the two tissue inflammatory marker ratios, one at the invasive front and one at the tumor center. So this slide shows you the C index for the TNM staging, which is 78%, whereas our model was about 92% as such. Yes, our study has a few limitations. The sample size of the final model was about 900 samples cases. The external validation was not done, and that needs to be carried out with in future. And we actually didn't take the socio-economic status of the patient. That data we didn't collect. So in conclusion, these were the factors which were actually put into the final model. And this study successfully developed a novel risk model for predicting the prognosis of oral squamous cell carcinoma by incorporating a comprehensive range of socio-demographic, clinical, and histopathological characteristics, along with the inflammatory markers, that is the pre-treatment and the post-treatment inflammatory markers, as well as the tissue inflammatory markers as ratios. These newly developed models demonstrate superior predictive accuracy of overall survival compared to the existing model. And this usually gives a practical value of these models lies in their ability to assist medical professionals in treatment planning, prognostic assessment, and personalized treatment care for the oral squamous cell carcinoma. And consequently, these risk models represent a significant advancement in the prognostic evaluation and management of oral squamous cell carcinoma. I would like to thank all these people who have actually involved in this project. Without them, this project would have not been possible. And this is my email ID. If you have any questions or any queries, you feel free to contact me. And finally, I would like to welcome you all to the 11th Asian Society of Oral and Maxillofacial Pathology, which is going to be held in Kuala Lumpur, Malaysia on the 23rd and 24th of May. With that, thank you very much. I'd like to thank the organizers for giving me this opportunity. If there are any questions, I will be happy to take.
Yes, sir. If anyone has any questions, they are free to give it in the chat box. I'll gladly ask the questions as well. Okay, sir. Seems that there are no questions. So thank you so much, sir, for joining in. It has been an honor to moderate the session for you, sir.
Thank you. Thank you very much.
Yes, sir. So with that, I would like to invite our next speaker for the day, that is Dr. Aparna Dave, ma'am. I'm proud to say that she is one of my own faculty members. And so the next speaker is Dr. Aparna Dave, ma'am. She is a professor and the head of department for oral pathology with over 21 years of experience in teaching and research. Ma'am is a graduate and postgraduate of the prestigious Government Dental College and Hospital, Nagpur. She specializes in potentially malignant disorders of the head and neck region. Dr. Dave has contributed to several national and international publications and has guided numerous research projects, including undergraduate and postgraduate dissertations. She is actively involved in academic activities at the Faculty of Dental Sciences and university levels and regularly participates in national and international conferences. Ma'am is committed to the professional development of both faculty and students and encourages research collaborations across departments and institutes. Ma'am, we welcome you to the stage now.
Thank you, Dia. I'll just share my PPT.
Yes, ma'am.
Is my PPT visible?
Yes, ma'am, it is visible now.
Is it visible? Yeah. Okay. Good morning, all. After all the discussion, elaborative discussion about cancer and presentations on cancer, I would like to take a step back and talk about something very basic, yet crucial, something which every student, every aspiring dental professional must understand, the importance of record keeping. It's a very important thing which often is overlooked in our clinical practice. Dental records are vital documents in healthcare, serving both medical and legal purpose. These are comprehensive written or digital documents that contain detailed information about patients' oral health status, investigations, and treatment record, including an overall dental care. They are vital part of dental practice. These records help dental professionals track patients' oral health, monitor treatment, and plan for future care. The primary purpose of maintaining dental records is to deliver quality patient care and follow-up. With increasing awareness among the general public of legal issues surrounding healthcare and with worrying issue in malpractice, for insurance claim purpose, a thorough knowledge of dental record issues is essential for any practitioners. Dental records are essential for various reasons in dental practice. Well-organized records, dentists can easily access details about treatment, medical history, and make informed decisions for ongoing care. These records are crucial for accurate diagnosis and treatment planning, as they provide detailed information on previous procedures and ongoing concerns. Well-maintained records also makes it easier to refer patient to other dental professionals when needed, ensuring smooth coordination and collaboration in sharing of important patient information. So if the other practitioner knows what the treatment was being provided, it will be easier for him to manage the case. In today's world, maintaining proper dental record is also important from legal perspective, helping protect both the patient and the dental provider in case of disputes. They serve as a proof of treatment and are vital in case of disputes or legal issues. Records can contribute to research. They can be utilized for teaching purpose as well as for public health initiatives, offering valuable data on dental health trends and outcomes. They may provide evidence that can be utilized for forensic purpose. Additionally, dental records are necessary for insurance purpose, ensuring proper billing and reimbursement. Many institutions seek various accreditations, and some dental practices apply for accreditation from governing bodies. These governing bodies not only evaluate the organization's operation, but also assess the quality and organization of its documentation system. To ensure smooth practice and management, it is essential to understand different types of records we deal with. Administrative records form the foundation of practice and includes complete patient details, including medical details. Clinical records, another important aspect where we document the care we provide, right from examination details to investigation details, diagnosis, and treatment plan. Another important record that needs to be maintained is legal records, wherein consent forms, records of unexpected events happening during the procedure, or records of referrals needs to be documented. Documentation of referrals is also important, as it will ensure that nothing slips through the cracks and everyone involved in the patient's treatment is on the same page. Financial records are the crucial part of any dental practice, ensuring transparency and accountability. These records include all transactions such as payments made by the patient, along with the date and mode of payment. Keeping accurate financial record is not only vital for proper billing and auditing, but it also helps to ensure that everything is in order for tax purpose and compliance. So as you can see, dental record keeping isn't just about writing things down. It is about creating a comprehensive, organized, and secure system that ensures quality care, protects you legally, and helps your practice run smoothly. With digitalization and with availability of new health management system, many dental practitioners have shifted from traditional-based record keeping to electronic systems. Digitalization ensures that dental professionals have up-to-date information on patient overall health, which can be important for treatment planning. These systems allow for easy storage of patient history, treatment plan, diagnostic images, and other important data, which can be quickly accessed by authorized staff members. When integrated with other some dental offices nowadays store records on cloud, allowing for secure remote access to the patient information. Cloud storage provides data backup, reduces physical storage requirement, and ensures that the records are easily accessible in case of emergencies or if the patient visits another branch of the dental setup. Digital records offer efficient data management, easy access, need minimal storage space, but an initial investment and training is needed, which at times might be difficult for a person who has started up with a new clinical practice. With shift to digital records, it is important to ensure that the health information of the patient are kept confidential, not only by the dentist, but also by every member of the dental team. Many practitioners still prefer maintaining health written records. Although handwritten records are low cost, secure from digital risk, but these can be prone to the human errors. They require more physical storage and they are difficult to integrate with other systems. There are standardized protocols and guidelines established by dental associations and regulatory bodies that outline the best practices for record keeping. These guidelines ensure uniformity, accuracy, and completeness in documentation of patient information across dental practices. Some essential guidelines for effective record keeping that are crucial for ensuring high quality patient care include accuracy, clarity, confidentiality, accessibility, and adequate retention period. Accurate records are a vital part of dental practice. Accurately recording patient details, clinical findings, dental and medical history, treatment planning is essential. Status of lesional area, but also of the non-lesional area needs to be noted. Expected complications should be informed to the patient and also be documented. The details should be noted down immediately after the discussion, as some crucial points will be missed if they are written down later. This would contribute to an incomplete record or an inaccurate entries. To accomplish this, it is important to use standardized documentation practices. There is a need to review the records so that they are updated from time to time. It is important to train the staff in the documentation process so that everybody understands the importance of record keeping. Each record must be clear, precise, and easy to interpret. When documenting patient details, clinical findings, or treatment plans, it is important to avoid vague language or unclear notations, as these can lead to miscommunication and errors in care. Standardizing documentation procedures ensure consistency across the records, while clear and legible writing, whether handwritten or digital, helps preventing misunderstandings. Correction should be done with a single crosscut with a line. Overwriting should be avoided, and any additions should be entered with date and signatures. Any refusal of treatment, cancel appointment should be noted down. Dental professionals have the legal and ethical duty to maintain the confidentiality of patient records, a core aspect of patient privacy and ethical care. In India, breach of confidentiality can result in legal, ethical, and professional consequences. Professional bodies provide guidelines emphasizing the importance of safeguarding patient information. Digital records are vulnerable to cyber threats. Dental practitioner must implement secure encryption method, access control, and regular audits to protect patient data. Only individuals directly involved in the patient care should have access to the records. It is the responsibility of the dental practitioner to ensure confidentiality and educate their staff on maintaining privacy. Records must be accessible and should be able to reproduce whenever needed, either for the treatment purpose or for the legal purpose when the patient decides to seek treatment with another practitioner. In such cases, copies of the records must be provided promptly to the patient in accordance with the legal and ethical guidelines. As suggested by governing bodies, every dental surgeon shall maintain the relevant records of his patients. These records must be preserved for a minimum period of 3 years from the date of commencement of treatment in a format determined by the authorized body or accepted as a standard mode of documentation. The Indian Dental Association recommends that the records, radiograph, models, photographs, and the clinical correspondence should be securely retained for a minimum period of 8 years. If any request is made for medical or dental records, either by the patient or by authorized attendant or legal authorities, the same may be issued to the competent authority within 72 hours after obtaining a valid receipt of all documents. It is mandatory to keep the certified photocopies of such submissions with signatures and dates. Some organizations recommend dental records to be retained for 11 years for children or until the patient is 25 years old. It is very important that an accurate financial record is maintained along with the details of date, time, and mode of payment. The financial related documents need to be preserved for an observation period of 8 years to avoid attracting penalties under Section 271 of Income Tax Act 1961. Although the importance of maintaining accurate dental records is well known, there remains a lack of awareness amongst many dentists in our country. In India, it is still common to find instances where dental records are either poorly maintained or not kept at all. Record keeping of pathology data is crucial for maintaining accurate patient details, facilitating research, and ensuring quality healthcare. Besides the acquisition of biopsy specimen and histopathological diagnosis, pathologist needs to maintain records pertaining to retention and appropriate use of human tissue material. Once the histopathology report is issued, it is the responsibility of the private practitioner or the hospital record department to store or maintain the records. It is ideal to store tissue material indefinitely, though different institution or organization follow protocols that are suggested by the local governing body for maintaining the records of gross specimen, paraffin blocks, and slides. Professional organizations such as College of American Pathologists and the Joint Commission of Accreditation of Healthcare Organization recommends that the paraffin blocks and histopathology slides and cytology smears must be retained for 10 years and peripheral smears for 7 days. The Royal College of Pathologists recommends preservation of blocks permanently, histology sites for 10 years, and wet tissue for at least 4 weeks after the dispatch of report. In India, histology slides and blocks are retained as records for a period of 10 years, and Cancer Referral Center retain it for 25 years. When requested by patient for stain slides, blocks, and stain section, a proper documentation or transfer of slides and blocks is needed, and this needs to be documented. Healthcare institution registries maintain data on the patient diagnosed and treated for cancer at their facility permanently. It is not only important to document and retain or reject the tissue specimen, but it is equally important to document the use of specimen for further research. It is generally accepted that the institution or the practitioner has the ultimate physical claim to the specimen and the tissue materials because the patient provides consent for the information to be collected when the samples are initially taken. This consent granted at the time of original testing allows pathologists to store and use those records in future. Where future research opportunities are not clear or planned, it is recommended consent form mentioning the potential for further research should be taken. This way, the patients are informed about the possibility that their data or sample might be used for research in future and can choose whether to participate. Regarding disposal or archiving of the records, proper deletion of dental records that are no longer needed should be done in accordance with the regulations and law. While disposing of, it is mandatory that the patient's confidentiality is maintained. Though there are some organization rules, regulations which state that the electronic records should be retained and should not be deleted. When it comes to managing dental records, there are several critical issues that can affect the quality of care and legal compliance. It's a common perception of record keeping that which most of the dentists or the practitioners feel that they are maintaining the record very properly or very aptly. But when surveys were done or studies were done, it was observed that the majority of the dental practitioners or majority of the practitioners failed to record the complete details of the patient. At some of the point of time, the records are incomplete. Incomplete documentation is a common problem, and this can lead to miscommunication or gaps in the treatment. Additionally, failure to regularly update the patient record can result in an outdated information being used, hindering an effective treatment planning. Failure to record patient's consent, which is necessary for both legal and ethical reasons, while when using the patient data for procedures or for research purpose. Ignoring digital security protocol is another data protection is done to prevent unauthorized access or breach of patient's confidentiality. Maintaining records for required period of time is crucial to comply with legal and professional regulations. If records are not kept for the mandated duration, a practitioner could face legal challenge. Addressing this issue is key to ensure effective, secure, and legally compliant management of the dental records. To ensure effective management of dental records, several best practices should be implemented. Use of standardized templates for documentation can help maintain consistency and reduce error across the patient's record. Regular staff training to ensure that all team members are updated on the latest procedures, privacy regulation, and software updates. Routine audits of the records should be conducted to identify any discrepancy, incomplete documentation, or compliance issues, ensuring that records are accurate and updated from time to time. Backup systems for digital records are essential to prevent data loss due to system failure, ensuring continuity of care and protection of patient information. Implementation of secured access protocols such as encryption and role-based access for safeguarding sensitive patient data and preventing unauthorized access. By incorporating these practices, dental practitioners can maintain high standard of patient care and data security. To conclude, I would like to say managing dental records effectively is crucial for patient safety and overall success of the dental practice. By focusing on key practices like using standardized templates, ensuring regular training for staff, conducting routine audits, backing up digital records, and enforcing secure access protocols, dental practitioners can maintain a high standard of care and reduce the risk of errors or security breaches. These steps not only streamline workflow, but also help build trust with patients by ensuring that sensitive information is well protected and accurately documented. Embracing these strategies will help dental practitioners meet legal and ethical standards while ultimately enhancing the quality of care provided to the patients. Thank you for a patient hearing. Over to you, Dia. So shall I stop sharing the slide?
Thank you so much, ma'am. If any participant has any questions, they can ask ma'am now, or they can drop it in the chat box as well. So we can ask it for ma'am as well. So with that, ma'am, I guess there are no questions. So thank you so much, ma'am, for joining in and giving your valuable information, ma'am.
Thank you,
Thank you
Dia.
so much, ma'am. It has been an honor to be your moderator for the day. So with that, we would like to call the next speaker, for the day, that will be Professor Dr. Shelly Mahajan ma'am. She has completed her BDS from RGDC and Research Center, Bangalore. She has acquired her MDS in orthodontics and dentofacial orthopedics from Bangalore Institute of Dental Sciences, Bangalore. Ma'am did her introductory course and standard proficiency course in laser dentistry from Academy of Laser Dentistry, USA. She has also acquired her standard competency course on laser dentistry by the University of California, San Francisco. She is one of the founder members of Academy of Laser Dentistry, Affiliate India, and also an active member of IDA, Indian Dental
Hello.
Association.
Sir.
Yes, and life member of IOS, Indian Orthodontic Society. Ma'am has an academic experience of over 18 years of teaching in one of the best dental institutes of the country, and is presently serving as a professor and heading Department of Dentistry at the Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. She is also in private practice for almost 14 years of working as a private practitioner at 32 Pearls Multispecialty Dental Clinic, Dental Laser and Implant Center at Lucknow. Ma'am has presented many papers at state and national level and has various articles in national and international journals published to her credit. Ma'am has around 50 articles in national and international journals and authored and co-authored 5 books and contributed 6 chapters. She has been an active member in the organization of various workshops on laser dentistry and various other continuing dental education programs.
Hello.
Yes, without further ado, ma'am, we welcome you. The dais is yours now.
Thank you. Thank you so much for a wonderful introduction. Welcome to you all to the one and only the International Oral Cancer Congress, which is organized by Faculty of Dental Sciences, SGT, University, India, and National Health Academy. I am very thankful to Dr. Nurul also, who had given me this opportunity. He approached, and that's how I could take the topic of what is today the future of photobiomodulation in oral and maxillofacial cancer care. We all have known that there is dentistry, which is the prime of importance, and we as dental surgeons have got, the opportunity and the responsibility of serving each and every one. People would have got, 2 eyes, 1 nose, and maybe like 10 fingers, but they have 32 teeth. So we have the added responsibility, which is multifolds, and we touch each and every specialty of medical sciences as well. So I welcome you all, and I hope that this program is going to be insightful. So after the lovely introduction, let's introduce like oral cancer care, which has been one of the important, aspects of oral and maxillofacial surgery. The cancers involve not only just one specialty, but it is a multi-specialty approach. It includes, the early detection, which can be done by our oral and radiology department, then the treatment aspects, which can be catered by the oral and maxillofacial surgeons. It involves a lot of, ongoing process and a multi-specialty unit. It involves rehabilitation, not only the treatment, but even the after support of the patient emotionally, physically, they are quite broken. So it has a role, and where the role is prevention and early detection. Just 3-4 days before, we had World Cancer Day, which was 4th February, and there were a lot of seminars and walks which were organized just so that the patients are aware, and each and every one gets the opportunity to know what hazardous things they have when you have like tambaku, gutka, and all these things which are easily available. So there was a lot of voice which was raised throughout the world, and our country, where tobacco is so freely available, and alcohol, that is very important, prime importance of our thing, that we as doctors, we endorse this thing, that they are very hazardous. So there are many risk factors, like I told you, smoke and smokeless tobacco, then topped with alcohol. People have, a different aspect of maintaining their oral hygiene. There should be a good oral hygiene which should be made, and simple habits like, brushing technique. That also the patients are not aware of, like how they are supposed to brush the teeth. And in our area, like we have like tobacco, toothpastes and tobacco, these powders which are available, that is also very regularly used by the patients and not being aware that, these are also the potential hazardous things that they can cause cancer. Regular screening, everyone needs to know about the ill effects of limited mouth opening, and howsoever we talk to the, crowd, we tell them about any white patch, like which is called as leukoplakia, erythroplakia, trismus in the mouth, which they are having, or even, limited mouth opening, which we usually known as submucous fibrosis, and public awareness we do on multiple platforms. Then comes the diagnosis. We tell them that, okay, now since you have diagnosed it and maybe there is some potential of malignancy, they do not have to worry. We do the biopsy, which is like a gold standard method which we can follow, and that is for confirmation. And that too is not a the standard thing. We have CT scan, MRI. We tell them about the PET scans, which has to be done, and then of course the TNM staging, which we do to find out how much of the metastasis is there. Coming to the treatment modalities, I'm not the good person because I'm an orthodontist, but I know the vision of how we treat the patients. Primarily, it is surgery where we can perform like oral and maxillofacial. Friends are there, my brothers, which are and sisters, who do those treatments, which there is involving the primary resection, neck resection, and reconstructive surgeries. Then, of course, there is radiation, which is involved because many times the size of the tumor is too much that it has to be shrunken first. So radiology first or surgery first, that is always some or the other a debatable school of thought. And then chemotherapy also, most of the patients go in for that. And now we have like targeted therapy or the immunotherapy. After we do the surgery or the active treatment, then comes the major area, that is rehabilitating, because any or the other be it radiation or be it chemotherapy, they always have some or the other side effects. So rehabilitating those patients and giving them the supportive care is one of the utmost importance. They have problems in speech, they have problems in, taste sensations have gone, and even swallowing becomes very difficult. Their nutritional supply, that has to be very good, and psychological support, because they are completely broken because amount of debilitation the patient has. There is a lot amount of like low self-confidence, which they needs to be, inculcated, and psychologists and physiotherapists, everyone needs to be together. Then follow up, and again, the reoccurrence prevention should be there. The patient should not go back to their, the habits which they were like they had broken for that matter. They shouldn't have, the relapse of those habits. And maybe secondaries for that, they have to be worried throughout life. So 5 years, 10 years down the lane, they need to have, the preventive part, that they have to include, their lifestyle modifications and reduced future cases. So as I told you, chemotherapy and radiotherapy, they do have certain potential, side effects, and which deliberately, affects the quality of life and the prognosis as well. And then I have told that the side effects can be either acute or chronic. So some of the side effects I have mentioned, which are by the chemotherapy, that is mucositis, xerostomia. We all are aware of these dental terms. And taste alterations, because when they do the chemotherapy, most of the taste buds also go in for a toss. There is good amount of immunosuppression which takes place, and neurotoxicity, osteoradionecrosis, we know, hair loss, nausea, vomiting, all these things are there. And radiotherapy, because we are dealing with head and neck cancers, like right now, today's topic. So there is radiation-induced mucositis, because the area which is exposed in that area, that loses, that becomes very inflamed. And it is very painful for the patients to actually even speak. I'm sure, like, we get to know so many patients, because at Ramanoor Lohia, we have a radiation and oncology department. So we tend to get these patients, and we see the plight of their mouth that we couldn't ever imagine when I was a dental student. Xerostomia, taste alterations, radiation caries, because the area which comes into radiation, those teeth also goes in for a toss. Trismus, then osteoradionecrosis, skin reactions, because the area which receives the extraorally or intraoral, that is erythematous and very inflamed area. If they are exposed to the thyroid part, then hypothyroidism, lymphedema, and secondary malignancies. I told you there's a multi-specialty approach. Not only the oncologist or anyone is required, but also it is a complete unit where the speech therapist, nutritionist, radiation therapist, and dental surgeon plays a very pivotal role in managing, the multi-specialty approach towards these patients. So what is the role of a dental surgeon, So there are a lot of encountered things, like this is particularly, even the treatment preparation when they are supposed to go in for radiation, like after the surgery, if the lesion is quite big, they go in for the surgery, and after that, before the radiation, they send it to us so that we can evaluate, what kind of problems the patient has, dentally. First is oral prophylaxis, and then we have to see how much of the teeth which are there, they are carious or not, because after the radiation, again for 2 years, we are not supposed to do any active treatments. So the pre-treatment first is the comprehensive oral examination. You just have to find out how much of teeth which have been, carious, what is the DMFT of the patient. The oral prophylaxis needs to be done. If the patient is very caries prone, we do the fluoride therapy. Brushing 2 to 3 times a day, and whenever they are actually eating, they have to swizz their mouth, that, and they need not have to do, they have to have, non-detergent toothpaste. So mainly SLF free toothpastes are there, which are not having any detergent. So any kind of irritation which can be caused, they have to be removed. Flossing should be one of the prime thing which we have to endorse the patient, that they have to floss every time they are eating or swizzing the mouth. Then alcohol-free mouthwashes should be endorsed to them. Coming to the post-treatment and the during treatment management of mucositis, that is there. Then the prevention of radiation-induced xerostomia, which we encounter, radiation caries and oral infections, preventing osteoradionecrosis. This is one of the major thing which we have to ensure, and maintaining dysgeusia, which is like taste alterations which they have, managing trismus, because when they are not able, when the mouth is not being opened, and when they are not able to take, proper nutrition, then also your body can have a good amount of immunity loss, and the patients are very frail in these kind of conditions. Imagine their psychologically they are very weak, emotionally they are very weak, financially also they are very weak, and not only them, even the support system of their families, they would have gone, and every time knowing, going to chemos and going to radiations, and still having that fear of, again, maybe a relapse can occur. This can be quite debilitating for anyone, for that matter. So we are managing these kind of adverse effects, be it like we tell them if there is, xerostomia, so you have to take, you can take some ice cubes and you can sip, them. You can keep it in your mouth every time. You can take sips of cold water. So if they do not have any kidney problems, we ensure that you have like a lot of water intake. But in some patients, when it is due that there is a little amount of water needs to be given to the patients, but the patient is having mucositis or xerostomia, we tell them to have, sugar-free gums, which are xylitol ones, and some water-based non-alcohol like mouthwashes, which we have, like GC Mousse and other, going for salivatory saliva substitutes, which are there. Then regular mouth assessments should be there. They have to visit the dentist every 2 to 3 months, rather than the other things like where you have to see, depending on the high karyogenic index, they have to see the dentist. Avoiding any dry fruits, oily foods, and even the foods which are very spicy and can, limit the amount of, their oral hygiene. And considering humidified oxygen, if they have any ulcers, then they can go for, these benzodiazepine or other lignocaine kind of anesthetic gels they can have. So these are all the things which we do regularly also. But coming to today's topic, what is the role of photobiomodulation? What we have in today's lecture is basically, or a webinar is to make you aware of what all we can have. So we will be talking about what is photobiomodulation, what are the presentation objectives, like what is its role, in taking care of oral cancer, how we can, add an adjunct to the patient's hygiene and other ways, so that they can eat and, they have a, good life, for that matter. The quality of life is not compromised. then the mechanism of action and applications of it, like how it can mitigate, treatment side effects, promote healing and pain relief, and improve the quality of life. Photobiomodulation is not actually preventing the cancer, but only the thing is like after radiation and all, when the patient is in a quite debilitating state, and how we can improve, it can be added as an adjunct to improve the side effects of what the patient is having. So coming to the introduction, photobiomodulation. If you see like photobiomodulation, so what is photo? Photo means light, and bio means the biology, the life. So modulation is how we can modulate. We can increase or decrease. So it is photobiomodulation. So light, what role it has on the life, and how it modulates. Whether it increases a cell's mechanism or it decreases cell's mechanism. This is an effective, non-invasive technique that uses low-level laser or light-emitting diodes to increase or stimulate the healing. Be it an analgesic part, it reduces the pain and improves the tissue regeneration. It removes all the algogenic materials and improves the regeneration capacity of a tissue. It has shown to have like significant benefits in reducing the adverse effects of chemotherapy and radiation in any kind of cancers, be it head and neck, because we are concentrating right now on head and neck. So we will be talking more of that. And before 2014, it was always known as, low-level laser therapy or soft laser therapy or, phototherapy. So these are all the names, but now because a lot of studies have taken place into that, so now the term of photobiomodulation has been given. So we all know the healing property of light. When we get up, it is always sun, and in Indian and being in our country, and because we have a lot of good scientific evidence of how the healing of Surya Namaskar is there. We do yoga, we get up in the morning and we are doing prayers, we use yogyas, and in any kind of religion, sun is always, considered important. Imagine a life in a few days or so, a few years or so, where you do not have sun. I think it will, lead to more of, depressive disorders. And not only that, it has been scientifically proved also in ancient times as well. Sun was always used, to cure certain ailments. Be it, a psychological, psychiatric people also have used, sunlight as one of the things. They have LED lights to cure many of the mental ailments. And even psoriasis, or in Chinese and German and all those Mexican civilizations, Indian also, they have had the phototherapy, which has been given of importance. So in order to classify right now is not the time that I can talk about like what are multiple wavelengths we have in the whole of the electromagnetic spectrum. There are ionizing radiations as well as the non-ionizing radiation, and lasers fall into the non-ionizing radiations. So it is laser is like light amplification by stimulated emission of radiation. That is the acronym for that. And for the presentation, I have just, simplified it as like surgical lasers and non-surgical lasers, because as dentists, we want to use that howsoever we can have, in our specialty, how we can use them. So coming to like biomodulation. So what we have is the low-level laser therapy, which is non-surgical. So it falls in this category, which we have here. So we have the surgical part. I think a lot more is talked about, the surgical aspect of lasers, be it like soft tissue cutting. We use it in frenectomies, gingivectomies, and other areas of we do it, take biopsies with that, and fibroma removal. There are a lot of things which we go in for that. And also it is used for the caries detection, and low-level laser therapy has been used for the photobiomodulation. There have been photoactivated disinfection, which have been used for the diagnosis of the tumor, because there are many dyes which we can use and we can identify the tumors. So coming to the history, it was Dr. Andre Mister, and thank you, sir, for introducing us to this wonderful, modem where we can modulate the quality of life for the patient. He is known as father of photobiomodulation. What he did was he conducted an experiment. He thought that, okay, there were multiple things which were used, in 1960, this doctor had spoken about in 1967. We had he had conducted an experiment on mice. So Theodore Maiman was one in 1960. He had introduced rupee laser. So there were a lot of studies. There were a lot of studies on the tooth as well, other things also. So what Andre Mestre thought was that why not use this, ruby laser on lab rats to kill the cancer cells, because he thought that high-powered lasers will be that high-powered and low-powered lasers. So because the highest intensity was being used, so what they thought, like, why not use this high-powered laser to destroy these malignant cells? But instead, what he found was that when he was, giving the laser therapy to those cells, there were hair growth in rats which were encountered. So he discovered that, okay, there is some kind of healing, which is there. So wound healing is there, hair growth is there. So he found that it, rather than killing that, it was invented, it was a serendipity for that matter, that it was invented to kill tumor cells and find out whether we can kill. Rather than that, the biostimulatory effects were found, that it can increase, the hair growth and other wound healings and other things. So this led to, multifaceted, then it was used then and there in oncology, wound healing and pain management. Then coming to 1980s and 2000s, carbon dioxide was introduced and Nd:YAG lasers were introduced in oral cancer surgeries. So CO2 lasers were also used, and it was 10600 and Nd:YAG lasers 1064 wavelengths. There are various wavelengths which are used. And we do have diode lasers as well. So they were also used for the surgical removal of tumors, biopsy procedures and palliative treatment. So in 1990s, then Wellscope was there. I think we have one lecture also after, like in the evening or maybe tomorrow, for Wellscope, like how it is used. So in they have a property of fluorescence, radio fluorescence. So in those areas which are very healthy, they'll fluoresce. But in the areas which are having, malignancy, or there is high mitotic activity which is going on in the cells, that will appear as the darker one. So in these figures, you can see this area is there. So we are just trying to find out whether it has some potential of malignancy or not, or examining what is the biopsy site what we can take. Imagine most of the time when we have a carcinoma patient, a squamous cell carcinoma, we fail to take, the biopsy from the tissue which is supposed to be taken. And we are aware of that, okay, this is a potential case of malignancy, but because of the lack of biopsy, because the area which has been taken does not include the amount, becomes like, a problem. So one second, I think I lost my slide. Yeah, thank you. So then that is like, this was the development of that. Then it was lasers in multimodal cancer therapy. Then the role of biomodulation had come for the prevention and treating of the mucositis, which we'll be talking about it in detail. So what is the mechanism of action? This slide becomes very, a little, that howsoever is there, I'll make it more simple. So whenever the photobiomodulation therapy or the laser light is targeted to the cell tissue, what happens is multiple amount of changes which take place. First is in the cell itself, the nucleus of the cell. We all know that cells have mitochondria. We would have studied. So there is, the laser lights are more, diode lasers and other lasers. They have a affinity towards the chromophores which are there in the body. It can be blood, it can be hemoglobin, it can be carotenoids. And in the mitochondria itself, we have a cisternae lining which has a cytochrome C oxidase. So that the light is actually absorbed by the cytochrome C oxidase, and what it does is it liberates, ATP, which knows that is the powerhouse of the cell, and it can have multiple potentials. Then nitrous oxide, which has a vasodilatory effect, and also reactive oxygen species, which is very much, needed for the modulation of your TNF factors and the inflammatory and pro-inflammatory markers in the body. So they have a regenerative mechanism as well, which has like extracellular matrix, which is also needed for, osteoblastic activity, fibroblastic activity, and decreased osteoclastic activity. And analgesic mechanism, because they play a vital important role, in modulating the mechanical action potential. They work on action potential cells, and also they have a good amount of analgesic effect, because it reduces the nociceptive receptors, and also leads to more of analgesic type of and imagine like TRP, PV1. Then coming to the clinical applications, it has a role in oral mucositis, which is, it reduces the severity and leads to faster healing. Xerostomia, it improves the salivary gland function and post-radiation effect. Post-surgical healing, tissue repair, and less scarring and pain relief because of the analgesic effect that I told you, because of the neuropathic and inflammatory. So what it does is there are inflammatory and pro-inflammatory markers. So it reduces them and there are less amount of neutrophils and leukotrienes. So edema is also less in these patients. And pro-inflammatory markers like interleukin-1, that is also reduced, and also the tumor necrosis factor. So coming to photobiomodulation in supportive care. So there are multiple wavelengths which are used, and what we use is, 450 nanometer, they are diode wavelengths, and 859, which is of green wavelength, 650 nanometer, they are usually nanometer, which is 10 raised to -9, and 810 nanometer. They are red ones, they have a deeper penetration. And the effect, how we calculate is time, which is required, to let the laser light fall on the tissue, into power, what amount of power which is used in that, and the wavelength what we have. So usually the deeper penetration ones are mostly preferred, so they can have, an in-depth, they can have the biostimulatory effect. The lower doses have an effect on the analgesic part, on the smooth muscle cells, and also the endothelial cells, which increases the vascularization. And the higher doses, they have a good amount of tissue regeneration capacity, which is like osteoblastic and cartilaginous through this growth. And also the leukocytes and the pro-inflammatory markers, they are reduced. We have multiple, sites extraorally and intraorally, which have been there. And also concerned is the safety part of it. We do have, safety norms which are there because they are high level lasers. They are class 3 and class 4, classified lasers. It is very difficult for me to actually speak each and every detail about it because we have a very stipulated time we have to close. But I would tell you that there are safety goggles which are there, which have to be worn, while doing the patients. And usually we are provided with 3 safety goggles. One is for yourself, your assistant, and the patient itself. Which needs to be there. They have to be high suction, and there are certain norms which comes in laser safety. And there are multiple handpieces which are dedicated to that. They're not for cutting, they are just for biomodulation. So they have a bigger, most of the companies are now producing, and there are companies which are producing, the multi-wavelength lasers which are there. So this is an intraoral handpiece which we use for photobiomodulation. These are the extraoral handpieces depending on the area what you are intended. So if you are using, in a TMG area, suppose the bigger area is there, so you have to use a bigger handpiece. So if there is a smaller area which are there around the chin area, or in the the area which is there in the like neck area, you can use a smaller one handpiece, and never ever fire the laser in the eyes of the patient. So that has to be one of the precautions. So there are we target those areas, the first hole of the mouth, and there are some, facial pillars are there, then the tongue, the ventral surface, the dorsal surface, and even the cheek areas we can have like buccal mucosa, and the facial pillars also, they have to be. And extraorally, there are all these areas are there, from the TMJ area to your mental area and your neck area. So all these things are targeted. Coming to the mucositis, what it is the inflammation of the mucous membrane as itself. It has an itis linked to it, and it is oral and oropharyngeal region. There is a pain, discomfort, and inability of the patient to eat. The patient cannot sometimes even speak also. And because this area is totally inflamed, they cannot have, the capacity even to swallow the fluid of the things, they have a semi-solid diet and they cannot swallow that also. So according to WHO, there are many other specialties also which have now, graded that. There are societies which have graded. So they have graded mucositis into 4 stages. So first is like soreness and erythema. There is redness which is there in the mouth, and the patient will be having like, I cannot eat, spicy food. Then grade 2 is like there'll be ulcers in the mouth, and patient has the a disability of not being able to eat swallow food, the solid food. Then in the grade 3, it will be like ulcers which are of extensive area and the patient cannot swallow food. And fourth stage is very debilitating. Third and fourth are where the patient has got, there is limited amount of opening and there is lot of, pain in the patient's mouth and they cannot even open. And they are very like, a morbid state which the patients are in. So coming to the treatment guidelines, there have been respectable medical organizations which have had, the supportive cancer care. So there is Multinational Association, which is a Mark's organization, which has laid the guidelines of how the mucositis needs to be treated. European Society of Medical Oncology and various other ones. They have given the World Association for Photobiomodulation Therapy, which they have recognized, that there have to be prevention which has to be taken, and how we can, enhance the quality of life of these patients. So coming to the prevention and management of mucositis. So how it does is photobiomodulation, when we are putting on the tissue, it has a good amount of analgesic effect as well as it accelerates, healing because it works on the undifferentiated mesenchymal cells, and then it leads to the potential regeneration of the fibroblasts and the collagen fibers. So it decreases the severity and the duration. So how we do it is like we have an infrared one. So where we target on these areas where the area which are more affected. So it is mostly the parotid area and extraorally and intraorally we have it on the fascial pillars as well as on the ventral surface of the tongue as well as the dorsal surface of the tongue. So these are extraorally the lip cutaneous surfaces. They correspond to the buccal mucosa and bilaterally cervical lymphatic drainage system. So the power which we use is 0.3 to 0.6 watt, depending on what kind of wavelength what we are using. This is one of the random double-blinded clinical trial. There are many of them. If you just go to PubMed and see, there are many RCTs which have been done. There is meta-analysis which have been done and which documents that, these are the various areas where we can target the phototherapy and how it is like they had during the present study, this evaluated like how infrared light can, go ahead, and then they had found that the low-level laser therapy or the photobiomodulation, what it calls is today, has an effective, role in treating the oral mucositis. And when it is incorporating, red and infrared lasers along with the conventional therapy, they score like more, and the patient's quality is increased. Then reduction in the xerostomia, even in not only in the cancer patients, but even in the other patients also, which are having, multiple debilitating diseases in the geriatric patients. We usually use these kind of treatment plans. Even for the patients who have got a TMJ problems also, we are using phototherapy for healing their, ailments. And in xerostomia, it stimulates the salivary gland function and increases the salivary flow. It reduces post-radiation fibrosis in the salivary glands and preserves the gland function. So usually the preferred wavelength is around 810, 940, 980 we can have, and it goes till 1064. Now the diode lasers are also coming in 1064, otherwise 1064 was previously known as NDR lasers. So there also, this is one of the protocols, and what we do it in the major salivary gland bilaterally, parotid and sublingual glands, which are mostly the ones which are, because the serous portion of the cells gets destructed in xerostomia patients. So we have to activate the glands. So there is biostimulatory effect which has to go in for the glands. That is why we target mostly the major and the parotid glands, the sublingual, submental, and the submandibular glands. And usually this is the protocol where the total amount of 6 points are taken, and the wattage what needs to be done is 0.3 to 0.8. Why we say so? Because every patient has got a different threshold. When you're going it extra orally, the wattage increases. The wavelength is the same, but the wattage increases. And what my skin is, I think it would not be a European skin. So we are darker colored, a little brownish color. So we will have, lesser amount of wavelength which can work, lesser amount of wattage which can work on us. And the patients like who are fair skin, they might need a higher amount of laser energy to be absorbed in their body. And depending on extraorally, we would need more, and intraorally, less amount of dosage is required. So Coming to the prevention of osteonated necrosis, lot many patients are on bisphosphonates, so they have got multiple potential. So any amount of dental treatment which needs to be done, that has to be done before. And because we have a problem that we cannot stop their, certain medications in these patients, and they have a potential, thing of osteonated necrosis. So what laser does is it increases the osteoblastic potential and reduces the osteoclastic activities and promotes more of the bone healing, and also enhances angiogenesis, which is formation of the newer blood vessels, and improving the tissue oxygenation, because we have nitrous oxide, which is a vasodilator. So it dilates the, the muscles and the arteries, so that good amount of blood circulation can take place. It reduces the inflammation and pain because of algogenic material, which is being removed in those areas. And extraorally, again, the intraoral points are 5 or more points are which are given. You can see like along the lingual and the buccal aspects as well of the maxilla and mandible, depending on which the site is and what amount, it needs to be given. So in those kind of patients, intraorally we can give, and extraorally we can give. Extraorally, maybe a little amount of, as I told, power may be required, and intraorally lesser amount of power will be required. And the dosage, usually in these kind of patients or any kind of patients, we always say like one day you do it, or regularly if it is done, it is fine. But at least 3 times in a week, we can discontinue for one day, and then we can tell them the patient to come. And it can be done like prior to the radiation, during the radiation, and post radiation as well. So it will decrease the amount of side effects what it has, because as and when the tissue is being, like charged with whatever the things are there targeted with the chemotherapy and radiotherapy, it will have a regenerative effect as well. So the amount of deterioration in the tissue becomes lesser. So pain management, I told you that it decreases even the patients who have got this, they have a burning mouth syndrome, and neuropathic pains which are related to the nerve damage. Some people usually have, the nerve damage, and then they do not have the sensation at all. There is a lot of paresthesia which is encountered in such patients. So in those patients also, we use laser therapy. Healing of the surgical wounds and tissue regeneration. Most of the time when the patient has gone in for a surgical, removal or resection of the area, we use these kind because they promote the biostimulatory effect, and also the tissue capacity of fibroblastic activity, collagen production that is enhanced. And so there is good amount of, wound closure which takes place with this. So we have in RML, we have a dedicated laser to our department, as well as we have a oral maxillofacial pain center as well, where pain medicine with the anesthesia team, where we are doing all such kind of patients. And being in the medical institute, I feel fortunate that we get to have so many patients, which otherwise I wouldn't have if I would have been in another dental college, or maybe in an area which is of limited source. In dental clinics, we usually encounter less patients. But my prime aim of taking this lecture was that we can promote ourselves as, the healers as well, when we can, increase the quality of life and reduce the problems the patient is usually having. So I'll tell you some of the cases. This is still an ongoing patient because the patient is still having radiotherapy. Most of the patient, they go for one year radiotherapy because the amount of radiation which is actually given to the patient is very lesser. So, and they give it in parts, like two gray, depending on like if it is 30 gray, 40 gray, this is how they have to. So patients keep on coming. So this is an old patient. She's 45-year-old, not even old patient. She's 45-year-old patient, female, with grade 3 mucositis because of the obviously post chemotherapy. And this is how we imparted. And I'll show you. This was just yesterday. We did. So this was her. We had just done the 3 settings, and you can see this is how we do. We target this area, and you can have like, a non-focused mode and a focused mode. So non-focused mode will have a bigger area. So in the extraorally, we have usually a non-focused mode, and in the intraorally, because it is very precise, the major what advantage we have with the lasers is that it is monochromatic, collimated and coherent, that it will be a single wavelength which have a deeper penetration. It does not diverge. It is very focused, and also it travels in one line. It does not have multiple, directions, and it is traveling in one or the, in a very parallel motion. So here we can impart all the, light in the deeper into the area. And this was this is after 3 sessions, and you can see there is, I will not be able to show you what the patient expected, but you can see the healing part here. So you can see the exfoliation of this area, and there is good amount of regeneration which is taking place in this area. She is yet to come, and we will be taking her testimonials as well. But she herself has spoken about it, that she couldn't eat, and she had difficulty in eating. Now she eats semi-solid foods. So that was one of the good things what we had encountered. I felt like sharing with you. There's another patient who is having xerostomia. Same, she had to undergo her breast resection because of she had a CA, and then she had come with that, and this was like given to us because she had xerostomia. So in those kind of patients, you can see the tongue which is depapillated, and she had like a lot of problems. So in these were the areas which we had taken. So this was the area of what we had, the lateral border of the tongue and the other lip area we had given her. And she also had 40% increase in salivary flow. She used to say like, I cannot eat because I do not get the taste. And there is no amount of, saliva which is formed. So I cannot engulf easily. So there also we tried, and we could attain good fair results. So there are enough of systemic reviews. You can go ahead and you can go for, there is support cancer care journals which are there, where they play like, okay, well, how the photobiomodulation helps in, increasing the happiness quotient of the patient. There are clinical guidelines and safety consideration which should be considered, that it has to be applied, in just 1 or 2 sittings is not enough. It has to be a continuous effort. There are no adverse effects which have been reported. It is completely safe, even in cardiac patients or even in the patients who are having any kind of debilitating diseases. And till now, with the pregnant female also, we have not encountered any of the written or documented evidence where this has been contraindicated. And it should be started before. That is what I'm stressing on. What we get the patient is like during the debilitating part. Rather than that, we can help. We cannot stop the adverse effects of what are encountering in these kind of therapies, but we can always decrease the duration and the intensity of a problem. So avoiding high powered laser that may cause thermal changes in the patient, because they can have a thermal damage as well in the tissue. So treatment should be performed by a trained professional, because it has to be a person who is expert in, handling the laser equipment, rather than that, because any kind of thing, if you give a knife in a butcher's hand and what it will be, and if you give it in a craftsman's hand, and they can do wonderful things. There are guidelines on mucositis which have been given by many national and international organizations. The benefits are, it is non-invasive, pain-free. So the patient is also not, very apprehensive in, asking for them. Minimum side effects, cost-effective over the period of time, because initially as surgeons, when we have to introduce laser in our thing, so we have a laser unit in the department, and we have a laser unit, I think, in now every clinic for that matter. It has become like one of the bread and butters of dentistry. So when we have the surgical aspects as well, and we have other aspects, it has been, the photobiomodulation has also been used in certain criteria of, treating sleep apneas, and I'm myself using for hypersensitivity and other various applications. So here you need not have to, ask for another unit to be there in your clinic. It will be, or maybe in your department, it will be an add-on thing to your things, or what you have been already catering to the patients. There is improved patient compliance and comfort, and versatile applications with used in oncology and patients rehabilitation and your regular daily day-to-day clinical practice. Challenges and limitation are lack of standardized protocols. As I told you, whatever the things are there still, because it is very in infancy state. People are still working. We are all doing it. And in India, most of the time, we are doing so many patients as other specialties or other countries, but we lack certain documentation which needs to be done. And there has to be a training and expertise which have been there. Limited awareness is there amongst clinicians. That is because not many people have not voiced it. This topic was also like, I only asked, can I take this, Dr. Nurul? And he was very nice, and he told me, okay, ma'am, you can take this. And I'm really thankful, mentioning again and again for that. Initial cost of the equipment. But if you have already got, a laser in your clinic, soft tissue laser, I think giving your patients the best of the things, and you will have word of mouth, and what wow effect you can add to the patient's concern is going to be multifold therapies, and the patient and their families would be attracted to that. And further research is required. We do not have right now the long-term outcomes and efficacy, but I'm sure with the going on time we would definitely have that. Future perspectives are integration into the multi-specialty care and collaboration with the oncology and surgical and palliative teams. We have done it in RML. We are getting now the patients. And similarly, I expect that you can also have multiple, friends who are doing oncology and surgical part of it. You can go and ask them, to send you the patients so that you can increase, their quality, and you can add to the certain, quotient of quality life to the patient. Emerging technologies are there, then AI guided protocols should be there, and it is a portable and affordable device. Focus on personalized medicines, tailored parameters, and individual patients should also be one of the criteria. There are many multiple training ones. There are by American Laser Dentistry. There is by UCSF. They have a 2-day programs, or maybe a single-day program where they have introductory courses, standard proficiency or standard competency courses, and even masters and advanced you can go for it. But before using, I would always suggest that you do, a comprehensive training for that, so that you can be well versed with what you are. Because once you know what the ingredients are, it will be very easy for you to make a dish. So how the laser is there, how the interaction of the laser is there, what is the basic mechanism, what is the science behind this. If you know that, I think then sky is the limit. We are also like, going ahead with that. Coming to the conclusion, photobiomodulation is very promising adjunct therapy for oral cancer patients. It enhances the treatment outcome and reduces the complication, improving the quality of life. Further clinical research and awareness are key to wider adoption. And with that, I would like to thank you and all my patients who have, given me the leeway and the credibility that I could come and, speak in front of on their behalf to you. And you all wonderful audience, like we could not be, present here. We are virtually connected with each other. And these are my phone number and email. And thank you once again to the whole team, Dr. Nural, your team. I mean, you guys rocks for getting the best in the whole world to our own homes. Thank you so much.
Thank you so much, ma'am. It was such a comprehensive lecture on photobiostimulation therapy. We also do it in our department, but through your lecture, we have learned so much today, so much newer things, especially related to xerostomia and all. So we are definitely going to try it on our patients now. And it was a very insightful lecture.
Thank you.
Yeah, thank you so much. So
Yeah.
any questions, if anybody has, they can ask ma'am directly or put it in the chat.
There are few brand names of non-detergent toothpaste. Any SLS-free toothpaste are there. They are, these GC Mousse is there. Then by Abbott. Then we have Sensodyne. They are also SLS-free. So I mean, all medicated ones are, I think, SLS-free, where they do not have any gel. They do not have any foam, which is there. So when we tell the patient, we will say that you would not get the taste of it. But because jhag nahi banta hai, they say like there's no froth which comes. So we tell them that this only you have to use. There is Dente 91 Enamel Care and Clean Pro by 3M. Those are the ones which were there. Okay. Which wavelengths are more beneficial? So any amount of diode lasers we have, it is good enough because the cost is somewhere between 2.5 to 3 to 5 lakhs. You can get a good amount of diode laser. So it can work as a surgical laser as well. There are many lasers which are dedicated to low level laser therapy, because there is Thor company which is coming with cold lasers, because now only we are, voicing our things that they can be incorporated into the dental specialty. But other places, they have a dedicated, and even the people like who are there, physiotherapists, they are using, this aspect of in their own, all the sports people, they have this. I think I'm crossing the more time, I believe.
No, ma'am, it's okay. It's lovely to hear from you.
Thank you. I'm there, like you can have my phone number, anything which is there of I can be of any help, I'll be more than happy to.
Definitely.
Ma'am, Ma'am, can I have your phone number, ma'am? Like,
Yeah, I think
regarding.
it was displayed.
Ma'am had displayed it on the screen, beta.
Oh, okay, ma'am. Okay, thank you.
Yeah, I'll write it in the chat box, I think, because otherwise it'll become more universal. Though I did.
Ma'am, you can give it to her as an individual. Yeah.
Oh, it's okay. I have.
Okay.
It's okay.
Yeah. Yeah. Okay, ma'am.
Thank you. Thank you so much. Thank you.
Thank you, ma'am. So moving ahead with our further sessions. So we have our next speaker with us, Dr. Pulin, and Dr. Yashna. Kindly introduce her. She belongs to our own university. So we'll go on with Dr. Pulin.
Dr. Pulin, ma'am, Dr. Pulin Saluja is a professor in the Department of Oral Pathology, Faculty of Dental Sciences, SGT University. A proud alumni of SGT University, she has completed her BDS from DAV Dental College, Yamunanagar in 2007 and earned her MDS from SGT Dental College itself in 2012, securing the highest marks in her specialty. Since then, she has been an integral part of SGT family, contributing over a decade of dedicated teaching experience. Her passion for academics and unwavering commitment to her profession have shaped her journey as an educator and researcher. She has presented numerous papers at international and national conferences and has frequently chaired scientific sessions. Her contributions to the field have earned her several awards and recognition. Additionally, she has an extensive list of national and international publications in reputed journals and has authored and reviewed books in her specialty. Dr. Saluja's primary research interests lie in oral cancer and related studies. For the third consecutive time, a student under her mentorship has been awarded the prestigious ICMR STS grant. She firmly believes that undergraduate students are her greatest strength, emphasizing that with the right guidance at early age, they can achieve remarkable success. With this, I would like to request Dr. Pulin Saluja ma'am to kindly continue with the session to continue and give the insights of the role of artificial intelligence in the oral cancer prevention. Over to you, ma'am.
Hello, hi Ashna. I'm just trying to share the screen. How to go about it? Share window. Do I need to share the window? Hello, am I audible?
Yeah, you are audible. You have to share your PPT.
How to do it?
You share it from the link which is there. A green button is there.
I have clicked on the button.
You are trying it from your MacBook?
Yeah.
I also had an issue with that.
Okay, so how now what to do?
Somebody else is there with a different laptop, Microsoft laptop.
Okay, then I will have to mail my PPT.
You send
We
it
will.
to WhatsApp or with the help of pen drive, put it in ma'am's laptop and then share it. That's what I also did.
Achha, on MacBook, is it not?
No, it was not. It was not working. No.
Oh.
Just give me 5 minutes to read
Maybe Zoom has some privacy issues with the MacBook, so switch to other laptop.
Then just give me 2 minutes and
No,
give me
it's
two.
Oh yeah, take your
visible
time.
actually. It was visible for a while.
Ma'am, your screen is visible.
Okay, is it visible?
नहीं कहाँ है?
No, it was visible for a while, but it
वो मेरे साथ भी
disappeared.
हुआ था.
What you can see?
कहाँ है?
No, it's not visible now.
Try to share it.
See, there are two options, either to share window or to share screen. I don't know.
Share screen. Share screen.
I have tried both, but I am not able to do it.
Share screen. कहाँ है?
Your screen is shared actually. No, it,
Oh, yeah, my screen is shared, but I am not getting any, option to share my PPT.
Give me 2 minutes. Just switch.
I will just present
The
from
laptop.
Max
Switch the laptop.
Just give me 2 minutes. Give me two.
Yeah, it's okay. Take your time. Switch the laptop. We can see the presentation now. Dr. Pulin, we can see your presentation.
Hello?
Yeah, Dr. Pulin, we can see your slides and presentation.
Just give me 1 minute.
Yeah.
Hello?
Yeah, you are audible.
Am
Yes.
Okay. And visible also.
Yes, yes.
Okay. It is difficult to present from somebody else's laptop, but
No, it's okay. Just go ahead. Yeah.
okay. Very good afternoon, everyone. Thank you, Yashna, for the lovely introduction. I'm Dr. Pulin Saluja, professor in the Department of Oral Pathology, Faculty of Dental Sciences, SDT University, Gurugram. I am actually Punita ma'am's colleague. So thank you, ma'am, for the opportunity. Today, oh my God, I'm not able to. Is it moving?
Yeah,
Okay, okay. Yeah, okay. So today I will be presenting on a very important and emerging topic, that is artificial intelligence in the early detection of oral cancer. With oral cancer being a significant global health issue, the integration of artificial intelligence in its early detection has shown promising results. So through this presentation, I will discuss how AI is transforming the diagnostics, the benefits it offers, and the challenges we still have to address. So let us begin with the quote. AI in healthcare is not about replacing humans, but it is about empowering them to save more lives. This is our SDT University. We were accredited with NAC A+ last year only. So I just wanted to put up this picture in front of you all. So let us begin. Oral cancer, it is a global issue that poses challenges both in diagnosis as well as treatment. Being the top 6 cancer all over the world, it primarily affects lips, tongue, cheeks, and oral, the floor of the mouth. Major risk factors which are involved are tobacco, alcohol, HPV, poor oral hygiene. But the most concerning fact is that late detection drastically lowers the survival rates among the patients. Early diagnosis is critical because it significantly increases treatment success and the patient survival. However, several barriers, they make the detection difficult, which is where artificial intelligence can help. Now, there are many challenges in early detection. One of the biggest challenges is in case of oral cancer diagnosis, the symptoms often they go unnoticed or they are mistaken for minor oral conditions. Additionally, access to specialized diagnostic tools and trained professionals is limited, especially in rural and distant areas. So human error and subjective interpretation in clinical assessment, it also leads to misdiagnosis or delayed diagnosis. So AI has the potential to address these challenges by providing objective, fast, and accurate assessments. Now, when we talk about the role, specifically the role of artificial intelligence in healthcare, first of all, we should know what actually artificial intelligence is. It is an area of computer science that can be defined as a machine's capacity to emulate a human's cognitive capacity. Or in simple words, we can say it refers to machines that simulate human intelligence. In healthcare, it has been used for medical imaging, disease prediction, and even personalized treatment plans. AI algorithms, they learn to, is my screen completely visible? I just wanted to know.
Dr. Pulin.
Okay. So human error, so this thing, let's explore now how AI specifically applied to oral cancer detection. This picture we can see, the current medicine says that one treatment fits all. But future medicine, it has to be more personalized. When we are able to personalize the future medicine, we would be able to provide treatment and diagnosis more precisely. So let us talk about artificial intelligence in oral cancer detection. Artificial intelligence, it plays a crucial role in oral cancer detection by analyzing images, pathology slides, and patient risk factors. Broadly, we can say AI can be, it encompasses two distinct branches, that is traditional machine learning and deep learning. Now, this traditional machine learning, where we can see the it uses algorithms and computer processes to calculate information and recognize patterns from input data, and then offers a quantified judgment as a diagnostic result regarding the nature and behavior of the lesions. Whereas deep learning is actually more like human brain. Like we have neural network connections in our brain. So deep learning also works in that manner only. So they are neural networks which are regarded as a subset of machine learning. This machine learning is subset of artificial intelligence, and deep learning is subset of machine learning. So this deep learning or the neural networks, they are regarded as subset of machine learning. They are computational techniques where there is minimal human intervention and are based on formation of non-linear processing units with multiple hidden layers to learn and comprehend. It can process large-scale data and can thus explore complex relations between the input and the output. Using machine learning and deep learning models, AI can identify potential cancerous lesions at an early stage, long before they become visible to the human eye. And it can be integrated into various diagnostic tools, from like mobile apps to advanced imaging systems, making screening more accessible and efficient. Now, broadly, if we differentiate machine learning from deep learning, if we look at the problem-solving approach, machine learning has manual extraction, but there is minimal human intervention in case of deep learning. This machine learning can be either supervised or unsupervised, whereas this deep learning actually incorporates interneuronal networks. So it works on generative adversarial networks. As well as complexity of algorithms is concerned, there are various models which work for machine learning, and in case of deep learning, there are interconnected neurons. Then the machine learning relies on structured data, whereas deep learning leverages artificial neural networks. Now, as far as infrastructure and databases are concerned, machine learning has different types of like convolutional neuronal networks, etc., whereas deep learning, it relies on larger data sets. Now, when we talk about AI-based screening methods, it include image-based detection, where algorithms analyze clinical photographs, radiographic images, histopathologic images to differentiate between benign and malignant lesions. It can also be used in autofluorescence and spectroscopy techniques, where it enhances the accuracy of early cancer detection by identifying subtle changes at tissue level. So these approaches are particularly useful in mass screening programs and for remote healthcare settings. So here also, like if being an oral pathologist, this histopathology would be my favorite. So when we look at this picture, we can see that like when the data collection, when there is data collection, then after processing and AI training, the testing and diagnosis can be, done in remote and such remote settings where the specialists are unavailable. Then AI in radiographic analysis, plays a critical role in detecting oral cancer, especially in cases where there is bone invasion. So AI-powered models, they can analyze panoramic radiographs like OPGs, CBCTs, highlighting suspicious areas with a high degree of precision. Each and every area is scanned, and it helps to detect the bone invasion and the dysplastic changes there itself. So it reduces the radiologist's subjectivity, and it reduces the reliance on human interpretation and speeds up the diagnostic process. Then digital pathology is also transforming the histopathology and the field of cytology. Whole slide imaging combined with deep learning model allows AI to examine tissue samples and classify them based on cancer risk. This not only accelerates the diagnostic process, but it also improves the accuracy by reducing the inter-observer variability among the pathologists. Here we can see, like this is a biopsy image. When the biopsy image is obtained, then the slides are prepared, histology slides are prepared, then image acquisition is done. Captured images can be sliced from different areas. After pre-processing and segmentation, the features are being extracted. This is done by a deep learning model. So deep learning model along with the machine learning model, these different models we are going to discuss further. So they can definitely help us in early oral cancer detection. So it is going to make the faster and precise diagnosis in the future. Now this artificial intelligence is being used to analyze genetic and protein biomarkers also, which are linked to the oral cancer. So in this era of field cancerization, if we are positive, when the lesions are not visible to human eyes, when there are no visible lesions in the oral cavity or somewhere else also, if we are able to, if we are able to analyze the genetic and protein biomarkers, by studying the molecular patterns, it can predict which patients are at high risk of developing malignancies before any clinical symptoms appear. So this is going to enable early intervention and targeted treatment strategies in the future. Now, yes, in era of chat GPT, so there are chat bots and virtual assistants available also. So especially in remote and distant areas where telemedicine works as a preliminary screening method. So these AI-powered chatbots and virtual assistant, they are being used for patient education and preliminary screening. These tools can assess a person's risk of oral cancer based on their habits, symptoms, their medical history. They are particularly useful in telemedicine, where access to specialists is limited. Now, there are different AI models in case of machine learning as well as deep learning, like CNN, that is convolutional neural network. So they help in oral cancer, early oral cancer detection. Now, how do they do so? This like convolutional neural network, it helps, it is actually applied, it works on image classification and it helps us to detect the images. Like it can help us to detect the difference between leukoplakia and erythroplakia. So it is going to classify the images, helping and further helping to detect the lesions. Then support vector machine, it analyzes complex histopathological data. So random and then it can help us to analyze the different histopathological images also. Next is random forest algorithms. These all are like convolutional neural network. This is type of machine learning. So these random forest algorithms, they also recognize patterns in patient data to predict cancer risks. Similarly, deep learning models, they extract features from images and pathology slides, increasing their diagnostic accuracy. The combination of all these AI techniques, it is going to make the cancer screening more robust and precise, and it is definitely going to help us to predict the malignant transformation. Now, a few of the AI-powered applications have been established and are being used, though they are in trial form only, but still they are being used like Muskan.ai. This platform offers an oral cancer screening app that utilizes advanced AI algorithms and imaging techniques to provide accurate and efficient diagnosis. Then this is Smarty.ai. This platform highlights the practical impact of AI in oral cancer detection, including smartphone-based screening tools that analyze images captured via mobile phones. Then this Triple IT Hyderabad researchers at Triple IT in Hyderabad, they have developed a simplified image-based machine learning solution for preliminary screening of oral cancer. Then certain AI-based, a number of AI-based tools are being established or they are under, the trials. And so one such emerging tool is salivary biomarkers, is used for salivary biomarker analysis through AI to detect molecular changes indicative of cancer. A recent network meta-analysis concluded that coumarin, MMP9, and phytosphygosine, they were the most sensitive salivary biomarkers for oral cancer across the included studies. However, further research to refine the identification of these oral cancer biomarkers are warranted. Now, when we talk about risk detection, so beyond diagnosis, AI also helps in risk detection, prediction, and treatment planning. So it can analyze multiple factors such as patient history, genetics, lifestyle habits, what you are eating, what you're not eating, what you should eat, what you should not eat. All big data analysis and integration with different neuronal networks and machine learning models. This can help us in make the predicting the patient risk, and we can thus personalize the treatment plan, or we can tailor the treatment plan according to the patient needs for better outcomes. Various research studies and case studies are being conducted on daily basis so that we can be more precise about what particular model should be used for what diagnosis. So several studies have demonstrated the effectiveness of AI in oral cancer detection. For example, a study by Google Research in 2021 showed that AI could detect oral cancer from smartphone images with high accuracy. Then another study found that deep learning models analyzing biopsy slides had a diagnostic accuracy of over 90%. So these findings, they highlight the potential of artificial intelligence in revolutionizing the early detection. Similarly, Alzami et al. Developed an artificial intelligence model employing a neural network for predicting malignant oral cancer based on 29 variables gathered from 73 patients. So the model demonstrated good accuracy, about 79%, with a sensitivity of approximately 86% and specificity of 60%. In Nature on 11th, in journal Nature on 11 July 2024, the conference proceeding was published. The conference was on genomic analysis and technology at Delhi's International Center for Genetic Engineering and Biotechnology. There, Professor Dinesh Gupta, who is the group leader of translational bioinformatics at ICGEB, according to him, AI and ML, that is artificial intelligence and machine learning, they are making it possible to massively improve the accuracy, efficiency, and timeliness of cancer detection. This directly is going to it is going to improve the patient outcomes and reduce healthcare costs. The All India Institute of Medical Sciences, that it aims in Delhi, recently launched an AI system trained on 5 lakh radiological and histopathological images from 1,500 breast and ovarian cancer cases, the most prevalent forms of cancer in India. Melissa Fullwood, Associate Professor at Nanyang Technological University in Singapore, shared her team's use of AI to predict chromatin interactions in cancer. Similarly, researchers at IIT Dharwad, scientists from the Institute of Bioinformatics and Biotechnology, Manipal, and Kidwai Cancer Institute of Oncology, Bangalore, they are using multi-omics-based classification, which proved to be a more accurate prediction model. So definitely all these highlights, all these studies, all this information, it indicates the potential of artificial intelligence in revolutionizing the early detection. So definitely there are advantages of artificial intelligence in early detection. That is, it offers several advantages like faster and more accurate diagnosis. Definitely it is going to be cost effective as far as mass screening is concerned. The AI powered tools can also be used in remote areas where access to specialists is limited, and it is going to improve the healthcare outcomes globally. But definitely there are certain limitations as well. Despite its all benefits, AI models require high quality data sets for training, and biases in these data sets can affect accuracy. So additionally, it requires significant computational power, and ethical concerns around data privacy and patient consent must be addressed. Importantly, AI should be seen as a supportive tool, not a replacement for human expertise. So when we talk about future prospects of artificial intelligence in oral oncology, yeah, you can look at this dental chair. So AI integrated smart dental chairs are the need of the hour. They can perform which can perform real-time screenings. AI-driven telemedicine platforms, it could help identify at-risk patients remotely. In oncology, artificial intelligence could be used for gene-based treatment planning, leading to more personalized and effective therapies. As dental professional, we must stay updated with artificial intelligence advancements and integrate these tools into our practice. As dentists, we should collaborate with artificial intelligence researchers to refine these technologies and ensure they are ethically and effectively used in patient care. Definitely, we have to take care of ethical and legal considerations. We have to be we we have to regulate we have to ensure the ethical use of artificial intelligence. Issues such as patient data security, algorithm bias, and legal responsibilities, they need to be addressed before widespread adoption of artificial intelligence each and everywhere. And I would like to conclude with that artificial intelligence is transforming the early detection of oral cancer, leading to faster, more accurate diagnosis. While challenges remain, integrating artificial intelligence into clinical practice can significantly improve patient outcomes. Artificial intelligence will not replace doctors, so we should not be worried about. But doctors who use artificial intelligence will have a major advantage in saving lives. So these were my references. Thank you for your attention. I hope this session has provided insights into this new topic. Thank you so much.
Thank you so much, Dr. Pulin. It was such a lovely lecture, and it is a shining example of the impact that technology is going to have on all of us, and it is such a positive
I am
impact.
not able to hear you, Punita ma'am.
Okay. Just a second. Am I audible?
I hope I was audible.
Now, am I audible to you now? Dr. Pulin, am I audible?
Yes, you're audible.
Yeah. I'm saying, Dr. Pulin, it was such an insightful and lovely lecture. You have gathered all the points which are related to the technology and AI, which will help us with early detection of oral cancer. And we all know that early detection is the key. And why not use technology for early detection? Why not, use the boom of technology which is going around, the AI, the meta AI, which is moving all around us? Why not use it for our benefit? Why not
Yes,
benefit so
definitely.
many patients with it? And it was a
Yeah.
lovely lecture. So thank you so much, and God bless
Thank you.
If anybody
Thank you
has
so much.
any questions, then they can ask Dr. Pulin. She can, guide you through more things which you want to know regarding the AI and detection of cancer.
Yes, Dr. Punita, the next speaker is about to join in 10 minutes. She is busy in surgery. So
Yeah,
by the time, we can have a Q&A session.
Yeah, if anybody wants to know, there is a question, Dr. Pulin. Ahalya is asking, are there any courses available for, learning the AI for this cancer algorithm?
Yes, definitely. Though this machine learning and this is the machine learning and deep learning, artificial intelligence, it is actually data science. This is not actually our field. These courses are being taken up by the Faculty of Computer Sciences and Commerce and Management. And this machine learning is also being part, the mass communication people are also using this. They are taking also certificate courses and short courses. Even NEPTEL is providing the certificate courses for the same. Coursera, NEPTEL, all are providing the certificate courses for the same, specifically the use of AI in healthcare also.
Okay.
So we can check for the regular updates given by such resources.
Okay. So there's one more question. Dr. Shelly ma'am is asking that what are the AI tools which can be used for detecting the oral lesions? Are there some specific tools?
Ma'am, yes, they are this under the establishment only. Like I told, some apps have been developed, like Muskan as app, and such some apps are under the process. They are actually under trials. People are using this deep learning and machine learning models for data analysis, and apps are also being established, like I discussed about. And yes,
There was a
definitely for
I saw that, yes.
And yes, actually, Shelly ma'am only mentioned about like if we know the ingredients and definitely the steps also, we can prepare a good dish. So this though for medicos understanding this data analysis, this data science is a little difficult because we have never read about all this in our earlier days. So but yes, definitely, if we try to understand, if we try to gather knowledge, we can definitely do that. And we can always take help of engineering people and commerce and management people to understand the topic and help to collect the data and convert that data into for that meta analysis.
Yeah. Okay.
So,
ठीक
any
है,
other
Dr.
question?
Pulin. Yeah, that's it. I think
Okay.
it was a great session.
Thank you.
It was a shining example of the impact that the technology is going to have on us in near future. So
We
thank you
should
so
all
much.
be ready for that.
Yes, we have
And
to.
we should be confident enough that this is not going to replace us.
No,
This is
no,
only going to help us.
definitely, definitely. So on that positive note, so we'll be waiting. We'll be taking a short break of maybe 5 minutes or 10 minutes, and then we'll wait for our next speaker. When he arrives, then this next session will be starting.
Yeah, our next speaker is Dr. Priti Jain. She is an onco-surgeon, and she's supposed to finish the surgery, and she's supposed to go to the another surgery. So in between two planned surgeries, she would be joining, and that's why she is taking 5-10 more minutes. As soon as she joins, no, we'll rejoin actually. By the time, stay with us, and you can have any discussion that you can discuss the thing.
Yes, yes, yes. If anybody has
Thank you. Good.
some points, yeah, thank you, Dr. Pulin. You can go
Yeah,
ahead
yeah.
with the lunch. I'm sure you must be waiting.
Dr. Priti is joining in a short while. Just we have spoken on a phone and she is joining right away. Just wait for 1 or 2 more minutes. Dr. Priti has joined the meeting room. Yes, Dr. Priti Jain is there in the meeting room. Could you please introduce her and request her to start her presentation? Dr. Punita? Dr. Dia? Dr. Priti, just wait for a while. Our moderators are just joining in a couple of minutes.
Sure.
I think.
Hello.
Good afternoon, everyone. Shall we start with the next session? So can we start with the next session?
Yeah, Dr. Yashna. Yeah. Dr. Priti is there. You can just introduce her, and she will. She is in a rush. Actually, she has to go to the another surgery.
Yes, sir.
So
Yes,
yeah,
sir.
just start the as soon as possible. Yeah. Okay.
Good afternoon, ma'am. Dr. Preeti Jain, ma'am. She is an MBBS, MS, and DNB in surgery oncology. She's a director of oncology services in Shapristri Hospital and Cancer Center in Jabalpur. She's also a director in AOMSI Oral Oncology Fellowship from the Shapristri Hospital and Cancer Center, Jabalpur. She is a senior consultant in surgical oncology in Jabalpur Hospital and Research Center. She has an experience in standing in the field of surgical oncology for past 22 years and is one of the very few female cancer surgeons in the country practicing entire spectrum of cancer surgery and is the only lady cancer surgeon in Mahakaushal region. She is only the very few surgical oncologists in the country trained in the performing microvascular constructive surgeries. She has been an ex-HOD in the surgical oncology at Mahavir Cancer Sansthan, Patna. She has been a teacher and thesis guide for DMB courses in surgical oncology in Patna. She has been a pioneer in microvascular reconstructive surgery in the region of Bihar. She has worked at Tata Memorial Hospital, Mumbai, Nanavati Hospital, Mumbai, Manipal Cancer Center, Bangalore. She has also worked with Dr. Jatin Shah at Memorial Sloan Kettering Cancer Center, New York, USA. Presently, she is the director of the AOMSI Oral Oncology Fellowship at the Sapistry. She has been an active member of national oncology forums like Indian Society of Oncology, Indian Association of Surgical Oncology. She has organized several national and international oncology conferences also, workshops in Patna, Jabalpur and Indore. She has been a receiver of the Healthcare Excellence Award in 2015 for her outstanding contributions in the field of oncology in Bihar. She has also been a reviewer of the articles for the JCRT. Over to you, ma'am.
Thank you so much, Yashna, for a vivid introduction. Can I start? Am I audible, clear? Can
Yes,
I share my screen?
Yes, ma'am.
Yeah, your screen is visible.
Okay, great. So good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this wonderful opportunity to be a part of this wonderful and unique, conceptually unique conference. At the beginning of my surgical career, I had the privilege of working at some of the premium institutes in the country and abroad. And having worked in these institutes, I always used to take resources for granted. Today, we are going to talk about how to manage oral cancer in resource constrained situations and can we still achieve optimum oncological outcomes in spite of having constraint of resources, which is actually a reality in our country. But having worked in these premium centers, I always used to take, physical resources for granted, only to realize later that something which is very basic for some resources, which are very basic for some, can be like a luxury for others, which I realized very much in when I was in Bihar in Mahavir Cancer Sansthan, where I actually, set up the entire department, trained several surgeons there. And now when I came to Jabalpur also, we are facing similar kind of resource constraints. But during my stint in Patna and till now in Jabalpur, what has come to my rescue has been my team. And believe me, if you have a dedicated team, if you yourself are dedicated towards the care of your patients and your team is dedicated, you can actually overcome all sorts of constraints and still produce world-class results, which we are doing currently. So this has been my wonderful journey with my colleagues, residents, and trainees. I'm extremely thankful to my mentor, Dr. Ashok Mehta sir, who was the first one to get me introduced to head and neck oncology and who actually got me exposed to the most wonderful and premium institutes in the country. where I saw the resource-rich situations, and I'm even more thankful to my mentor, Dr. Ravi Dev, who trained me in a way, and he always used to tell that, Preeti, you should be able to operate on a footpath and still produce similar results like how they produce in MSKCC. So this is, with this ideology, I was trained, and resource constraint actually is a reality in our country. We cannot shy away from that, whether we are sitting in any city of the country. Resource constraint is real, but at the same time, Indian frugality is also one of the examples, like how we could land Chandrayaan 3 at a very, very low budget. It was not even equivalent to half of Bollywood's, very famous movie budget. Another example, the real true example of frugality and cost effectiveness in the medical field in our country is the concept of Narayan Hrudayalaya. And believe me, this model is actually a model which is studied and is taught all across the world for its uniqueness. Look at what resources do we have at work. I always used to feel, and a lot of people think that money and infrastructure are the only resources that we have. But if you go closely and think a little deeply, you will realize that time, vision, ability, your skills, your teamwork, your willingness, your intent to treat the patient, your passion, your commitment, and your team's commitment, your persistence, your promptness in dealing with situations, and your patience, all these are actually your resources. And from the patient side, patient's involvement and willingness, his attitude, the family's attitude, patient's healing capacity, they all become your resources. Because by definition, a resource is something which is a source of aid which can be drawn upon whenever needed. And let's define what is a favorable patient outcome. A favorable patient outcome means your patient survives and survives disease-free and disability-free. That is called as a favorable patient outcome. And to achieve this optimum outcome, what do we need? We need correct patient selection, correct planning, a flawless execution of that plan. And if you see here, these two aspects, that is patient selection and planning, they do not require any kind of resources. So they are resource independent variables, except for the execution which happens in the hospital. You need some amount of resources there. Now let's have a look at a patient's journey, a journey of an oral cancer patient. Diagnosis of oral cancer does not require a massive armamentarium. You just need your keen eyes, keen observing eyes, and a well-trained mind to suspect. And to diagnose, you just need a couple of instruments like biopsy, forceps, good light, and that's good enough. You're done. Staging, a standard good CT scan, an average CT scan is good enough to stage oral cancers. In our country, most of the cancers, when they come, they are T3, T4. And we by and large, we know what our surgical plan is going to be. So you do not need any PET scan or any kind of very expensive scans to stage the disease. Then comes the patient selection. Patient selection for the modality of treatment which is being given, which is to be given to the patient, is largely decided by your clinical findings and your imaging findings. For example, for extent of bone resection, etc., etc. So by and large, even a student nowadays learns that these small lesions which are nicely resectable by local resection, they are very much resectable. However, one needs to know and understand when not to operate. It is very important to learn when not to operate, because if you start spending your resources on these kind of patients, you can technically resect everything and reconstruct everything, but that doesn't mean that you're giving a disease-free life to the patient. So if you waste your resources on patients, like if you start thinking that I will operate on this patient, yes, of course, you can resect the entire cheek and do something for reconstruction, like a huge AT or something. But remember, he has got a nodule here, and this is a metastatic phenomena. The day you the day you resect, in 15 days time, you will see his face totally studded with nodules. Similarly, this case. So you have to be little, intelligent in choosing the patient that you're wanting to choose. Now, this was a similar lady who had extensive skin and soft tissue involvement. We resected her, because she was very keen on it. She responded very well to chemotherapy, and we gave it a try. But look at what happened. She came back, started with nodules, and this was a miserable kind of condition. So experience teaches us when not to operate, and knowledge, experience, your method, and teamwork. This all leads to excellent outcomes and results. And all these do not require any major infrastructure or any major resource other than your brain. Now, planning of the treatment has to be in a multidisciplinary tumor board, like how we do here. This is an example of how we run our tumor boards, wherein your surgical plan, and when the surgeons are sitting planning the surgery, we chart out the incision plan, exactly how we are going to do it, how much are we going to resect, and how we are going to reconstruct. All these things again do not require any major infrastructure or any major resource here. It's all about man and mind. Then another very important thing that most of us forget doing is patient optimization. The day you see your patient in the OPD till the day the patient comes on your operating table, you must try and optimize your patient, correct his nutritional deficiencies, build up his strength, build up his lungs, and you can give simple homemade, you can advise on simple homemade high protein diet at home. Oral cavity cleaning is important, because the more the dirty your oral cavity, the more would be the chances of having fistulas and infections and so on and so forth. Building lung capacity is again very important, because these patients, they undergo long surgeries under general anesthesia. The lungs have to be good. So give them this toy to play. This is called as an incentive spirometer. Let them use this. Let them get their lungs strengthened, let their gut be better, let their muscles be better. So overall, when you improve the nutrition, give some supplements, they definitely respond very well, and they come up post-operatively, the recovery is good. Now finally you decide about surgery and your patient is coming on table. In the operation theater, there are certain non-negotiable resources, there are certain negotiable resources. All the physical resources, in my opinion, expensive gadgets, advanced energy sources, robot, laser, high-end cutting saws, etc., are negotiable resources. However, what is absolutely non-negotiable is your sterilization protocol. Your OT may be having very modest kind of an infrastructure, but the sterilization protocols have to be absolutely right. You should invest in a good cautery, because oncosurgeons, we do most of our work with the help of cautery. So cautery cannot be compromised. Good OT lights, good anesthesia workstation, a competent anesthesiologist is very important. Instruments for bone and soft tissues, whatever instruments are being used, they have to be standard. And then your patient has to be well prepared. There has to be surgical plan in place. Do not induce the patient and then start thinking, oh, which incision I should take. That is wrong. That is absolutely wrong practice. It is going to put you into trouble anytime. Then your surgical skills, of course, are the most non-negotiable asset that you have. Then, of course, your commitment, your teamwork, your staff should be well trained. All these things, they matter a lot in the final outcome of your patient, in your execution and final outcome. Now, a word about how do we do our surgical planning. Well, when you are planning in a surgery, along with your incision plan, we always consider what kind of reconstruction we are going to do for this particular patient. For example, a patient with a small area of skin tethering, we would generally include it in as an ellipse in our, or a crescent in our primary incision for the neck dissection and the primary, rather than putting a big circle and then thinking about, oh, how do I close it now? So if you have this much of planning beforehand, this skin, see, this is another crescent shaped excision here. Now the little mobilization of the chin on this side, and the patient gets closed very nicely and beautifully without any much hassle, and without the requirement for another flap or folding of a flap or having any kind of such hassle. So that saves your time, that saves your anesthesia, that saves a lot of resources saved. Another example, we did a radical maxillectomy for this lady and reconstruction by a temporalis flap and nasolabial for inner lining. because temporalis would take care of the palatal defect, and this fellow will take care of the buccal mucosa defect. She had a small buccal mucosa defect, not a big one. So a lot of mucosa was already there. So this is the maxillectomy defect. And see how we planned our nasolabial flap incorporated it in the same incision as the primary and the neck dissection. So if I had done a lip split here, then it would have been a big problem. How do I reconstruct? Then I would have taken a chest, a PMMC. PMMC would be bigger. Then you would want to do a prap, radial forearm. This lady was not fit enough for a radial forearm, so we resorted to this kind of a reconstruction, and this finally came very pleasant and beautiful. Another example of a lady who had no money with her. She was a scheme patient, had extensive N3 disease. The node was fungating from here. We had to do a PMMC with the DP combination. But when we planned our incision, we planned in such a way that everything gets incorporated in the same incision. And finally, you get a nice closure like this. Otherwise, you would start your case and then you think, oh, how I should take this flap up and how I should take this. So all this should be planned. So planning is extremely important. Then only you will be able to save your resources. Now, this case, you would say that it will make a very big defect. The bone was not involved, so we did a resection of the skin disease along with lip and reconstructed with a double transposition flap. Another elderly person with with a lot of comorbidities, wherein we couldn't have done an ALT for him. So we did double flaps. See, we took an incision like this in the neck and then continued it as a DP. So this flap gets transposed here, and the defect made here is filled with this cervico DP advancement. So if you put a little bit of your mind and you plan nicely, see, area resected. Now the neck flap goes here and the chest flap goes there, and nicely it closes primarily. There's no need to put an ALT. And over the period when I trained so many surgeons, I realized that the more you simplify your surgical steps, it easier it is to get transferred to the younger generation. So you must always keep thinking about how do I simplify this, like how cookbooks do. Our grannies, they used to cook wonderful food, but they would not tell 1 spoon of this or half a spoon of this. But if you make it objective, you can reproduce the same taste. If she puts half a spoon of something, you also put half a spoon of something, and you specify everything, then why you won't be able to create the same kind of outcome? Same goes for surgery. If you break down your steps, make SOPs for everything, it becomes very easy for others to learn. And the same thing continues in the younger generation. Well, practically all cancer operations are wide excisions. I always tell my students that cancer surgery is nothing but wide excision. But these wide excisions, to perform these kind of excision resections, see, you can see the skull base here, maxillectomy done, mandibulectomy done, ITF clearance done till the skull base. To do these kind of resections, you need tremendous amount of surgical skill, patience, and training, and lot of tissue respect, so that you do these kind of resections in a nice bloodless field, and your instrumentation should be such that your tissues, they look nice, moist, and smiling, rather than looking red and feeling, you get a feeling of how badly the surgeon has operated. Looks like somebody has operated in a hurry, or was not in a good mood, or was not a well-trained surgeon. So you must take care that your field is nice. If you produce this kind of, you compare these two fields, this field versus this field. We have done it very nicely, patiently, preserving all structures. This is the external jugular vein, the greater auricular nerve, the spinal accessory nerve, the branches of the cervical plexus, omoid, everything has been preserved, and with removal of all the fibrofatty tissue and the lymph nodes. And that's how your field should look like. Then you will get pleasant results. Now coming to reconstruction. How do we optimize our resources when we are doing reconstructions? It is important. We all understand that doing microvascular surgery is a little more expensive. However, we always do it whenever it is absolutely necessary. But for smaller and medium-sized defects, you can very well do away with good local and regional flaps. And mastering them is extremely important and a non-negotiable step if you want to optimize resources in reconstruction. For lateral oral defects like this, one can always resort to doing good bipaddle PMMC flaps. You can see the result here. Another patient with a massive through and through defect here, but reconstructed with the help of a PMMC. This guy was, we did an ALT. Just for a comparison, I'm showing another case where we could do an ALT because we had the resources to do it. And I compared the result. This is the ALT pre-flap. This is PMMC. If you see occlusion here is nice, occlusion here is also nice. So practically the outcomes remain the same. However, yes, PMMC has a little bit of chest deformity, little bit of shoulder dysfunction, but you don't have to deny patient to surgery just because he's unfit for a major procedure or your resource constraint here. Another example of an extensive disease of the maxilla, more into the skin and soft tissues. Total maxillectomy with removal of the floor of orbit, everything has been resected. And this is the kind of specimen that we remove. And this reconstructed with a nice PMMC flap. This is a follow-up of the patient. She is quite acceptable. So these kind of defects wherein you would otherwise you would have wanted to do an ALT can also be sometimes in the resource constraints, you can always do a PMMC for them. However, for such big lesions, for such advanced lesions, if you want to resect, you have to resort to an ALT flap. This was a very massive defect. We did an ALT, and fortunately, this guy is living even after 3 years of surgery. He's perfectly fine. However, we were expecting little adverse outcome in him, but another example where we did an ALT is left buccal mucosa defect along with involvement of the lip. So we resected lip, we resected both the upper and the lower lip, entire cheek skin. And this is how the final outcome was after the healing of ALT flap. Now, for certain central arch defects, you have to do a fibula. So I'm not saying that you should not perform pre-flaps or microvascular reconstruction. You must, but if you are resource constrained, think, just make your imagination go, let your imagination go a little wider and think, if I can I manage this with something else? Especially if you are not doing it yourself, you are hiring a plastic surgeon or somebody, then another team is involved, so more money, more infrastructure is involved, and so on and so forth. So for these kind of central arch defects, we always have to resort to these pre-fibula. So we did a pre-fibula for this lady, and that's how she looks. While doing microvascular also, if you are resource constrained, you should learn and adapt to using loops rather than a microscope. If you do not have a microscope, there's no need to deny microvascular surgery. We operate equally under both microscope as well as under the loops as the situation dictates. Another example wherein there was a tongue defect. This was the kind of defect this guy had. We would have easily recommended a radial forearm, but we could do away with a nicely taken nasolabial flap, and that's how the patient looks like. We cannot forget mentioning our good friend submental flap, a parotidectomy performed and covered with skin cover given with submental flap. Infrahyoid flap is an excellent flap for defects of the ventral tongue and floor mouth, because its reach is nicer if it is in the lower part of the oral cavity. So this is an example of an infrahyoid flap. This nicely replaces the radial forearm in floor mouth lesions. Now coming to complications. First of all, if you are wanting to operate in resource constrained situations, you cannot afford to have complications, because the management of complications can sometimes suck away all your resources. So, but complications will happen. So what to do? So first thing is expect complication in patients wherein you know that this guy will get infected, or this guy is low on protein, or this guy this flap vascularity is a problem. So as far as possible, try to prevent. However, if you could not prevent, expect it. When the patient gets symptoms, suspect little redness along the margin of the flap, little blackness around the margin of the flap. Identify it, accept that there is a problem, quickly look for solutions and act. Then only you will be able to salvage the situation. And if you, the longer you delay the handling of these complications, the more will be the pressure on your logistics and your resources. And of course, you must audit your outcomes once in a while, because this is what keeps us going. This is what makes us learn from our own mistakes. This is my teacher who taught me that the only way to make redness surgery cost effective is avoid having complications. Well, this was all about training the hands, but as the hands get trained, the mind also should get trained. So you have to master your science. It's not just about practical, it's about a lot of theory also. This will teach your mind when to operate, when not to operate, what is comprehensive management, what should be done when. So to conclude, in my experience of about 23 years, I have learned that a modest setup with a committed team is sometimes more resourceful than a well-equipped center lacking the above. But however, striving for better resources must continue. We must look for better options, better machines, better equipment, better OT setup. Everything should be made better, but without compromising on the patient's outcomes. Thank you very much, ladies and gentlemen, for your patient listening. Thank you.
My heartfelt thank you to you, ma'am. It was a very, very insightful and fantastic lecture, I must say, one of the best in the sessions till now. And your passion towards treating your patient was clearly reflected through your lecture. We also have a trainee here. I can see his pictures there, Dr. Sunil Gulia. He is working with us in oral surgery department, and he is trained by you, and it shows clearly the way he treats the patient. We call him many times to our department for early oral cancer patients and also for advanced cases. So he is a big help to us nowadays, and we are blessed that you have trained him so well. And it was a great lecture, ma'am. Seriously, it was worth listening to. And if anybody has any questions, you can ask ma'am, and we can continue with the session after that. If anybody has questions, you can put it either on the chat box or you can ask ma'am directly.
Thank you very much.
Thank you, ma'am. Thank you. I know you have a busy schedule, so thank you so much, ma'am, for sparing your time and being with us for last 30 minutes. And it was
My pleasure. My pleasure.
Thank you, ma'am.
All right. Thank you so much. Bye.
Thanks. Thanks, Dr. Priti, for sparing your times in the mid of a surgery
Thank you
and
so much.
giving your precious time to us.
It's a pleasure.
Thanks.
Pleasure
Yeah,
is
yeah.
all mine. Thank
Okay.
you.
Okay.
Bye.
Okay. So there is an announcement. The Dr. Gaurav and Dr. Sakti Deora, because now we are getting the speakers who are surgeons actually.
Yes.
And I try to reach both of them. Dr. Gaurav is not reachable. I think he would be busy. And Dr. Sakti Deora, he is saying that in a WhatsApp, he messaged that he would be joining in another, say, 1 hour actually. And his attendant has picked the phone when I called him. He's saying that he is busy in OT. So then we have Dr. Natasha Lalwani. She would be joining at 3:40. So it's 1 hour a time between. So I'll try to request Dr. Natasha to join early. Otherwise, it would be a break for say 30-40 minutes break.
Right.
So yes. We have taken the speakers approval or everything in the email rather than WhatsApp to make it more firm actually. But still, because these are the surgeons and they are, they have to go to, RTI, road traffic accident, etc. So they are on call surgeons, and also that's why sometimes it's difficult for uh, to let them available actually. So this is the issue actually. This is the first time we are facing, but they will join. I mean, the speakers would be coming, but the time is a constraint actually. So we'll take a half an hour break, and we'll join again. I'll, I would request everybody to join at 2:45. No, so it's a 3:15. I'll try to request Dr. Natasha. She can come early, and she can start her presentation. Afterward, there Dr. Kehinde, he would be joining from UK, and I have spoken. He is joining within an hour. So Dr. Natasha, then Dr. Anjan Shah, then Dr. Shahida, then Dr. Divya, they would be joining on their turn and all. So this is the announcement from our side. Please join in another, say, half an hour.
Okay, sir. Okay. Thank you so much, sir.
Thank you.
So we'll get back after half an hour. I'm busy.
अरे ये कैसे गाना चला रखा है यार, दुखी दुखी से छोटी बजा है, मेरे फोन से बजने चाहिए। पता क्या कर रहा हूँ तुम्हारा?
किस दुनिया में रहते हैं, अब कुछ भी न कहते हैं, काफी दिनों से तेरी खबर ना आई। दिल को तो हम मना भी लें, किसी और को बसा भी लें, पर कैसे तुझे मैं भूलूं पिया मेरी।
Dr. Natasha, I have seen that you joined in. We were waiting for the two speakers who supposed to join. They couldn't join us. One was Dr. Gaurav Singh and another was Dr. Sakti Singh Deora. Both of them are busy doing some surgeries and all. I have spoken to their attendants and they are saying that they would be joining for a short while. So they requested to postpone their sessions for say 45 minutes to 1 hour. So now you join in. Just I'm writing an email to all my participants to join in under say 10-15 minutes. So with our database, we'll just writing email to everybody and we'll start our sessions in another 10-15 minutes. Just wait for a while. Are you there, Dr. Natasha?
So all good afternoon again, and welcome you again, all delegates. Sorry for the inconvenience. Our three speakers who supposed to give their presentation, they are oral surgeons or onco surgeons, so they are not able to make on a time. Actually, they are busy in their OTs actually. So their emergency surgeries came up and they are not able to join. So now we have speakers with us. Dr. Natasha is joining in a short while. Dr. Kehinde is already joined, and Dr. Ramya is also joining. And then we have all the speakers who will be joining on time and will allow one by one everybody to present their presentation. You would be hearing a sound, background sound, because today is a polling day, as I told in the early morning, and results declared, and BJP has won the elections. So the people around us is enjoying the victory actually. So we are getting a noise from background. So we are just waiting for Dr. Natasha to join, and then she will start her presentation. We have already emailed to all subscribers, all IOCCONians who are registered with us. They have received the same message through email that we are rejoining at 4 o'clock. So we are just about 1 or 2 minutes to go, and then we'll go as a regular sessions. So the first speaker would be Dr. Natasha Lalwani. After that, Dr. Ramya R would be the second speaker, and then or Dr. Kehinde will join. So we'll see how we go, because there are two speakers who lagged and now they are available. So we'll see how we'll go. But I'm pretty sure that everybody will give the time, and the session will elongate a bit in a late evening. But let all speakers join in and put their views on the latest in oral cancer. Thank you. I request Dr. Punita, could you please, communicate our distinguished moderators if they are available in meeting room to introduce the speakers. Otherwise, maybe I would be introducing the speakers. Thank you. Dr. Punita, could you unmute your microphone? Am I audible to you?
Hello, good afternoon, all. So, we are back after a small break of half an hour or so, and we'll be continuing our sessions henceforth. And I think our eminent speakers have already logged in. And Dr. Sakshi, you are there?
Yes, ma'am. I'm here.
Yeah. Can you please introduce our next speaker of the session?
Yes, ma'am, sure. I think Dr. Natasha is not here still.
Dr. Punita, let us take Dr. Kahinde. He is available. Fortunately, he is available. He joined on time actually. So without waiting time, Dr. Kahinde, can you unmute and can you present right now? Because we have 2-3 speakers here.
Okay.
Very good afternoon to you, sir.
Yes, ma'am.
Now, Dr. Samriddhi Agarwal is going to introduce you to the gathering, and then you can continue ahead with your lecture, sir. Samriddhi. Good afternoon, sir.
Yes, ma'am.
Yes, sir. Sir, I'll be introducing you. Professor Kahinde Kanmodi is a public health scientist and a dentist with over 10 years experience in scholarly research, teaching, postgraduate curriculum development, thesis supervision, and leadership in public health. He attained a professional rank at the age of 33, and he is currently the Director of International Engagement at the Faculty of Dentistry, University of Putisatra, Cambodia. Professor Kanmodi has co-authored over 290 scientific publications and he has been cited over 4,000 times. Professor Kanmodi is a recipient of multiple competitive age grants and he is an editor or reviewer to over 30 international journals. Professor Kamodi has served on several committees, panels, boards established by several international organizations, including the WHO, Cochrane, and Science for Africa Foundation. It's very pleasure to meet you, sir. Over to you, sir, for your lecture.
Thank you very much, ma. My network went off, so I was disconnected, so I was trying to reconnect. So I want to share my screen now.
Right, sir. Right.
I'm so sorry. I'm trying to share my screen. Okay, document. Yeah. It was showing that I should share. I've sent my slide earlier. Can it be shared from your end so that I can present over it?
Right, sir. Right, sir.
Okay.
Just wait for a while, Dr. Kendi. Let me see my team would present share your slide. Just hold on.
Okay.
Slides are visible?
Okay.
Yes, sir. These slides are.
Okay.
Yeah. Can I start now? Yeah. My name is Kainde Komodi. I'm a professor at University of Kutisastra. The title of my keynote lecture is entitled Bibliometric Analysis, a robust approach for appraising international research engagements in oral oncology. In the next slide, please. Can you go to the next slide?
Wait.
Okay.
Slides are moving?
Yes. So the table of content are as follows. I'll first discuss about bibliometric analysis, the definition and its importance, and discuss about the definition and global burden of oral cancer, and also where we are concerning global oral cancer eradication. Then we also talk about international research engagement as a key tool for global oral cancer eradication, and also the key findings and policy implications concerning existing bibliometric analysis on international research engagement in oral oncology. And also I also conclude and also be able to answer some questions as time permits. Please, the next slide. Yes, bibliometric analysis is a rigorous study involving the use of mathematical and statistical methods and bibliographic or scientific data to measure the patterns, trends, relationships, and impact of academic literature, researchers, institutions, and countries. When I talk about bibliometric or scientific data, I'm referring to like author names, journal names, manuscript title, keywords, institutional affiliation, country affiliation, founder, and the likes, and year of publications, those general bibliographic information that we use in referencing manuscripts and use for metrics. Some of the benefits and importance of conducting a bibliometric analysis include, for instance, one of the benefits is to assess research outputs of authors, institutions, and countries, to look at the volume and the quality of research outputs from authors, their institutions, and their countries as a whole, and to be able to use it to compare, and also to identify key authors. Okay, among the authors that have, or institutions and the likes that have published research in these particular topics, who are the key authors? I mean, like the most productive in terms of volume of publications, or the most influential in terms of the volume of citations they obtained concerning their manuscripts. So, like to identify key authors, key output, research hotspots, and trending topics. So in some topics, in some subject areas, some topics are trending. Like in our present day now, in the aspects of information technology, AI, artificial intelligence, is one of the most trending topics right now. So things like that. So how to identify that AI is the most trending topic is through bibliometric analysis. So mapping knowledge networks is also known as science mapping. We look at international collaboration, local collaboration between institutions, countries, authors, and the likes. So that's science mapping, and to look at connection between keywords. And also, one of the benefits is to develop strategies for science diplomacy. If you look at now, many countries now are now having science policy advisors, science diplomats, science policy officers. As far back as about 2 decades ago, the European Union made the policy that their consulates, their embassies, national government should have science diplomats, either in their, I think maybe in their Ministry of Science and Technology. Like for instance, the recent agreement, I think as far back as the past 2 years, between India and the UK, for instance, they signed partnership on, I think, technology, like maybe robotics and the like. So those are some aspects of science diplomacy. And when they want to implement that, bibliometric analysis may play a key role, like to look at which institution in India is the hotspot for AI research, robotics research, and which institution is the hotspot for AI and robotic research in UK. So that can stimulate effective collaboration. Please, the next slide, please. Yes, so I'll now talk about the definition and global burden of oral cancer. Actually, there is, let's say, dichotomy, like the lack of consensus globally concerning the proper definition of oral cancer. But according to so many leading organizations in the world, like Center for Disease Control, WHO, and in fact, in the UK as well, oral cancer is defined as a malignant neoplasia of the mouth, the lip, and the oropharynx. In some places, they say it's just the oral cavity. No, according to WHO, according to CDC, and according to the UK, their statistics, their agency for cancer and the national statistics like that, they classify oral cancer as neoplasia or cancer of the mouth, the lip, and the oropharynx, and it applies like that in some other countries as well. So the burden of oral cancer is so enormous, and in 2022 alone, that's roughly 2 to 3 years ago, about 389,846 people were newly diagnosed of the disease, while about 188,438 people died of it, according to Fale et al. 2024. The next slide, please. Yes, global oral cancer eradication, where we are. Where are we exactly? Over the years, several public health efforts have been put in place to tackle the global oral cancer burden. Unfortunately, these efforts have not effectively eradicated the global oral cancer disease burden. Actually, that's true, because the burden of oral cancer globally in the 1990s and now it has skyrocketed. And that's not the case for childhood diarrhea disease. That's not the case for malaria. That's not the case for maternal mortality. That's not the case for life expectancy. For those ones I mentioned now, there have been obvious improvement over the years. And also, but for oral cancer, it has been getting worse. It has been getting worse. And according to several organizations, like Oral Cancer Foundation in the US, it was projected that maybe by 2030, oral cancer may overtake cervical cancer. And in fact, the leading cancer in India, for instance, is oral cancer. The leading cancer, especially among men particularly, the leading cancer in Sri Lanka is oral cancer as well. So the slowly progressing eradication efforts calls for a need for global reflections on the failures concerning oral cancer eradication efforts. Meanwhile, we are noticing progress being made concerning breast cancer eradication. So, but for oral cancer, it has been a bit slow and not so encouraging. The next slide, please. Yes, international research engagement, a tool for global oral cancer eradication. Yeah, a key tool for global oral cancer eradication. Oral cancer is a disease with multifactorial etiological factors ranging from genetic factor to sociocultural factors. Some of the sociocultural factors are economic issues, which is part of a social issue in a way, like poverty, hunger, malnutrition, and also war too is a sociocultural, is a social issue too in a way, because it's a social science problem, because war makes people to have limited access to cancer care, to cancer preventative interventions, to cancer care, treatment and diagnosis and the likes. So additionally, the prevention, diagnosis and treatment, which also includes rehabilitation of oral cancer, heavily relies inter alia on biological, psychological, sociocultural, political, and technological factors, which is very, very important. We need technology for diagnosis, like for instance, in the treatment of oral cancer, like transpharyngeal surgeries now, where Da Vinci robots is being used for robotic surgery. So all those is not all countries have access to such kind of minimally invasive technology approach to treatment of oral cancer, and the like. So the socio-cultural issue like poverty and like the political aspects, which is also aspects related to war, places that are ravaged by war. Like for instance, research has shown that people in Syria, they have limited access to cancer due to the war in Aleppo and the likes and instability across different parts of the world. So there are the places in the world that are worstly affected by oral cancer. I mean cancers generally, which oral cancer is inclusive. The psychological factor is also part of it, because when people are depressed, they tend to have lower immunity, and the anti-cancer genes, the chemoprotection from the body against cancer tends to be depressed. So those are factors that plays a role. The above identified factors are most probably accountable for the slow progress made so far on global oral cancer eradication. The next slide, please. Yes, international research engagement, still on that. The enormous complexity of the preventative, the diagnostic, and the management aspects of oral cancer makes it one of the diseases that is most notoriously difficult to eradicate in this current century. To eradicate oral cancer, it will require a well-concerted global effort where institutions intentionally, is not just haphazardly, they need to have intention, like the way we say in politics, the political will, the intention to collaborate to fight the disease, which is the oral cancer we are talking about. The next slide, please. Fortunately, the world has been able to eradicate some diseases in human history. Typical examples are polio. Like, for instance, within the past 4 or 5 years, Pakistan, India, Nigeria, and I think Afghanistan, they were called PAN countries. I think after that, India went, then became PAN, Pakistan, Afghanistan, Nigeria. So those are the countries that were the last places to completely eradicate. And the one for India is understandable. India is over 1.4 billion people. That is a huge population. So, so it was eradicated recently, so within the past 10 years ago. So these are, and also Guinea worm, for example. So these are diseases that were eradicated through synergy and concerted efforts among all nations of the world, of which research-based institutions played a major role. The global successes with polio and guinea worm eradication indicates that oral cancer can also be eradicated. The next slide, please. Yes, unfortunately, international and multidisciplinary collaboration between universities on oral cancer is very poor. For example, many dental schools work in silos. Sometimes research from our dental institutions, sometimes even within the same university, they tend to collaborate less outside the dental school, like collaboration between school of maybe faculty of social sciences, maybe between sociologists and dentists. The collaboration in that aspect is very low. Oftentimes, dentists collaborate within their university, like maybe people in prosthetic dentistry collaborating with oral maxillofacial surgery. The collaboration with people, researchers in humanities, in technology, is very low compared to some other fields. So these are some of the challenges we are experiencing when it comes to global oral cancer research and eradication. International research engagement plays a monumental role in disease eradication efforts. Through such engagements, oral cancer researchers can access diverse expertise and perspectives from different geographical, cultural, and academic backgrounds. Like, for instance, the way things have been done in India, for instance, may be slightly different from the way it is being done in UK. It can be slightly different from the way it is being done in Cambodia. It can be slightly different from the way things are being done in Rwanda. It can be slightly different from the way things are being done in the United States. So when there is international collaboration, people tend to exchange ideas and share best practices on how to improve clinical care of patients on oral cancer. So those are some of the benefits of international engagement. And it also increases access to funding opportunities. So those are some of the opportunities we tend to get from international research engagements, especially in the field of oral oncology. And it also improves research productivity, visibility, and global impact. Because when research involves people from different geographical areas, it increases the robustness of the study and tend to increases the global impact and the quality of the research and the visibility. The next slide, please. There are many success stories on the internet on how international research engagements on oral cancer has enormously contributed to global oral cancer eradication efforts. Below are just a few examples, as you've seen on my screen: Consortium for Head and Neck Cancer in Africa, of which I am a member, and also Asia Pacific Oral Cancer Network. So these consortia, they were established for eradicating oral cancer, one in Africa, the other in the Asia Pacific. And this group, they've done quite a lot of significant research, which has in a way contributed to efforts towards eradicating oral cancer in their region. So these are just key examples, just some few examples. We have much more than that, but I just identify these examples because I'm familiar with these two consortia, because I'm somewhat familiar with both of them. The next slide, please. Yes. Bibliometric analysis on international research engagements, still on that. Now I want to talk about the key findings and policy implications. Unfortunately, bibliometric analysis on oral cancer, where international research engagements were investigated, are very sparse. This makes it difficult for developing global strategic directions and partnerships towards oral cancer eradication. Based on my systematic search, some days ago, I did a systematic search. I think that was on the 6th. Yes, using the search string. I should have put the date. I did the search on the 6th. Using the search string, bibliometric analysis and oral cancer. I used title because to make it focused and very specific. Only 7 bibliometric analyses on oral cancer are available on PubMed, with the oldest paper published in 2017. This is very, very deeply concerning because other medical topic areas have their oldest bibliometric analysis several decades ago. E.g., look at, for instance, adverse reactions, which is under the field of pharmacognosy, pharmacology, the pharmacovigilance, those aspects of pharmacology. They've published research on adverse reactions as far back as 1977. That is several decades ago. And on kidney, for instance, was in 1996. That was close to 30 years ago. Then on tobacco use, that was more than 20 years ago. So meanwhile, for oral cancer, we are having our first one in 2017, which shows that we oral cancer researchers, policy advocates, oral cancer stakeholders, we are lagging behind compared to other aspects of health topics, health matters, in terms of research efforts, collaboration, and the likes. Can we see the next slide, please? Yes. So, in continuation to that, out of these retrieved 7 bibliometric analysis papers on oral cancer, which I got from PubMed, I would like to identify and discuss 2 of them, where international research engagements were adequately explored. Simply see below. One was in an MDPI journal, the other one is in Springer Journal, Curious. The other one is in Current Oncology. The title of the first one is Mapping the Scientific Landscape of Bacterial Influence on Oral Cancer, a bibliometric analysis of the last decade's medical progress. Then the other one is bibliometric analysis of poor oral health as a risk factor of oral cancer. So that is, sorry, please give me a few seconds. Okay. Let me just slide that. So, yeah. The next slide, please. Yes. These 2 articles were co-authored by Hu and Lim in 2023 and Mauli Senior et al. 2023. I will explain some of the key findings of these articles and their policy implications. This explanation, I'm going to explain them. This explanation will also provide further emphasis on the huge importance of bibliometric analysis in building international research engagement strategies on oral cancer research. The next slide, please. The article by Hu and Lim in 2023 analyzed oral bacteria and oral cancer as a research topic and found that Harvard University is the most productive university on the topic area, and that the top 10 most prolific institutions on the topic are in the USA, Finland, and China. And also the top 10 most prolific countries are China, USA, India, Finland, Japan, Taiwan, Germany, Australia, England, and Sweden. What can we learn from this? is that, for instance, maybe I'm a, for instance now, maybe I'm a oral cancer researcher in, let's say, Savita University, or let's say Jawara Nehru University now, let's say it has a dental school. And now I want to look for, and I'm interested in oral cancer and oral microbiome. I want to look at the relationship between oral bacteria, oral flora now, and also oral cancer. And I need to collaborate with people that maybe they have more experience than me in research. And maybe I want to look at a different population. The majority of the population in India are Indians. Maybe I want to look at maybe Caucasians, maybe in the United States. Maybe and I look at, okay, which university have expertise? Okay, Harvard. Okay, because bibliometric report has shown that. So I can contact maybe the dean or the head of department of oral microbiology or the likes, then contact them that I would like to work with their researchers that are expert in oral bacteriology and oral cancer and oral oncology. So that's the benefits of bibliometric research. And also the top 10 most prolific institutions on the topic area. Like, for instance, if one wants to collaborate with, maybe do multi-center studies now, I can say, okay, India is one of the most prolific countries in terms of oral bacteria and oral cancer research. Let me do multi-center study collaboration with researchers in India, since India is a hotspot for research on that topic area. So it means that I can easily get experts, I mean world-class experts that I can collaborate with in India or in Japan or in Finland or in Sweden or in England. So that's the benefits of bibliometric analysis. The next slide, please. The article by Mahuli Senior et al. Analyzed poor oral health and oral cancer as a research topic and found that Professor Saman Wana Pulasuriya, who is in King's College London, is the #1 researcher globally on the topic area concerning poor oral health and oral cancer. And also United States, United Kingdom, and Switzerland are the top 3 countries producing research papers on the topic area. And also Oral Oncology Journal is the #1 journal globally with the highest output on the topic area. It means that from here now, if now, for instance, and I think Professor Wana Kulasuri, I think that's a Sri Lankan name, most likely is from Sri Lanka. So maybe I contact him, I want to do a study in Sri Lanka, I can easily contact him that, Professor Saman, please, I would like to do a study with you on this. So leveraging on his network, I can easily contact researchers in Sri Lanka. That's for example. And also, for instance, I want to do studies maybe multi-country, and I want to go to the countries where I can easily get expert. I can easily go to United States, United Kingdom, and Switzerland. Or maybe I want to retrieve literatures that are very, very relevant, very authoritative. I can go to oral oncology because they have the highest output in the topic area. Or maybe I want to subscribe to a journal in that field. I can easily subscribe to that journal because I have first-hand information that they have the highest output. So these are some of the benefits of bibliometric analysis in terms of international research engagement in oral oncology. The next slide, please. Overall, the findings highlighted from the articles by Yuan Lin and Mahuli Senior et al. Have provided insights on the places to consider if an institution or researcher wants to seek expert collaborations concerning oral bacteriology, oral health, and oral cancer. Also, their findings also identify those countries that are not research active on those topic areas, exposing areas of missed opportunities. Actually, those are areas of missed opportunities. Let's say in a continent or in a country where they don't have any research at all on oral cancer. You can look at it that this is a gray area. You want to apply for funding in global health. You can reach out to researchers in those countries and contact them that I want to apply for an NIH funding on global health or NIHR or a funding in India from Medical Research Council in India. I think they give funding too. So you can say, I want to reach out to apply for grants in those institutions that I would like to do a global health research in those countries that they don't have research topics on those areas. And in global health, those are the areas that easily catch attention. When you are doing a study that is novel, that is going to get impact, that is going to be like first of its kind. So those are some of the ways of increasing chances of winning research grants. So those are some of the benefits of bibliometric analysis. It is difficult to just go online and identify those countries without doing a bibliometric analysis. So those are the benefits of bibliometric analysis. And all these have implications on policy. The next slide, please. Bibliometric analysis on oral cancer, where international research engagements are reported, can help universities, research organizations, and dental colleges develop effective strategies that can be used to establish robust, strong, and topic area-specific collaborations on oral cancer across the planet. With well-laid out strategies, universities, research organizations, and dental colleges interested in oral cancer research can develop effective policies that will help them achieve their research goals on oral cancer, which will invariably help in the global oral cancer eradication efforts in the long term. The next slide, please. Conclusion. Yeah. Bibliometric analysis is clearly a robust and strategic tool that can be used by researchers and institutions in identifying how they can navigate their international research engagement goals and strategies concerning oral cancer research. As scientists, policymakers, and practitioners, we need to acquire advanced research skills to conduct robust bibliometric analysis. This will equip us with the strategic skills needed for tackling the global oral cancer problem we have in our present day. The next slide, please. Those are my references. Next slide. The next slide, please. Questions and answers. Thank you very much for your listening. Namaste. And thank you.
Thanks, Professor Kehinde, for throwing light on bibliographic analysis of oral cancer. Anyone who want to ask question from Dr. Professor Kehinde, you can. Questions are most welcome, or you can ask the question in the chat box. And how to start with bibliometric analysis? The question asked by Dr. Ahalya Sagiraju. There's in the chat box.
Thank you very much, Dr. Sagiraju, for the question. Yes, a way to start with it is that there is a paper by Dontu et al. What I can do is that maybe I can drop my email in the comment box, or I can send the documents to Dr. Anwar so that I can share it with you. Yeah, there is a paper that talks about how to conduct bibliometric analysis. So it gives like a step-by-step approach. And also a way to also learn it is that because bibliometric analysis is a different, kind of a slightly different research methodology. So the analytical softwares are different. Like for instance, the software, I've published close to 10, if not more than 10 bibliometric analysis, and many of them in Q1 or Q2 journals. So a way is that you can use this software, VOS Viewer, is a software for scientific mapping. Bibliometric analysis is in two parts: the performance analysis and the science mapping. The performance analysis, you can use Microsoft Word, Excel, or you use the analytic tool of Scopus for it. Or for science mapping, you use VS Viewer, or I think SiteFactor. I've forgotten the name of that other software. So if you need more information on that, maybe let me drop my email in the comments box. Maybe you can chat me, you can send me a message on that. Okay. Yeah. So that's my email. I can send you can send me maybe hi or hello on email, so I can send you documents that I think will be helpful. Actually, bibliometric analysis, I learned it on my own. So you can also learn it on your own. So, and if you are experiencing maybe difficulties, I'll be very glad to create some time to put you through on that. Thank you, sir.
Thanks, Dr. Kehinde, for joining us. You shifted from, I think, UK to Cambodia. You have changed, your university is changed actually.
Yeah.
So when did you change? It's just 6 months back. Dr. Ruwan was telling about when we are looking for you because you were a speaker in our last edition as well. So
Yes,
we have
yes.
using your previous designation, but he said that you have changed your organization.
Yeah. Yes, I've been with Cambodia for like 2-3 years now, but I am getting more engaged. So hopefully by June, July, I'm relocating fully to Cambodia. My family is still in the UK, so but in some couple of months' time, I'll be in Cambodia fully.
Okay.
Yeah.
Nice, Dr. Kehinde. Yes.
Yes, sir.
If there is any question, you just look at means on a chat box. There might be you can answer there only because there are 2-3 speakers who are busy in doing surgeries and all. So that's why we are lagging, and the 2-3 speakers, we have supposed to give them time right now. So we are running short of time. Sorry for that. We are moving to the next speaker with your permission.
Okay, sir.
Yeah. Okay. Dr. Natasha, are you there? Could you please unmute your microphone and open your camera? Yes.
Yeah, I'm there.
Yeah. Your colleague, Dr. Shakti Singh, is also not, available. Means his, surgery is being done. He is free from OT or still he is there?
No, actually, I am in Ahmedabad. He is in
Okay.
Sumerpur.
Acha. Okay. So let
I
me.
was occupied elsewhere. He is occupied elsewhere.
Yes, yeah. Okay. So let me introduce you formally, Dr. Natasha. I'm just giving a brief introduction because we have lost our time due to unavailability of speakers. I'm just giving your introduction in nutshell. If I'm leaving anything, you just add on. Dr. Natasha Lalwani is experienced and highly proficient head and neck cancer surgeon with over 9 years of dedicated practice in oral oncology and microvascular reconstructive surgery. Her expertise include performing complex cancer resections, reconstruction, utilization, loco-regional flaps, and advanced microvascular free flap reconstruction technique to restore both functional and aesthetics, ensuring optimal patient outcome. With a career spanning of over 1,000 successful surgeries, recognized for a meticulous approach to treatment, blending technical precision and innovation surgical solutions, committed to delivering comprehensive patient-centered care for by addressing not only the disease but also the physical, emotional, and social well-being of patients. So if I missed anything, I'm just giving a brief introduction. You can add on and you can start your presentation. You share your slide. Yeah.
Yeah, that is more than enough. Thank you. Thank you for the intro. So I hope my slides are visible.
Yeah, your slides are visible.
Okay, you can see, right?
Yeah, it's visible.
Okay. So good evening, everyone. Namaste. And let's start with the presentation. The topic for my presentation today is realms of reconstruction oral cancer and what are the factors that govern the choice of reconstruction. So the arena of reconstruction is very elaborate and we will see what all are the options available and what are the factors that govern the choice of reconstruction. I'm Dr. Natasha Lalwani. I'm head and neck cancer surgeon and I practice in Ahmedabad. So before we come to realms of reconstruction, we should first know why we need to reconstruct, when should we reconstruct, and how to reconstruct. So why reconstruction is necessary? So we are talking here in regards to oral cancer surgeries. So whenever we perform any ablative oral cancer surgery, it leads to debilitating defects in terms of function, cosmesis, and nutrition, because and as a result it has huge implication on physiology, psychology and nutrition of patient. So we cannot just leave the area raw, the resected area raw. We need to reconstruct it, because otherwise, it might lead to exposure of vital structures. It can also result in impairment of routine daily functions like speech and swallowing. Aesthetic disfigurement is, of course, one of the main concerns for patient. And uh, 4 days back, it was World Cancer Day, and the theme was United by Unique. And everyone was talking about how the approach should be patient centric and how we should focus not just on treating the disease but patient as a whole. So nowadays focus is not just on treating the disease only, but we need to look at quality of life as well. As it is rightly said that we don't have to just give them years to live, but what is the quality of life in those years, that is even more important. So that is why we need to reconstruct the resected part. So yes, it is, especially in head and neck region, it is very challenging. Why is it challenging? Because it is a very anatomically complex area. Mouth is the mirror of body, we say. And this area plays very, very crucial roles. It helps in speech, it helps in swallowing. It is very important aesthetically. Below head and neck, people would be okay with certain adjustments. But when it comes to your oral cavity and face and neck part, aesthetic becomes quite a major concern for patients. They have fear of surgery because of this only, because they will not be able to be a important social uh, part of culture and society after surgery, because they think that there will be significant aesthetic disfigurement. So with the reconstruction, what is our optimal goal? The goal is first to provide the optimal cancer treatment. Because we have reconstruction options and we have certain limitations in reconstruction, that does not mean that we have to compromise our resection. The first and foremost goal is to provide adequate resection. And next comes reconstruction, and the goal should be to restore form, function, and maximize the quality of life. Quality of life, not just life. So it can be quite challenging in head and neck area, but the intention should be to provide reasonably well aesthetic function and form which can correlate to their pre-operative period. So if you can maintain competence, if you can give them decent in spite of such big resection, if you can give them reasonably okay aesthetics, still it might be okay. So what is the goal of reconstruction? Whatever we have removed in resection, we have to restore that. Most important being function. So our concern should be that there should be post-operatively no drooling. We should minimize risk of aspiration. We should aim to provide significantly proper speech. So we need to restore function. Of course, we need to restore form. And we also have to create barrier between the cavities that has been created as a result of reconstruction, so that there is no communication like oro-nasal communication, oro-cutaneous communication. So there should not be communication between the two cavities which are meant to be separate. And of course, finally, if we are talking about quality, then facial reanimation and dental rehabilitation. When should we reconstruct? Ideally, whenever we are performing the resective surgery, resection should be done at the same time. Immediate reconstruction will also prevent further fibrosis and retraction of the defect. So second stage reconstruction is not usually advisable, and it will allow timely implementation of adjuvant therapy. So immediate reconstruction is usually the norm. Unless it is absolutely contraindicated, delayed reconstruction is can be considered, but usually it is not required these days. Now, how to reconstruct? Here comes the topic proper. There is a huge realm of reconstruction. There are various flaps which can be your friends, your server. How to use them? That will come in the session of factors affecting governing the choice of reconstruction. So a very brief about evolution of reconstruction. So realm means the domain kingdom. So there are always domains in kingdom. So similarly in reconstruction also there have been eras. Early era was of primary closure. There was use of skin grafts and dressings and such things. Wounds were left behind for secondary closure by granulation. Then came the era of regional flaps. So there were various local and regional flaps which were utilized for reconstruction. Gradually, PMMC became it took major significant burden the threat of huge resections. And now the era has come of modern microsurgical era. It is the era of free flap reconstruction. It has to be a patient-centric approach, customized for each individual. A very brief mention of history, because whatever we are doing today, the pioneers have been in the history, and it is a must to give them their due share. I'll not be talking in detail about history, but just mention Sushruta, because in India, the plastic surgery was pioneered, and it was by Sushruta. He proposed reconstructive surgery for nasal defects. He took template of a leaf and then designed a median forehead flap for reconstruction of nose. And that is how the advent of plastic surgery started. Now, coming to realms. So, how do we decide what are the wide array of reconstruction available to us? That is discussed in terms of reconstructive ladder. Now, what is a reconstructive ladder? It is a wide spectrum of reconstructive possibilities that is available to us, from simplest to the most complex option available. So this is reconstructive ladder. Now the primary aim is wound coverage and infection. This is pertaining to the disease proper, that if we are removing something, we need to cover that, because as I've mentioned earlier, it will prevent infection and it will give support to the function and form. So this is important. But how it should be done? It should be done in such an anatomical replacement is the term. We need to replace volume by volume in anatomical manner, so that it will maintain function and aesthetics. So traditionally, the reconstructive ladder it started from the simplest form and it went on to the most complex. So it was primary closure, then use of skin grafts, then we used local flaps, and now the era has come of free flaps. The traditional reconstructive ladder was initially followed, and it was universally accepted without considering the final functional result. The transition was in such manner only because there was no other solution available. But now we have the availability of various free flaps. So now the transition has moved on from traditional reconstructive ladder to a reverse reconstructive ladder, or more appropriately, if I say, reconstructive elevator. So what happens in this is it allows you to jump from one step to another in a very creative way, keeping in mind the patient's needs in order to achieve the most desired result. So now what we follow is a reverse reconstruction ladder or a escalator approach. This is the trend that is followed. Why is it followed? Because Now we believe that particularly in cancer surgeries, early aggressive intervention, it leads to better long-term function and cosmesis. So we should start in a reverse order. And also it avoids failure and need for secondary salvage reconstruction. So in cancer, the concerns of from a surgeon's perspective are two, that there can be a recurrence and there can be a flap failure. So if we take into consideration both these factors, so especially considering that there might be a recurrence, a free flap could be a better choice of reconstruction at first go, because that would allow you for a less invasive option in cases of recurrence if there is any. And especially in salvage surgeries or recurrent surgeries, the tissue has already encountered previous surgical insult. There can be effects of adjuvant treatment like radiotherapy and chemotherapy. So in these scenarios, the reconstructive options are very limited. And to do a microvascular free flap in such scenarios, there can be limitations because in previous surgeries, the vessels might have been used or there could be complete fibrosis. So if we use the best possible option in one go, we might retain the easier options for later stages as and when required. And also, if there is, in worst case scenarios, if there is failure of locoregional flaps, then doing a free flap for failure of locoregional flaps is a very tricky situation. So secondary salvage reconstruction also, if we keep options of locoregional for those, it will be better. And utilization of free flaps in the first go is now indicated. So we will go by the reconstructive ladder and see what are the options available to us. But at the end, I'll tell you how we nowadays follow the escalator approach. So the most common in the this is like a add-on. We can use dressings. There is a wound raw area which is left for secondary granulation, and we can apply dressings over it to facilitate better wound healing. The dressings could be as simple as betadine soaked gauze. It can be gelonate, paraffin, antimicrobial dressings. So a wide range of dressings is available. Then when we move further up in the reconstructive ladder, it can be a primary closure. A simple primary closure, when it is done nicely, it gives very, very good result. But it can be done only in situations where we can approximate the wound edges together without any tension. So of utmost importance here is that we should be able to bring edges of wound together without any tension. And when we are doing such extensive resection, the probability of that is very, very low. So primary closure for oral cancer resection is usually very, very limited. And to do so, as I told you, that it should be done in such a manner when we can bring the wound edges together, especially in head and neck area. It is possible in certain areas because the skin in face and neck is very elastic and it has got good laxity. We can easily mobilize the facial skin and we can also undermine. So undermining can allow for greater mobilization and it can facilitate direct closure. And in order to minimize this scarring, we need to plan our incisions in such a way that design, if it falls within the relaxed tension lines of face and neck, it will give a better aesthetic outcome. So, but that is possible only in very limited situations. So next up in reconstructive ladder is skin grafts. A skin graft could be either a STSG, that is a split thickness skin graft, or a full thickness skin graft. Skin graft can be used only in those areas where we have a bed of well-vascularized soft tissue, or a periosteum or perichondrium is maintained on the raw area. On those surfaces, skin graft can be used. And if there is infection on the wound bed, if bone is denuded, there is no periosteum, there is no perichondrium, then graft uptake will not happen, and in such cases we cannot utilize skin graft. So if I briefly tell you what is a split thickness and what is full thickness, in a split thickness we take dermis and a part epidermis and a part of dermis. If we take a whole of dermis along with a little bit of subcute fat, it becomes a whole skin graft. So split thickness graft, it can be used to resurface large defects, because we are taking only epidermis and dermis from a distant organ, and this part will heal on its own. And this skin can be applied on a larger defects. But the problem here is that the skin STSG contracts more, and once it heals, it becomes more prominent as compared to the adjacent skin, and the recovery of sensation is less as compared to the full thickness graft. But again, full thickness graft is suitable only for small defects, because the donor site has to be closed primarily, or otherwise we'll have to put a STSG on the donor site. So that makes no sense. So the sites from where we can utilize full thickness graft, it can be from forehead, preauricular, postauricular region. If we are using eyelid, contralateral eyelid, and the ipsilateral would be closed primarily. Supraclavicular region can be another region for full thickness graft, because here we can close it primarily. So here the limitation is that it can be used only for small defects. Now moving upwards on the reconstructive ladder, we have flaps. So tissue expanders is not generally used in oral cancer surgeries. So I'll skip that and we will come on to utilization of flaps. Now flaps can be of various types. If we grossly classify flap, it can be based upon the type of tissue that we are harvesting. It can be a cutaneous or a faciocutaneous, it can be musculocutaneous, it can be osteocutaneous, or it can be a combination of all these. It can be myofasciocutaneous, it can be osteomyocutaneous, so it can be a combination of all of these as well. Now, according to location, it can be a local flap, regional flap, or distant flap. It can be based upon the method of mobilization. How are we putting it in place of defect? It can be rotation, transposition, advancement flap, or it can be a tissue transplantation, that is free flap. And according to the blood supply they receive, it can be random flap, axial flap, or free flap. Random flap usually have their blood supply from the subdermal plexus. Axial pattern usually has a named vessel, and free flap have a distinct vascular pedicle which is detached from the donor site and transplanted onto the recipient site. Again, in very simplified way, based on their circulation, whether it is random pattern or it has a named vessel, whether it is local or distant, pedicled or free, and what type of tissue it has, whether it has only faciocutaneous or it is osteomyocutaneous flap. Further, we will see in this order: local flap, regional flap, and distant flap. So local flap, what is a local flap? It is a tissue that is mostly detached from the surrounding tissue only, but it retains enough connection to preserve adequate supply to the entire flap. So local flaps which are used in head and neck region are mostly cutaneous flap, and they are used for small to moderate size defects of head and neck. They are mostly cutaneous. I'll come on to non-cutaneous as well. But the idea here is that they are detached from the surrounding tissue only. So it can either be transposed, rotated, or advanced, and the donor site is then closed primarily. So if we are advancing to cover this defect, this site would be closed primarily. Transposition, we can transpose the flap and the donor site would be closed primarily. VY advancement is most commonly used. Then rhomboid flap, it can be a transposition flap. It can be as simple as a Z plus T. It also comes under local flaps. So if you see, local flaps give very beautiful and good result, and they have rich vascularity. There are a lot of options available in local flaps. We can plan long and thin local flaps. Ideally, the ratio which is used is 3:1. And the aesthetic component here is very good because the local flap will give you the best color and texture match. And again, the point here is that we will not be violating any other part of body. It will be in the same incision and same field. Although the advantages mentioned that it requires little expertise, but if I personally say, local flaps need you to be very good in physics, and you need to have that imagination to utilize local flaps to its maximum potential. And of course, it is time saving. So as I said that they are mostly cutaneous flaps, but within oral cavity also, we can use certain local flaps. The most commonly used being buccal pad of fat. So buccal pad of fat, instead of, if there is very small defect, instead of keeping it raw, we can put a buccal fat pad there. Why? Because otherwise it will lead to contracture and scarring in a later stage. Any which way, the patients of oral cancer encounter problems of fibrosis, post-radiation fibrosis, OSMF, pre-existing OSMF. So it is always better if we intervene certain tissue rather than keeping the area raw. So buccal fat pad can be an option. Then there is facial artery-based myomucosal flap that can also be used, but if there is existing OSMF, this is not an option for us. This will also restrict certain amount of mouth opening. Then we can use palatal flap. It is a beautiful flap. It can be used for certain defects in the upper alveolar region. We can also use combination of buccal fat pad with palatal flap. All these can be used in combination as well. Then we can also use tongue as a local flap because it has got rich vascularity. So we can use tongue flap to cover certain defects in the vicinity of tongue. But usually it is not advisable because in long term it does impairs speech to a certain extent, not significantly, but yes. And then at times we need to do a second procedure for once after 21 days for flap cutting. Now, these were local flaps. Now, we can use local flaps for adjoining areas. It can be, again, of wide range. It can be nasolabial flaps, forehead flaps, cervical flaps, or submental flaps. Forehead flap, as I told you, the history began from this. It can be a median forehead flap, it can be a complete forehead flap, or it can be a glabellar flap, central. So it can be rotated easily to cover certain defects of head and neck cancer. The drawback here being that it requires a second procedure and aesthetic outcome over a period of time for all local flaps, it improves. So the catch is here that initially you might feel that it is not aesthetically pleasing and there is a lot of mismatch, but over a period of time, local flaps become better in terms of function and aesthetics. Then nasolabial flap, it can be a superiorly based nasolabial flap or inferiorly based nasolabial flap. If a nasolabial flap is raised very properly, keeping nasolabial crease in consideration, it will not give you any kind of post-donor site morbidity. That is, the crease also will not be so significantly visible, but the point here is that you need to plan your nasolabial flap very well. Only then the post-op scarring would be concealed. If we cannot plan it in a better way, then of course there is a scarring which resembles like a prominent nasolabial crease, but it is acceptable to a certain extent.
Okay,
Then we can have
sorry to interrupt you. Could you please make a bit of fuss because our speakers are in a waiting room. Yeah. You can
yes.
carry
So
on. Yeah, you take time, but I'm just requesting you to.
yes.
Okay.
So it can be, next option can be submental flap. It has its own limitations. It can be a temporalis flap as well. Deltopectoral flap, it requires again a second procedure if we are not tunneling it for a neck defect. Then PMMC became workhorse as the era progressed further, and it can be used for wide variety of huge resections as well. LD flap, not very routinely used, but yes, it is also a very good flap to be considered. Then comes the era of free flaps. So in free flaps, again, there is a huge spectrum available. Radial forearm flap became the choice of reconstruction for defects, small to medium sized defects, because of its thin pliability, long vascular pedicle. It was used in many of the resections. Lateral forearm flap, I don't have any personal experience, but yes, it is also a choice. Then medial sural is an alternative to radial forearm flap. In this, donor site morbidity workhorse. Initially, PMMC was the workhorse. Now, ALT flap is considered the workhorse of reconstruction. Now, if there is a resection which includes bony defect, then fibula flap can be used because it can be modified to mimic the mandible by osteotomies, and it can be used. Especially reconstruction should be done if it is anterior mandible resection. Scapula is another choice for bony reconstruction. When we are doing maxilla palate reconstruction, it can be a very good choice. Otherwise, palatal obturators were used in resource constraint settings, or when there is no availability of free flap. They can still be considered, but still it is advisable that rather than a cavity, we fill the cavity with at least soft tissue flap. So what are the factors affecting choice of reconstruction? In any choice decision-making scenario, there are mainly three factors: patient factor, physician factor, and tumor factors. So coming to first physician factors, the surgeon should have expertise of microvascular free flap. That is an absolute must. And hospital should have resources and infrastructure for the same. Usually it is better if there is a team approach. Otherwise, there are chances of fatigue and efficiency. But yeah, people are doing it single-handedly as well. But in longer term, a team approach is better. A complete evaluation must be done for patient. In terms of patient factors, we need to look for age, functional capacity, whether there have been any adjuvant therapies taken, airway protection, what are we expecting in terms of survival. So patient-related factors like age, what is the nutritional status, what are the lifestyle factors of patient, what are the patient expectations, what are the donor site morbidity consideration, and adjuvant therapy, if any, taken. In patient-related factors, the most common factor which I have not mentioned here is financial constraint, which becomes a major limitation in doing free flaps in many of the arenas. Then tumor-related factor, if I simply tell you the site size of defect has to be considered. So it has to be reconstructed volume by volume in an anatomical way so that we replace the entire functional unit. So if to summarize, if I tell you based on patient status, patient and tumor status, we can opt for no reconstruction, local flap, pedicle flap, or free flap. The function here is to restore function, form, and aesthetics. And based on size of defect, if it is a small defect, it can require no reconstruction, primary closure, skin grafting. If it needs a flap, small to medium defect, local flap. Depending upon patient condition, we can opt for free flap first, because first choice of reconstruction, more aggressive, it is better in cases of cancer. If patient condition or physical or financial does not permits, we have huge area of regional flaps. So what is the future here? Now we say that it is the era of microvascular free flap, but with advancement in 3D printing and bioengineered tissue, regenerative medicines and tissue engineering, we might soon see a new era of reconstruction coming into place, which will include all these things which are mentioned on this side. So if I tell you the reverse reconstruction ladder or escalator, it again has its own disadvantages, because the availability of escalator lift, it leads the reconstructive surgeons to use free flaps as a choice first, which is okay, but we should keep in mind that it is not the technique which is going to solve the problem, but the problem should be considered in terms of site function, aesthetic considerations, and morbidity as well. So I would again emphasize that the patient has to be the center of decision making, and that is how we come to a conclusion that what kind of flap, what kind of reconstruction will be best suited for a certain patient. It has to be a patient-centric approach. Thank you so much. If there are any questions, I'm open to it. And if you have any queries, you can contact me.
Thanks, Dr. Natasha, for throwing light on various decision-making process on various available flaps we should use to reconstruct the patients in oral cancer. Any one who want to ask any question regarding reconstruction? Any opinion you want to take? Dr. Natasha is available now, so you can get the opinion. She has already given her number in the last slide and email ID, so you can contact her. Any question from any registrants or any attendees? They can ask question. They can just unmute and ask question. Or you can ask question in a chat box. Dr. Natasha, right now there is no any question, and
yes,
if there is any question,
feel
stay
free
with
to
us
ask
for a
me
while.
in the chat box. I'll be available for a while, and otherwise you can.
Yeah, so nice of you. Yeah. So, Dr. Natasha, should we move on to our next speaker?
Yes, yes, please. Thank you so much. Thank you all the participants,
Dr.
and thank you to the organizing team for this conference.
Yeah, thanks. Okay. So, now Dr. Natasha have given her email ID and contact number as well. So, anybody have any question regarding reconstruction, they can connect Dr. Natasha for the asking question. Our next speaker is, though her talk is scheduled tomorrow, she was the first speaker, and her talk was scheduled on Sunday, 9th of February from 9:30 onwards. But due to his engagement and all, she is preponed her talk today, and she is not a new face to us. Those who are regularly joining our program, we started this is our fourth edition. Actually, we started from 2022 3 4, and this is 2025. And Dr. Ramya is in all our programs, not this oral cancer, apart from this, and our other program, other specialty like orofacial pain, and she is also in Pink Dental Congress and all. So she is known one to the MedSkill and the any program which is being organized by MedSkill and National Health Academy. Thanks, Dr. Ramya, for sparing your time again and joining again. Yeah, I'm just formally introducing you. Just give me. I'm just hurriedly introducing you because we have lost time because our speakers are busy in doing surgeries, so they couldn't join actually. Dr. R. Ramya is a doctorate in oral pathology and microbiology and has 17 years of experience in teaching. She secured a gold medal in her postgraduate program and was selected for Inspire Scholarship Program for pursuing a PhD from Department of Science and Technology, New Delhi. She was a co-investigator in DST TID project with involved development of novel neuro electrostimulator for management of salivary secretion in xerostomia in elderly patient, which has been filed for India international patents. The device bagged 2 national level award for its novelty and design. She has worked on a joint project with the National Center for Nanoscience and Nanotechnology, University of Madras, and Nanoscale Flexible Hemostat funded by BIRSC New Delhi. She has 210 publication of her name, and she has authored 4 textbooks, 1 international and 15 national patents for medical device and innovation. Significant credentials: research coordinator of Institute Review Board, guest editor of SRM Journal of Dental Research, and nodal officer for National Institutional Ranking Framework Committee 2020. Her current role is Associate Dean, Extension Activities Professor and Head of the Oral Biology, Savita Dental College Department. She is an avid orator and has delivered more than 120 invited lectures till date in reputed platforms. Director of Trimp Academy, which serves as a Center for Excellence in Dentistry. She is a PhD guide and 3 awaiting Viva VOC, and she has been awarded 9 times for different awards and all. And she is you will find him anywhere in say FM radio, any different talks and different forums and all. She is very versatile personality, not only involved in dentistry as well as other part of whether it is AI innovation and whatever. So she is be there. If you frequent on a Facebook, you would be finding that she is talking somewhere in any day in a various Facebook platform. I'm just looking her in a various advertisement or promotional brochures on a Facebook and from different forums actually. So over to you, Dr. Ramya. If I left
that was
you can add and you can
very
start.
lengthy. Yeah, thank you so much, Nurul sir. It means a lot to me, and I'm really happy to be again in this wonderful platform. And it's an honor to be considered repeatedly. So it's very close to my heart, and I'm really very honored to be here again. Without much ado, I'm just starting my talk today. So this talk today is about metabolic reprogramming in oral cancer and institutional experience. So we all know enough about oral cancer. You've been hearing it for the past 3 days. So I'm not going into the prevalence rates or any numbers about oral cancer. I'm here to mainly stress about how metabolic reprogramming happens in cancer and how chronic metabolic diseases are coexisting with cancer. And that is what we all need to know, especially in terms of preventive concerns about oral cancer regimes. So metabolic reprogramming is something which happens in the cancer cell for its survival. When a cell has to proliferate and it has to divide very fast and very quick to undergo a malignant proliferation, what happens is the metabolic activity is multifold. So to keep up with that pace, what happens is the utility of the metabolism and its byproducts, everything again increases multifold. And this is what is actually metabolic reprogramming. In other simpler terms, it is just that cell is surviving, at the same time it is multiplying and it has to spread. So to do that, it modifies itself, it modifies its metabolic machinery to do this kind of extraordinary proliferation and survival. So that is precisely metabolic programming. And this was very nicely brought out to the medical world and the researchers. And this is what actually was brought out in the year 2011 by Hanahan in a very in a extraordinary publication about the hallmarks of cancer, or a revisited hallmarks of cancer. And we can see that from that time things started changing, and again it was all pertaining to the research and the patterns which kept evolving from the past 2 decades very specifically. And this is specifically about the Warburg effect, which typically indicates about the change in the cellular energetic mechanisms. So why is this being told repeatedly? I'm just trying to bring you understand that metabolic reprogramming is a basic characteristic of a cancer cell. You name it, any cancer, there is metabolic reprogramming, only then the cancer cell will survive. So now the next connect is to witness that it has been on the race when there is a existing comorbidity. So what are common comorbidities we commonly encounter, especially in a country like India? We have been very sadly named as the diabetic capital of India, which I feel, diabetic capital of the world, and that is not something which we can even think about. It's a very, very sad state of affairs that diabetes mellitus has almost become rampant, and every member of a family, or most of the members of every family, has diabetes mellitus right now. I'm specifically picking out diabetes, and that is because of the very high prevalence rates. It is not only diabetes mellitus, there are other coexisting conditions, coexisting chronic metabolic disorders, which have a direct impact on this metabolic reprogramming, which the cancer cells are already doing for survival. So the cancer cells have already established, and when there is existing comorbidity of chronic metabolic disorders, this becomes synergistic, and the survival of the cancer cells becomes even better. So it achieves an advantage. So that is the main thing which we are witnessing in our institution. We've been seeing a surge of cancer cases in the last 5 years, specifically in the last 5 years. And the pattern is very, very significantly altering towards non-habit related oral squamous cell carcinomas. And the gender, again, there is the pattern is changing. We are seeing increase in OSCC cases in female gender. So put together, we are becoming very curious about understanding the patterns. We quickly saw the patterns, how and why, and we could very clearly figure it out to these chronic comorbidities which are coexisting. And after which we started observing that whenever a cancer case comes, especially a non-habit related cancer, immediately we try to analyze the history of the patient, the medical history of the patient. And very, very frequently we have come across that there is a coexisting comorbidities, especially diabetes mellitus. So what diabetes mellitus does, this is one kind of, I would say, a model disease which can be explained to understand how carcinogenesis can become more worse. The process which it happens is there is a hyperinsulinemia condition, and this leads to hyperglycemia, and there is chronic inflammation, general chronic inflammation. You all know that chronic inflammation is not only pertaining to diabetes mellitus. Chronic inflammation can happen because of many, many other cases. Very simply put, just a simple a broad spectrum antibiotic can alter the microbial balance. That altered microbial balance itself can lead to a state of dysbiosis, and that dysbiosis, when it is prolonged, it can lead to a chronic inflammation, leave alone diabetes mellitus for that reason. So these are very, very important pointers to remember. So we already know that metabolic characteristics of cancer cells are becoming worse by the Warburg effect, and Warburg effect is what speaks about the deranged cellular energetics. So in comparison with normal cells, when there is the presence of increased glucose levels in that particular patient, the situation worsens. And the metabolic pathways which alter in the presence of diabetes specifically, the entire system or the metabolic pathways, many of them are deranged. It is not only glycolysis. We already know that lipid metabolism very much gets affected in the presence of altered insulin levels. And additionally, the pentose phosphate pathway also gets altered. So when all these mechanisms are totally in a deranged, imbalanced mechanism, there again, the changes are reflected at a genetic level, and all the pathways are getting affected. Specific to be mentioning is of specific mention is mTOR pathway, and it can also lead to other epigenetic modification. As a quick summary of whatever I had said about the comorbidities, specifically about diabetes increases cancer risk by 20%, and it doesn't stop with oral cancer alone. This is a statement given to all cancers. And again, the 5-year survival rate of patients with diabetes mellitus is, is drastically different from those patients who are non-diabetic mellitus. So in this, in view of this, I've been observing this for almost close to 6-7 years, and a study done by my postgraduate student. We were very curious to see how diabetes is influencing the incidence of oral squamous cell carcinoma, and this is a publication. And we found that the PGC1 coactivator, which is a very important mediator of all the metabolic pathways, together was checked, and we found that there was a drastic difference in hyperglycemia patients and patients without hyperglycemia in associated with oral cancers. And another similar study from one of my colleagues recently done also has a very emphasizes on very clearly on how it can have a very significant impact on the carcinogenetic mechanisms. And look at this from it starts from the sedentary lifestyle. It starts from how quickly our lifestyle have been very modified. We are in a time period where all of us are overthinking, or because we are flooded with a lot of information, and overthinking automatically leads to stress, and there is metabolic derangement. And this goes into development of chronic metabolic diseases. And again, it all forms a full circle of increasing the cancer risk. This is a string data, a gene network study, which gives everything about what exactly goes between the molecular level of interplay between diabetes mellitus and oral squamous cell carcinoma. You can very clearly see that the key genes which are affected are clearly indicated. And in case if there is a patient with diabetes mellitus and if there is already a familial risk, these are some areas which we can target upon. So that is something which has to be thought about. So knowing very clearly that there is a clear coexisting relationship with diabetes mellitus and oral cancer risk, and considering that the cases of diabetes are on the risk, are all diabetic people susceptible to cancer? Well, it is one of the risk factors. So that is something which every one of us as dentists have to be very specific about. Suppose if a patient comes to you and he is on a oral hypoglycemic drug or any anti-diabetic medication or a previous history of diabetes, you know that India, it is notorious that they don't take proper treatment, and some of them they use various type of medications, and some say that they're completely cured of diabetes. There are many versions to diabetes disease in India. In case if you happen to meet them, just spend that 2 minutes of extra time of yours to quickly scan through the oral cavity, understand if there is any mucosal change. So that is something which I feel is the responsibility of dentists to give and indicate. You don't have to frighten the patient, but it is our duty, having heard that there is a very big risk that there is a chance of them getting oral cancer or any other cancer for that matter, it is our duty as healthcare providers to alert the patient to be more disciplined, to have a better lifestyle so that they don't damage the body further, pushing it into a malignant transformation or a pre-malignant phase as well. So how do we handle such cases? Or how do we, as healthcare providers, can we take this further? Yes, these are areas where targeted therapies can work really well, because these are areas which have been explored by scientific literature in real depth. So targeting all these pathways can really work wonders. And there have been multiple suggestions as how these pathways can be targeted and how these altered metabolic pathways can be used as a biomarker for identification. And the same way, they can also be used for identification and they can also be used for therapeutic management. So this is one area I would say is area which is definitely frightening, but at the same time, this is one area which can be targeted so well so that we can really arrive at some very good solutions or therapeutic options for oral cancer management. And yeah, I'm sorry, I think. So this is what I feel is a take-home message. So understanding the comorbidities of oral cancer is very, very important for dentists. And please have that sympathy or empathy, not sympathy, empathy towards every patient who walks into your practice, and spend that extra 2 minutes to just screen through the entire zone of the oral cavity. Try to identify if there is any striking area of doubt, and then immediately alert them so that you will be a person who would really be a messiah to help the patient out. And all these processes are very, very important, especially in the Indian scenario. And not only in the Indian scenario, we've been seeing a surge of such cases very, very, very on a very higher note in the other global, in other countries as well. Another interesting finding in our institution, what we have observed is those cases which have diabetes as a coexisting morbidity, the grading of that cancers are always on the poor prognosis side. They are never on the better prognosis side. You know that histopathological grading can be well, poorly differentiated, well, moderate and poorly differentiated. We know that well-differentiated squamous cell carcinomas have a better prognosis. Moderate and poorly differentiated cancers have the prognosis tends to taper down. So we've been seeing that whenever there is a non-habit related case, especially females, most of the time the grading is of very rarely we see well-differentiated cases in such condition. Most of the time it is either moderate or poorly differentiated, which means that the prognosis is poor when there is a coexisting morbidity. So it is our responsibility to identify them and to alert the patient in this regard. So thanks for patient listening. And again, Nurul, thank you for giving me the opportunity for the 4th time this time. Thank you so much.
Thanks, Dr. Ramya.
And I'm open for questions. You can ask me anything. Yes.
Good evening, madam.
Yeah, good evening, sir.
This is Dr. Abhay Kulkarni.
Hello, sir.
Yeah, thank you for a wonderful information. Yeah. Ma'am, I just wanted to have one information on oral cancers. What was the reason for the oral cancers in these cases where you have come across?
What was the?
Like whether they were habituated or were having the oral cancer patients. You have come across with many females with oral cancer patient. So what exactly was the reason for their oral cancer? Was it habit related or non-habit related?
The biggest challenge is nowadays we are facing non-habit related. and you'll be surprised that they don't even have a sharp tooth. So that is the pattern which we have been observing for the past 6-7 years, and that made us very curious to dig deeper and see what is actually making it worse, or what is triggering the carcinogenetic mechanisms. So metabolic dysregulation is something which we feel is the core thing. Yeah.
Yeah, correlating factor, that is metabolic. All the time, is it diabetic is a culprit, or you have found out any other disease also?
So most of the time it is diabetes, sir. Yeah, most of the time it is diabetes. There have been many times of other chronic medication, usage of other chronic medication. Many times we have seen patients with osteoporosis using bisphosphonate therapy, those kind of problems. We have seen hypertension, long-standing hypertension cases also, but I don't see much of evidence in the literature. So for diabetes, there are multiple evidence available in the literature. So when there is no evidence in certain things, but we have just seen it as a pattern, I cannot tell it in the open forum. So very good evidence, as similar to what pattern we have observed, is clearly indicated in diabetes. Whereas the other things which we have observed is very poor oral hygiene. It's something which we are very commonly observing in the recent past. In addition to hypertension and bisphosphonate therapy, to be of specific mention. Yeah.
Okay.
Thanks, Dr. Ramya, for answering the
Thank you.
question of
Thank you
Dr.
so much, sir, and thank you for adjusting the time. I'm really thankful for that. Grateful. Thank you so much.
Thanks. Thanks. So we are running short of time. So Dr. Ramya, we are just pausing the Q&A of yours, and we are moving to the next speaker. Are you there, Dr.? I think she left. Yes. So we are moving to our next speaker, Dr. Anjan Shah. Dr. Anjan, you are there. You are visible. Let me introduce you formally, and then we'll start taking your presentation. Dr. Anjan Shah is an oral and maxillofacial surgeon with a special interest in head and neck surgery and rehabilitation. He specializes in facial reconstruction with microvascular flaps and rehabilitation with implants. He completed his dentistry from Government Dental College, Bangalore in 1994 and followed this with a master's in oral and maxillofacial surgery from Nair Dental College, Mumbai. He followed this with a resident post in oral oncology at Kidwai Institute of Oncology, Bangalore, and moved to UK to complete his fellowships. He has trained and worked at Southampton University, Sheffield University, and Ipswich Hospital. He holds 4 fellowships, 2 from the English and Irish Royal Colleges, and 1 in implantology. He also is the first fellow in an international board of oral and maxillofacial surgery to hold a CAQ, Certificate of Added Qualification in Oncology and Reconstruction. Dr. Shah is professor in the Department of Implantology at Raja Rajeshwari Dental College, Bangalore. He is also a mentor for Nobel Biocare and has guided a number of dentists into developing implants in their practice. He is a consultant maxillofacial surgeon focusing on reconstruction and rehabilitation at Bhagwan Mahavir Jain Hospital, Bangalore. He is currently the representative to IAOMS and the AOMSI, Association of Oral and Maxillofacial Surgeons of India. Over to you, Dr. Anjan, for your topic.
Thank you, Dr. Anwar, for that kind
management of head and neck cancer. Yeah.
And thank you, MedSkill, for inviting me again. I hope I'm audible. Am I audible?
Yeah, you are audible, sir.
Fine. Okay. So let me just share my presentation first, and then we'll.
Yeah, your presentation, your slides are visible.
Slides are visible. Okay. So my topic for discussion is a little different from what we've been talking about. We've been talking about prevention, and we'll go back to the assessment and management of oral cancer. And my topic is how do we manage the neck and why is the neck important in the treatment of oral cancer? And this is a tricky thing because, there's been a lot of dilemmas about how do we treat, should we treat the neck? And I'll try to dwell whatever light I can on this and try to give you an idea of, what the current status is. So, as mentioned by Dr. Anwar, I come from Bangalore, and this is my team who I work with. We work under a group called Bangalore Maxillofacial Associates, and we do a lot of reconstruction rehabilitation work, not only for oral cancer, but also for gunshot injuries. We see a lot of patients from Yemen and Iraq who come for this sort of rehabilitation to us. Now, if we look at the history of management of oral cancer, it was treated in two ways, with surgery and with radiotherapy. And very early on, even as early as the late 19th century, it was realized that oral cancers can spread to the neck. And this part was then treated in different ways. Mostly the treatment when the patient had some metastasis to the neck would be radiotherapy. And eventually Boca in 1906 advocated the radical neck dissection. As surgical techniques improved, the radical neck dissection became the state of the art for managing the neck in oral cancers. Now, if you look at the results from that time, if a patient presented with a lesion in the neck, the survival of the patient was only 38%. And, this is something to remember when we look at today's data. Now, what are the problems in managing the neck and doing a radical neck dissection? So here is a patient who you can see has had a radical neck dissection. And you can see that, the form of the face, he's also had the mandible removed, but you can see from the neck that a lot of tissue from the neck is missing. So when he talks, you can see the carotid pulsating because, the skin overlying is very thin. And especially if they've had radiotherapy, the risk of wound breakdown and getting a carotid blowout is quite high. So a number of patients after treatment with a radical neck and radiotherapy do have a carotid blowout and succumb to it. And that was one of the reasons why we started being more selective. More importantly was a shoulder dysfunction, because what we've discovered is that the patients complain mostly of shoulder dysfunction. This chap is an auto rickshaw driver, and his main complaint is not the appearance of his face, but the fact that because he's had surgery on his neck and he has accessory nerve disability, he's not able to operate his auto rickshaw because, as we know, the hand gears work using the right hand, and he's not able to do this because of shoulder dysfunction. So Simon Rogers, who has done a lot of work in the field of quality of life, did a study on what are the things that affect the patient's life the most. Because yes, it's important that we treat the cancer, but it is also important that we get the patient back to the same quality of life that they had before their treatment. Otherwise, our treatment is incomplete. And what he discovered was that when we look at the neck dissections, the biggest complaint that patients had from all of these was accessory nerve dysfunction. So the fact that if they had weakness of the shoulder, they were unable to do various day-to-day activities like driving, lifting up weights, things like that. So this is why we now try to preserve the accessory nerve when we are doing a neck dissection. So the previous slides you saw how patients could have carotid blowout, and that was eliminated widely by preserving the sternomastoid. The second thing we realized was that preserving the accessory nerve was also equally important. Now, that is why we have gone from doing radical necks to being more selective with our neck dissections. And most of the literature comes from Jatin Shah's work in 1990, where he showed that if you have a tumor in the oral cavity, there is about a 33% risk of micrometastasis to the neck. So patient presenting with a ulcer which is diagnosed as an oral cancer and no neck node palpable in the neck. Scan doesn't show any neck node, but you do a neck dissection, 33% of these patients will have some metastatic neck disease. And most of the disease is confined from oral cancers is confined to level 1, 2, and 3. Sometimes the tongue does have a risk of spread to level 4 because tongue is an area which is prone to what we call skip metastasis. So you may have no positive nodes in 1, 2, 3, and you have a positive node in level 4. And that is what we know as a skip metastasis. But level 5, where the majority of the accessory nerve is situated, has a very low risk of metastasis from oral cancers. And that is the reason why we have gone away from doing level 5 neck dissections if there is no palpable node. So what Jatin Shah advocated was what is called as a staging neck dissection. So basically remove the nodes, and if on the nodes there was a positive pathology, then do a radical neck, because the standard of care at that time was still the radical neck dissection. Now, if we look at why is the neck node metastasis so important, let me just illustrate this with two patients. What happens with a neck metastasis is it significantly affects the staging of the patient, the prognosis, and what treatment you're going to give. So here we can see a patient with a large tongue lesion. And this is, as you can see, a 3 centimeter, so it's a T3 lesion. It's with the depth of invasion, but there were no positive neck nodes while doing a resection and neck dissection. So if we look at the staging of this, T2, N0, M0, so this becomes stage 2. And this patient, because he had a large tumor, we did give him radiotherapy, and he still comes for his follow-up. 7 years on, he is still disease-free. The lesion on the right, as you can see, is a smaller tumor. So this is a 2 centimeter tumor with, again, 5 millimeters depth of invasion. But when we did a neck dissection on this patient, it showed extracapsular spread in 2 neck nodes. So here we can see the stage from what was T2N, the N becomes 3B. So very high staging of the N part of the TNM staging. And that becomes stage 4. And for that, he required chemoradiotherapy. And unfortunately, in spite of that, he died in 2 years. So we can see that neck node metastasis has a significant effect on the prognosis and the management of these patients. So why do we want to know the neck node status? Because it affects the patient's prognosis. If the patient has a positive node in the neck, the disease-free survival is reduced by 50%. Out of that, if there is extracapsular spread in that node, the survival reduces a further 50%. So now it goes down to 25%. So it's very important that we assess the neck correctly because it affects the prognosis and the treatment. So the indications for adjuvant therapy are if there is a positive node. But if you have a positive node with extracapsular spread, then the patient needs post-op chemoradiotherapy. So basically, they have 1 dose of chemo every week, and they have a cycle of radiotherapy over 5 weeks. Now, this is the present classification that we use. So some of the older textbooks may not have this, but all of you should be following the current AGCSE 8th edition classification. And you can see that depth of invasion is very important, because if the depth is greater, it has far more implications than the size of the tumor. You can get a very large tumor, but a very superficial tumor. And these tend not to be so sinister, and the prognosis doesn't tend to be so poor. But if you have depth of invasion increase, that significantly increases the morbidity. So as you can see here, depth of invasion less than 5, it becomes T1. Between 5 and 10 is T2. And more than 10 mm becomes a T3. So depth of invasion is very, very important. But apart from that, neck metastasis is also very important in the staging. And as per the current guidelines, if you have extracapsular spread, it automatically becomes an N3. So as you can see from the classification that N1 and N2 are both ENE negative, which means there is no extracapsular spread, while in N3, there is either extracapsular spread or metastasis in more than one lymph node greater than 6 centimeters. So how do we manage the neck? Again, there is just illustrating from this study that there is no uniformity in how to manage the neck. And for many years, the teaching was you can decide whether you want to observe the neck. So if the patient doesn't have a node positive, we call the patient back every few months, palpate the neck, and if everything is okay, send the patient away. You could do a neck dissection, and that might improve your sensitivity to picking up some neck disease. Or you could simply give the give patient radiotherapy to the neck. So these are the 3 treatment options. Now, what has changed this is this paper from the Tata Group, which was published in the New England Journal of Medicine. So what they found is that there was a significant increase in neck metastasis. And if you don't treat the neck with a neck dissection, you significantly affect the patient's long-term future. So what they did was they had 243 patients where they treated the patient with a neck dissection and 253 where they followed the wait and watch. And when the wait and watch was done, they basically had an ultrasound and a physical examination. And these are the results. What they found was that those who had an elective neck dissection had an 80% chance of being disease-free, while the ones who didn't have a neck dissection had a 67% chance. So more than 10% greater incidence of a recurrence in the neck if you didn't do a neck dissection. More importantly, the survival. So the survival as well was significantly affected by if you did an elective neck dissection, the patient survival was higher, while if you didn't do a neck dissection when the disease was discovered, it was usually a very high stage disease, and therefore the prognosis became very poor. So on the basis of this, and then following this, there have been a number of studies looking at the same thing in different centers. And this is just a list of all the various studies from various centers. It is now sort of a consensus that we should do some sort of detective procedure on the neck at the time of addressing the oral primary. So apart from actually doing a neck dissection, doing a good quality neck dissection is also equally important. So if you remove a neck specimen and if you get less than 18 nodes, probably the quality of your neck dissection is not that great. So it's very important that you have a close relationship between the surgeon and the pathologist in dealing with these to have good outcomes. Again, from a meta-analysis, it was found that if you did a neck dissection, it prevented death of 12.5% of patients and prevented a recurrence in 23% of patients. So this is the current standard of care, doing an elective neck dissection. What else could we do if we don't want to do a neck dissection? We could examine the patient, we can image the patient, we can do sentinel node biopsy. So there are some tools which may more accurately tell us if there is a node, and therefore possibly we could minimize the morbidity for the patient. So one technique is to look at color Doppler ultrasound, look at the pattern of the node, look at the vascularity of the node, And this probably is the most sensitive, but you need to have a dedicated head and neck ultrasonologist, which is someone who is quite difficult to find. The alternative is to do a sentinel node biopsy. So sentinel node biopsy is something which was being picked up from treating melanomas and breast cancers. So by injecting a dye into the primary tumor, we can get an idea of which nodes there may be spread of the disease to. We can simply take out that single group of lymph nodes, avoid doing any significant injury to the rest of the neck, and we may be able to give them the same sort of quality of care as a neck dissection. So again, there are a number of studies on sentinel node biopsy, and overall, there is a favorable outcome on the prognosis by doing sentinel node biopsy. And it may help to reduce the side effects and unnecessary surgery. So a more pragmatic way was to look at comparing the outcomes of all patients. And this is what these studies have done. And what they concluded was that for a patient who had a sentinel node biopsy, if the sentinel node was negative, the patient didn't need a neck dissection, and therefore the patient saved cost and morbidity. But if the sentinel node was positive, the patient then required a second operation, which both in terms of cost as well as, if the patient wasn't a very fit patient, 2 operations back to back could increase the morbidity for the patient. And that is one of the reasons why people are reluctant to take this up yet. Sentinel node biopsy is good for thin tumors. For patients who are not prepared for a neck dissection, if you tell the patient, look, if you could have some shoulder dysfunction, and if they say that my livelihood depends on my shoulder function, you could consider doing a sentinel node biopsy and reduce the morbidity. And for patients who have had a recurrence after a previous neck dissection, where doing a neck dissection may not actually be that useful. Remember, though, that sentinel node biopsy is a technically demanding technique. You need to have, again, a good ultrasonologist or a nuclear detector as well as a surgeon in order to make it quick and cost effective. So sentinel node biopsy is another option if you do not want to do a neck dissection. The other way in which we can reduce morbidity is by limiting our neck dissections. And again, this is something which came out from one of these startup papers by Dr. Pant Vaidya, saying, should we do level 2B and level 5? Because these are the areas where the accessory nerve runs through, and this is the areas where is the highest risk of causing shoulder dysfunction. And what they showed is that for most oral tumors, there was really not a great advantage to doing level 2B, apart from in the tongue, because in a tongue, you can get skip metastasis, and it is therefore recommended to do a level 2B neck dissection as well. The other interesting finding was they found that if level 2A was positive, then B would always be positive. So maybe you don't then need to do level 2B because you're going to anyway send the patient for radiotherapy or chemoradiotherapy. So that's another finding of this study. So finally, which type of neck dissection based on site? So tumors of the soft palate typically spread not only to the same side, but also to the contralateral side. There's about a 25% risk, and therefore a bilateral neck dissection of level 1, 2, and 3 is what is advocated. For a floor of mouth lesion, there is a certain amount of, again, bilateral spread. Anything more than 5% is significant. So therefore, a bilateral neck dissection would be advocated for a floor of mouth tumor as well. And for the tongue, it tends to be more of level 4B involvement, and therefore a skip metastasis could be possible, and therefore a level 1 to 4 neck dissection is what is advocated for tongue lesions. Now, what are the morbidities that the patient can have from a neck dissection? Obviously, accessory nerve damage is the main thing. This can happen because of actually physical damage to the nerve, cutting the nerve, stripping off all the vascularity to the nerve, or it could be, and it could cause both dysfunction and pain. If you're doing a level 4, there is a risk, particularly on the left side, of injuring the thoracic duct and causing a chyle leak. While doing level 5, you may encounter the brachial plexus, and again, this is one of the risks, injuring the brachial plexus, and again, the sympathetic chain as well. So this is a flow chart of what should be treated with a neck dissection and what should not. And basically what Weiss looked at is if the risk of metastasis was 20% or higher, then we should be doing elective neck dissection. And we can see that from this, for most patients with a large tumor or a tumor with a depth of invasion greater than 5 millimeters, there was a good indication for giving the patient a neck dissection. So finally, what should we do for every patient? So if the patient comes with no palpable nodes in the neck, we might still do a neck dissection because we often need to access vessels for a reconstruction. If you're doing a free flap, like Dr. Natasha Nalwani mentioned, we need to access the blood vessels in the neck, and therefore we might as well do a neck dissection as well. If the risk of occult metastasis is greater than 20%, so patients like tongue lesions, retromolar regions, alveolar lesions, and soft palate, probably we should routinely do it because there is a significant risk of occult mets. And patients who are unreliable at follow-up. So yes, we can adopt the watch and wait option, but some of our patients in reality come from rural areas where they may not come back. And therefore, for this patients, maybe it is better to treat the neck primarily because the patient is unlikely to come back for follow-up. And therefore, we follow this policy. Now, lip carcinoma is a special thing because lip carcinoma has a very low incidence of neck metastasis. However, we do occasionally get neck metastasis from an isolated lip carcinoma as well. If this is the case, if this patient with a lip carcinoma also has a palpable or positive node, the prognosis is actually extremely poor because these are much more aggressive tumors than the typical lip carcinomas, which have a good prognosis and require only limited surgery. The other thing that we should be looking at, particularly in terms of prognosis, is depth of invasion. And when we take our biopsies, and I think there's other lectures on biopsies, remember to take a sizable enough biopsy so that you're not only getting a diagnosis of whether the patient has a malignancy or not, but you also have some of the architecture to tell us whether the patient has an invasive front, whether there is significant dysplasia. All of these things can be assessed from the incisional biopsy, and a more aggressive plan may be better for these patients if the incisional biopsy suggests that there is greater incidence of depth of invasion or characteristics of the tumor. At the moment, we do not yet have any specific markers to tell us which oral cancers may spread to the neck and which may not. But in the future, we may have some tumor markers which will tell us, should we be doing a neck or should we avoid doing a neck? Some of the work around microRNA, P16, Ki67 is verging towards telling us which patients are at greater risk of neck metastasis if they have a N0 neck. For the patients who are currently under treatment, sentinel node biopsy may be the least minimal that we should suggest. And if you're doing a resection of a large tumor, we might want to take an in-continuity dissection of the tongue and the floor of the mouth and the neck nodes. Or if it is maxilla, then that of the level 2 and 5 as well for these patients. So the challenge we have at the moment with oral cancer is that it is a disease which usually requires surgical management. Most oral cancers don't respond well to primary chemotherapy or radiotherapy. So if we are going to do surgery for them again, and if the patient does require reconstruction, almost by default, the patient will get a neck dissection as well. Until we find non-surgical ways, I think neck dissection will still be part of our treatment for oral cancers. But what we should assess the patient for to decide what is the risk or need for a neck dissection is looking at the patient's biopsy, the site, the size, and the depth of invasion, whether it is unfavorable histology, need for reconstruction, the patient's general health, and finally, in our country, as we know, cost is an issue because not everywhere is free treatment available under the various schemes. And if the nodes are positive, this is a guideline which I think all of you can access from the NCCN website. And it pretty much lays out what is the treatment. Basically, if a patient has one positive node without adverse features, it's radiotherapy. And if there are adverse features, then automatically the suggestion is to give chemoradiotherapy. And that's how we manage these patients. So thank you all for a patient listening. And that's the end of my lecture. I hope I've given you some insight on how to manage the neck, how to assess the neck, first of all, how to decide which patients are at a greater risk of having neck metastasis, and therefore making a decision of which type of neck dissection to do, and how we can limit the damage by reducing the size of our neck dissection and being more and more specific, like a sentinel node biopsy. Thank you very much. Any of the organizers, are they there? If
Yes, sir. We are here only. Yeah. Anybody, audience, anybody want to ask any question, they can ask question to Dr. Anjan. So neck approach in oral cancer is very important. And those who are the oral surgeons, those who are our attendees or the budding dental surgeon, they want to inquire about the importance of neck management of neck in oral cancer. They can ask question right away.
And also remember that, you know, the oral medicine and radiology is also extremely important, because if you looked at my presentation, the most sensitive way of detecting a node is actually ultrasound. And I hope that some oral medicine trainees take up head and neck ultrasonology as a technique, a specific technique, because this is probably the most sensitive way of detecting a patient when they come for a follow-up to look for nodes.
Yes, yes. Ultrasonography is recommended for detecting the lymph nodes in neck actually. Any audience want to ask any question? Or you can ask question on the chat box.
Sir, you said about skip metastasis, no?
Yes.
Hello? Yeah. I just wanted to have any way we can just have a suspicion of having a skip metastasis in that particular cancer patient. Like what way we should have in a mind to look for the skip metastasis.
So this is actually the reason why sentinel node biopsy became popular, because see, we routinely, let's say for the tongue, do a level 1, 2, and 3, but we often miss the level 4. And actually, you know, if the patient doesn't have any positive nodes in 1, 2, and 3, what favor are we doing the patient by removing those nodes if there is a metastasis in level 4? So by doing a sentinel node biopsy, you may be able to pick up just that node in level 4 and do a very isolated neck dissection. And that would give you the answer as to whether the node is positive or not. So I think for the future, I think sentinel node biopsy will be a very important way of picking up skip metastasis. At the moment, see, we have PET CT, we have ultrasound, but there aren't enough studies to show that any of them prove the accuracy of picking up skip metastasis at the moment. So at the moment, current literature, I think sentinel node biopsy, sentinel node biopsy is still in trial stage, but at currently maybe sentinel node biopsy is the best way to pick up skip metastasis.
Okay.
Any further question? So there is no more question. If anybody want to ask question, they can type on the chat box, and maybe Dr. Anjan
Yeah,
will
sure.
be
Yeah.
here for a
I'd
while,
be
so he can
happy
answer
to,
the question.
answer questions.
So we are, with your permission, Dr. Anjan, we are going to our next speaker, though we are already late actually.
Yeah,
one
sure.
speaker from Italy is already joined in, and one is from Jammu Kashmir. So I'm just introducing these two speakers, and then the last one would be joining from USA. So the next speaker is Dr. Shahida Nasreen. Dr. Shahida, are you there? Can you please unmute
Yes,
yourself?
I'm here. I'm here.
Yeah, great. Okay. So Dr. Shahida Nasreen is Associate Professor in Radiation Oncology in Sere Kashmir Institute of Medical Sciences, SKIMS, Srinagar. And she is having 15 years of experience in radiation oncology with privilege of working at different reputed institute of India, a special interest in GI, breast and head and neck cancers. She have multiple national and international publications. She has participated in various quality improvement projects like Equip India, and I have seen her many in a YouTube presence as well. She is working closely with the social groups and all for making people aware of this cancer and all, how to so I have seen multiple videos in a YouTube where she is involved herself in educating the general population how to prevent cancer. So over to you, Dr. Shahida, for your presentation.
A very pleasant good afternoon to everyone. I first want to thank the organizers for their kind invitation and wish them all the best for the event.
Thanks. Yes, your slides are visible.
Okay, thank you. Sorry.
Yes, it's not
So
sure.
moving to my topic, I will start from the my topic is the recent advances in radiation oncology for the oral cavity cancers. I will start from the algorithm treatment. Oral cavity cancers, as we start the treatment, we, for the purpose of the treatment, divide it into early stage lesions, locally advanced tumors, and the metastatic lesions. For early stage lesions, we mean T1, T2, N0, N1 lesions. Surgery is the preferred treatment, and chemoradiation is given if the patient has inoperable disease. Brachytherapy is the treatment of choice for T1, T2 lesion with N0 neck. And for locally advanced tumors, that is T3, T4, and plus disease, surgical resection is to be done, followed by the adjuvant radiation therapy. And chemotherapy is to be added if there is extracapsular extent with positive margins. And definitive chemoradiation is reserved for unresectable tumors or patient if he is having inoperable disease. And for metastatic disease, if the patient's PS is good, then we can offer him a palliative chemotherapy, palliative radiotherapy, or palliative surgery. But if the PS is low, then best supportive care is the treatment of choice. Now moving to my proper topic, that is recent advances in radiotherapy in oral cavity cancers. I'm going to cover it under the heading of radiotherapy techniques, imaging modalities. Imaging modalities means imaging which is not inside the treatment equipment, and radiotherapy dose and fractionation. This is the first radiotherapy techniques. We treat tumors by external beam radiotherapy, in which we have photons and proton beam therapy and heavy particle therapy, and internal radiation, that is the brachytherapy. Now moving to the techniques, we have started from the conventional 2D radiotherapy. As we see here, this is the 2D plan of radiotherapy. We used to give two parallel portals along with the lower anterior field. What used to happen with that? The tumor as well as the surrounding critical structures used to receive the equal dose. What happened with that? There used to occur two problems with that. One is that we could not escalate dose to the tumor, and at the same time, the surrounding critical structures used to receive the same dose as the tumor. As a result, we could not completely have a better local control of the tumor, and at the same time we used to have higher acute and late toxicities of radiation. So we moved to the conformal radiation therapy. In conformal radiation therapy, we started with 3D RT, which was almost similar to the 2D radiotherapy, and then we moved to the image guided radiotherapy, intensity modulated radiotherapy, which is a her form of the conformal radiotherapy. We use modulated fluence of radiation to treat the tumor, and by which we can decrease the dose to the critical structure surrounding the tumor, and at the same time could enhance the dose to the tumor. This is the IMRT and this is the 3D CRT. As you can see here, the dose wash. Here is the parotid, which is the critical structure in oral cavity tumors. Here we are prescribing dose of 60 gray to the tumor, but we can see here hot spot inside the parotid gland that is receiving 74.8 gray, and at the same time we can spare this parotid gland in case of the IMRT. So IMRT has its advantages. It improves target conformity, can produce intentional dose inhomogeneity, which we call dose painting. It has a better normal tissue sparing, enables dose escalation, can compensate for missing tissue. But at the same time, it has its own side effects or disadvantages, we can say. Sorry for the interruption. My slides are not actually visible here. Okay. So it has increased clinician time for target and organ outlining, needs extensive quality assurance program, increase machine treatment time and increase planning time, and increase integral dose. So when we compare it with the conventional 3D or the 2D radiotherapy, we have achieved we have decreased the acute and the late toxicities of radiation therapy, but at the same time we are not able to increase the locoregional control, neither the overall survival. This was a systemic review and meta-analysis which compared the IMRT with 3D CRT in case of the oral cancers, and they concluded that it has definitely decreased the acute and late toxicities, but at the same time it has not able to increase the locoregional control or the later or the overall survival. So, and at the same time, it has increased the treatment time. So we move to another technique of radiotherapy, that is the volumetric arc, modulated arc therapy. What it does, it helps us in giving a comparable or improved dose distribution versus the fixed field IMRT. By simultaneously varying the dose range, gantry rotation speed, and multi-leaf collimation shape. What happens with that? It improves the patient comfort on the couch and minimizes the organ displacement, and that helps in the reduction in the treatment time. With volumetric arc therapy, there was a study, multi-institutional comparison. They concluded that it was able to reduce the treatment time by 50%. But locoregional control and overall survival was not improved. So we moved to another technique, that is the image-guided radiotherapy in case of the oral cavity cancers. In image-guided radiotherapy, there is a direct integration of imaging into the linear accelerator. All of us know when we use a conformal radiotherapy, we use immobilization devices. But with the higher level of the immobilization, still there are chances of imprecision because of the patients are not completely immobilized by the immobilization devices. So with the help of the IGRT, we are able to increase the precision of radiotherapy by instant correction of these deviations. And this therapy is more suitable for mobile tumors, tumors immediately adjacent to the organs at risk, and in difficult cases of irradiation. There was a study in BMC cancer. They have studied post-operative daily IGRT versus IMRT in case of the oral cavity cancers. What they concluded that for patients with locally advanced oral cavity cancers, post-operative IGRT results in better overall survival, better local progression-free survival, less marginal failure, and shorter overall treatment time than post-operative non-imaging IMRT. But when the radiation oncologists were studying these daily images, what they observed that during the course of the radiotherapy, patients develop significant anatomical changes because of the shrinkage of the large tumor or the nodal masses, weight loss, or resolution of post-operative changes. So what next? So move to the another form of the radiotherapy, that is the another technique of radiotherapy, that is adaptive radiotherapy. What is adaptive radiotherapy? It is replaning patients during treatment either in response to the weight loss or tumor shrinkage or at predefined interval over the course of radiation. Replanning allows the radiation plan to adjust to the changing tumor and the normal anatomy, reducing dose to the sensitive structures, minimizing dose inhomogeneity and inadequate target coverage. Main aim is to particularly spare the organs at risk and at the same time increase the dose to the tumor. But there are two main challenges of the ART. That is the most how to find a most relevant candidate for the ART and what is the optimal timing of replaning. Although the third week is suggested at the optimal timing of replaning, and the patients who have a more radiosensitive tumor, at the patients in which the more anatomical changes or the weight loss is expected during the course of the radiotherapy are candidates of the ART. This is how it works. This is at the time of simulation. This is 2D. We can see when we deliver the treatment, there is motion of the organ at risk 2 that moves inside the treatment plan, and there are chances of more radiation toxicities, acute and late. Here, this is the 3D CRT. As we see, there is organ motions, daily day-to-day motions. As we are giving lesser margin to the GTV, gross tumor volume, clinical target volume, so there are chances of missing the tumor. And same happens with the MRT and IGRT, but we are expecting this with the ART. Adaptive radiotherapy is planning is done either online, real-time adaptive planning, or offline, interfractional adaptive planning. Online or the real-time adaptive planning is more useful where anatomical changes such as tumor shrinkage or variations in patient positioning occur frequently. And the offline is suitable for systematic or slow progressive changes, for example, tumor regression and the weight loss. But to our aim, what we wanted to increase the tumor control, local regional control, increase the overall survival, and decrease the systematic acute and late toxicities of the radiation. But it has not done that. There was a systemic review on clinical adaptive radiotherapy for head and neck cancer. What they concluded, neither the overall survival, local regional control increase, nor the acute and late toxicities decrease. But I want to emphasize here on the point that if we do the proper selection of patients for the adaptive radiotherapy, and if we define the time when we should do the planning, we can achieve the results what we expected from the adaptive radiotherapy. There was also a multi-centric randomized control phase 3 trial of adaptive radiotherapy. They have used even the PET, but the results are not impressive. There is another form of the external beam radiotherapy, that is proton beam therapy. As we see here, the dose depth curve, the protons deposit their dose at particular depth. That is called the Bragg peak. By extending the Bragg peak, we are able to maintenance of the full dosage of irradiation to the target organs, and at the same time are able to reduction of irradiation to the adjacent critical structures. This is the difference between the IMRT and IMPT dose volume histograms. Here we can see the mandible and the spinal cord is completely severed in case of the IMRT as compared to the in case of the IMPT as compared to the IMRT. And there was a systemic review, efficacy and safety of proton therapy versus intensity modulated radiation therapy in head and neck cancers. They have concluded that proton therapy demonstrated superior overall survival, disease-free survival, and better local control rate compared to the IMRT. And toxicities were also less. But the problem with the proton is its expensiveness, and it is available only few centers, so it is not easily accessible to the patients. But I believe that in coming years we can overcome this. Now moving to the internal radiotherapy, that is the brachytherapy. In brachytherapy, we do application of radioactive source directly to the tumor. There is a steep dose gradient, excellent sparing of normal tissues, high doses to the tumor center, a short overall dose delivery time. This is the most conformal form of radiotherapy till date. This is how is it. This is a beautiful isodoses of these brachytherapy. These are the sources, and this is our tumor and target volume. As you see, the dose is received by the tumor, and there is a steep dose gradient outside the tumor. So the normal structures are not receiving as much dose. So the later toxicities, acute and late radiation toxicities are less in case of the brachytherapy. But brachytherapy has its own limitations. First is the invasiveness of the implantation procedure. We don't have sufficient trained staff for the implantation, and there are few centers only all over the world which have a brachytherapy unit attached to their cancer unit. So the brachytherapy is not everywhere available. This is the main drawback. And another is the size of the tumor. That is, it is applicable up to the 4 centimeters of the tumor. Nodal control is particularly challenging, and which we need in case of the oral cavity cancers. But the brachytherapy still has a role. There was a paper in brachytherapy in recently published that post-operative high-dose rate brachytherapy alone in stage T1 to T3 with N0 oral cancers with negative prognostic factors. It was a retrospective study, and they have shown very good results. So brachytherapy still have a role as a definitive treatment in early lesions and as a boost therapy after external beam radiotherapy in case of the bulky diseases. So moving to the imaging modalities, here I'm talking about the imaging which is mounted inside the treatment plant, inside the linear accelerator. Previously, we used to have USG, X-rays, but at present, most of the centers have a CT scan inside the linear accelerator, what we call cone beam CT imaging. How does it help us? It helps us allowing for the accurate positioning, real-time adjustments during treatment, and reduced margins around the target area. And ultimately, it helps in minimizing the damage to the healthy tissue while maximizing the tumor coverage. But there are issues with the CBCT, that is excessive scattering, poor image quality, and ionizing radiation exposure. So we move to the another, that is MR linear. All of us know the MRI helps in a better delineation of the soft tissue. So we're able to identify the brain tissue, nerve, and muscle better, which is important in case of the oral cavity. And it gives a superior target picture, raises the target dose, and at the same time, there is an advantage that biomarkers of picture direct the intensification or the enhancement of the radiation. There was a paper, the value of CT, MRI, and PET in detecting retropharyngeal lymph nodes. Sensitivity was very high for the MRI, and at the same time, specificity was equal to the CT scan. Now, this is the latest PET linear, but results are not yet out. It is in its infancy stage yet. Now, moving to the fractionation, before the IGRT, IMRT, we were playing with the fractionation, especially in case of the oral cavity lesions and the head and neck cancers. We were talking about the hyperfractionation, hypofractionation, accelerated fractionation. We're playing with the radiobiological properties of the radiation. But when we started treating with the IMRT, IGRT, we forgot about the fractionation. But recently, there was a stereotactic body radiotherapy. How is it different from the IMRT and IGRT? It typically delivers a highly inhomogeneous dose within the target, that is hot spot between 120 to 160 degrees. There is a sharp dose fall off outside the target, and high dose perfection is used 6 to 10 gray per fraction. How it acts? This is the mechanism. It causes direct cell death, which usually occurs with the radiation. It causes vascular damage. So the hypoxic cells, they release the HI1F alpha. When we take concentration into HI1F alpha, inhibitors, they prevent the recurrence and metastasis, and there occurs an indirect cell death that leads to immune response. It also causes the immune cytokine releases, and those also prevents the recurrence and metastasis. So SBRT has a systemic effect as well as local effect. This is how it acts locally. How it acts systemic on systemic prevention of micrometastasis or metastasis. This is the tumors, and these are the immunodendritic cells. These are CD8 T cells. When SBRT is given, it causes maturation of the dendritic cells. They cause activation of CD8 cells. These activated CD8 positive T cells act on the tumor, as well as they are released into the circulation, by which they prevent the micro metastasis and the metastasis and recurrence. This is how ICI, immune checkpoint inhibitors, act. When immune check molecules are there, they prevent activation of the T cells. And what happens with that? That T cell is phagocytosed, and T cell is not able to act on the tumor cells, neither locally nor systemically. When we give ICI, immune check inhibitors, they block these phagocytosis of the cells and causes activation of the T cell. Activated T cell acts locally on the tumor cells as well as goes to the circulation and causes the systemic effect. This action of the ICI is similar to the action of the SBRT on the on systemic circulation. So they act synergistically when they are given together. As far as clinical indications are concerned, at present, we are using it for the recurrent and the metastatic setting in case of the oral cavity cancers. But on afferent setting, it is used in untreated elderly patients who are not candidates for definitive surgery or radiotherapy. There was a multi-institutional phase 2 study of concomitant stereotactic irradiation and stuximab for recurrent head and neck cancers. They have concluded that this is an effective salvage treatment with good response rate in this poor prognosis population with previously irradiated head and neck cancer. Treatment is feasible and with acceptable side effects. There was also a stereotactic body radiotherapy as primary treatment for elderly patients with medically inoperable head and neck cancers. They also concluded that survival and they have an encouraging survival and relatively low toxicity in elderly patients with unresectable head and neck cancer with good quality of life. Now moving to another specially fractionated radiotherapy. This is also a hypofractionated radiotherapy. This is not a new technique. It was initially introduced in early 90s. At that time, we used to treat tumors with the orthovoltage radiotherapy. Orthovoltage radiotherapy was lacking the skin sparing effect of radiation. So it used to cause severe radiation reactions on the skin. So to prevent that, they used to use a metallic grid to deliver high doses through the small interspersed openings, allowing recovery of the surrounding skin through the sparing of the stem cells in the blocked areas. Now, this specially fractionated radiotherapy has taken rebirth because of the SBRT, because mechanism of action is almost similar. At present, we are using this fractionated radiotherapy either in the form of the grid or the lattice radiotherapy. In grid, we use a sieve-like metallic block or MLC to generate the high dose peak and intervening low dose valley areas throughout the tumor. This is the sieve-like device which we use for the grid therapy. And for the lattice radiotherapy, we create small, typically 1 centimeter in diameter, islands of high dose spheres, vertices, using conformal technique. Mostly VMAT is used. This is the mechanism of action of the especially fractionated radiotherapy. We talk about the hot tumor and the cold tumor. Cold tumor is at the center of the tumor where there is fibrosis, hypoxia, and hot tumor is at the periphery of the where there are inactive T cells. What happens when we give the specially fractionated radiotherapy? High dose of radiation is received at the center of the tumor. It causes cell death of these hypoxic cells and the fibrotic areas. And low dose is received at the periphery, where there occurs activation of the dendritic cells. They cause activation of the T cells that go into the circulation and prevents the micrometastasis and the later recurrence. These are the isodoses of the specially fractionated radiotherapy. As you can see here, central area receives the 86 gray, and at the same time, the peripheral area receives only 43 gray. There was a article in Red Journal, evaluation of specially fractionated radiotherapy and definitive chemoradiotherapy with curative intent for locally advanced squamous cell carcinoma of head and neck. They have concluded that GRID followed by chemotherapy and SIB-IMRT is well tolerated and yields encouraging clinical and pathological responses with similar acute toxicity profile as in patients receiving chemoradiotherapy without GRID. There was another paper, clinical outcome of specially fractionated radiotherapy in the treatment of bulky tumors of the head and neck. They have also shown a promising results in GRID radiotherapy. Combining specially fractionated radiotherapy and immunotherapy opens a new rope of hope for enhancing therapeutic ratio. These specially fractionated radiotherapy with ICI, the studies are going on and initial results are promising. There is another hypofractionated radiotherapy that has again taken a rebirth, that is the Scott shot radiotherapy. It is a cyclical hypofractionated palliative radiotherapy regime. It was started previously in RTOG 8502 trial for advanced pelvic malignancies. What they used to do, they used to give cycles of 14.8 gray delivered in 4 twice daily fractions, 3.7 gray per fraction over 2 consecutive days. Cycles were repeated every 3 to 4 weeks. Total cycles of 3 were given. And presently, they have been tested in case of the head and neck tumors, and they have a promising result. And studies of immune check inhibitors with the Scott shot radiotherapy are going on. Take-home messages for oral cavity cancers. Adaptive radiotherapy demonstrates significant potential for success when patients are carefully selected and the timing and frequency of treatment replanning are optimized. Brachytherapy is still the most conformal radiotherapy and has a role in early oral cavity lesions as sole modality and can be added as a boost for the bulky lesions. Salvage or adjuvant SBRT for oral cavity lesions can be used in appropriately selected cases. SRF and Scott shot radiotherapy combined with immunotherapy represents a promising advancement in cancer treatment. Thank you. Any questions? I welcome.
Thanks, Dr. Shahida. Anyone want to ask any question? They can unmute your microphone and ask the question right away, or they can put their question in the chat box.
Good evening, madam.
Good evening.
A very nice session, informative session. I just wanted to know that to avoid the unavoidable complication of radiation therapy, especially treating the oral cancers, that is radiation-induced mucositis, do you take any particular measures or you advise any particular measures for that, or at least to minimize that? We cannot advise it, avoid it completely, but at least to minimize to some extent, because after treatment of this thing, oral cancer with radiation therapy, so many patient comes with the debilitating condition in which they come. They are not able to eat, chew food and all those things. So any particular methods?
First thing is with the advancement of the radiotherapy techniques, as well as I was talking about the adaptive radiotherapy, the side effects of radiation have minimized almost. But I would say here that still there are side effects. Especially during the course of the radiotherapy, oral hygiene is very important. That can decrease the side effects, acute radiation-induced side effects, as well as later. So we always tell our patients to keep oral hygiene proper. We usually tell, because I'm working in a government hospital, we tell patients to wash their wash their mouth, take goggles of the normal saline along with the soda bicarb 5 to 6 times a day, and that has helped patients to some extent.
Sodium bicarb mouthwash.
Soda bicarb along with the salt, gargling without 5 to 6 times a day.
Okay, that is before radiotherapy. Before
During the radiotherapy course.
During the radiotherapy course.
During the
also.
radiotherapy course and for at least 2 weeks after the radiotherapy.
Okay. Okay. Thank you.
Thank you, sir.
So, Dr. Shahida, we are getting one message to you from Dr. Ahalya Sagiraju. She is saying that such a brainstorming lecture with so much of information compilation. It was an
Thank you
exclusive
so much.
radiotherapy varieties. So I'm just forwarding this message to you.
Thank you so much. Thank you.
Yeah, if anyone want to ask further question, they can type on the chat box. We are running short of time, Dr. Shahida. Should we move to the next speaker?
Yeah, please. Thank you so much. Thank you.
Thanks, Dr. Shahida, for joining us and helping our all the dental surgeons, budding surgeons. They know much about the radiotherapy and all, so they would be.
Thank you so much. Thank you.
Okay, so moving to our next speaker, let me introduce him, Dr. Stefano Cavalieri. He is joining from Italy, Milan. Dr. Stefano, just say hello so that we see that your mic.
Hello, can you hear me? And
great.
yeah,
Yeah. So we are very privileged and with advantage that a speaker of your stature is joining our program. You are specialized in head and neck oncology. So let me formally introduce Dr. Stefano Cavalieri. He is a clinical researcher at the Department of Oncology and Hematology at the University of Milan, and a medical oncologist at the Head and Neck Medical Oncology Department of Fondazione IRCCS Institute Nazalia del Tumoro di Milano in Italy. His clinical activity is devoted to multidisciplinary management of patients with head and neck cancers and advanced non-melanoma skin cancers. His interests include clinical and translational research in head and neck oncology and rare cancers, real world data, and the application of big data and artificial intelligence to improve the care of cancer patients. His research network experience include participating in the TRI-TRACK program and his advanced training program for young cancer leaders in translational cancer research promoted by the Cancer Corps Europe CCE, an early career investigator mentoring course of the European Organization for Research and Treatment of Cancer. He is a member of Italian Association of Medical Oncology. He is a member of Italian Association of Head and Neck Oncology. He is also a member of European Association of Medical Oncology and EDRC. He is a oncology MD at Oncology of University of Milan and a medical oncologist at the Head and Neck Medical Oncology Department of Fondazione IRC Institute Nazalia del Tumoro di Milano in Italy. Over to you, Dr. Stefano.
Thank you. Thank you very much for your very kind presentation, and it's an honor to me to be here today in such a relevant meeting in a scientific and academic society where so much can be learned about oral cavity cancer. My presentation will be about more generically head and neck cancers, and I would like to. Can you see my slides?
Yeah, your slides are visible.
Okay, great. Thank you. So this is just my disclosures, and an additional disclosure I must make is that I am, as previously said, I'm a medical oncologist, and I devoted to head and neck cancer patients. So I'm not a head and neck surgeon. I'm not a biologist, a bioinformatician. So my presentation will deal with essentially with the clinical implications of the prognostic signatures in head and neck cancer in general, and most of them can be, not all, but most of them can be applied also to oral cavity cancer, and not to the technical or the computational aspects of this. And this is the outline of my talk. And the first question I pose is, why should we focus specifically ourselves on transcriptomics while dealing with the predictive and prognostic gene signatures? And since nowadays, several omics can be studied in cancer, and routine genomics testing has gained relevance in medical oncology. It depends on the regulatory aspects of each site and each institution and each country and so on. But for instance, we can say that it is difficult to plan for instance, systemic treatments for an advanced melanoma lacking the BRAF status, or to manage, for instance, metastatic non-small cell lung cancer without a comprehensive NGS, next generation sequencing techniques. And what I mentioned before deals essentially with genes and DNA, while the focus of this talk is essentially, of course, gene signature, but gene expression signature, so transcriptomics, which is the study of mRNA. And so why don't we go then for genomics in head and neck cancer? Well, historically, several gene-by-gene approaches have been tested and have been explored with quite old papers in this case. And these are two examples of some papers published by my mentor and the group of Milan about the role of TP53 in head and neck, and an association between a functional TP53 protein and a pathologic complete response was described in ITAC, which is the intestinal type adenocarcinoma, the work-related rare tumors of the sinonasal cavity, which was treated with induction chemotherapy. And about oral cavity cancer, in that old study of platinum plus fluorouracil induction chemo for resectable oral cavity cancer, which all of us know that has failed to reach its primary endpoint. In that case, consistently, a loss of function of the p53 mutant protein predicted a significantly low PCR rate, so pathologic complete response rate, and suboptimal response in general to cisplatin-based neoadjuvant chemo in patients with oral cavity, resectable oral cavity cancer. And unfortunately, we don't have drug in this setting to tackle molecular alterations of the guardian of the genome, as it is often defined in the literature, which is p53. And therefore, this even relevant information cannot be directly have an impact on our patients, unfortunately. And as in the case of TP53, the genomic landscape of head and neck squamous cell carcinoma is mainly made of tumor suppressor genes, which unfortunately are not actionable. And other gene-by-gene approaches have been explored in this setting to identify predictive biomarkers of response, not only prognostic biomarkers, to target therapies for head and neck cancer patients. And in the pre-immunotherapy era, some years ago, both EGFR gene copy number and gene expression at immunohistochemistry level have failed to predict the clinical benefit of cetuximab-based, which is an anti-EGFR, first-line systemic treatment for recurrent metastatic head and neck cancer patients. So we need something more than gene-by-gene approaches. And in this scenario, transcriptomics might provide a significant opportunity in the future, and essentially now for clinical research, of course. And in this setting, more or less 11 years ago, Loris De Cecco and the group of the Istituto Nazionale Tumori, which is the Italian way of saying National Cancer Institute in Milan, published this paper in Annals of Oncology. It was a meta-analysis of 9 public datasets, which led to the development and the external validation of a transcriptomic model. So again, mRNA, so gene expression, which was made of 172 genes, which was found to be prognostic independently of HPV status. So many head and neck cancer types, but squamous cell carcinoma independently of HPV. And the same research group of Milan built another large training and validation set through the meta-gene approach, so a meta-analysis of public datasets, including the TCGA and so on, and 6 different head and neck cancer and the neck squamous cell cancer subtypes were identified, summarizing the aberrant alterations which occur during tumor progression. And based on the main biological characteristics, and as you may see here, and the deregulated pathway, the signaling pathways, the subtypes were designed as immunoreactive, inflammatory, HPV-like, classical, and also hypoxia-associated mesenchymal. And the most aggressive behavior was observed in the hypoxia-associated subtype, which is the cluster 3. And this cluster has some very interesting, I think, characteristics, because it has the worst prognosis of the 6 clusters, but still it is a strong predictive factor of response to anti-EGFR drugs. So, as shown in, it was demonstrating for cetuximab, for panitumumab trials, and this was also demonstrating in 2 window of opportunity studies, which explored either cetuximab or afatinib, again, 2 anti-EGFR, in the pre-operative setting for essentially for oral cavity cancer. And at the very opposite of the hypoxia cluster, there is the immune reactive group. And tumors with these characteristics have better prognosis and are associated with a greater benefit to immune checkpoint inhibitors, so those drugs which were mentioned in previous presentation. And indeed, we validated this observation in an Italian multicenter cooperative study, which was a phase 4 study, essentially, of nivolumab, so immunotherapy, anti-PD-1 immunotherapy, in platinum refractory disease. And again, the potential clinical utility of using transcriptomic models in the recurrent metastatic phase was also shown in other contexts and with inflammatory gene signatures, not only immune-related, but also inflammatory. And indeed, in this paper, a 4-gene model shown to be related to a prolonged survival and higher objective response rate in patients receiving first-line platinum plus cetuximab-based treatment in a pre-immunotherapy era, again, in a clinical trial conducted in Italy. This observation is valid not only in the more frequent head and neck squamous cell carcinoma, including oral cavity cancer, but also in rarer disease, which are not rare in some areas, such as China and Southeast of Asia, which is, for instance, EBV, Epstein-Barr virus-related nasopharyngeal cancer. And this is one example. The Rational 309 study was one of the 3 randomized clinical trials showing a significant benefit of adding an anti-PD-1 agent, so immunotherapy, to first-line platinum plus gemcitabine, which is the backbone of chemotherapy for NPC, versus chemo alone in the recurrent metastatic nasopharyngeal cancer. And transcriptomic studies have shown that tumors with a hot microenvironment and those with an activated dendritic cell signature are associated with higher clinical benefits. So something that was mentioned in the previous presentation about hot tumors is again comes back with as relevant information also for systemic treatments. And however, the 3 randomized trials showing the benefit of these first-line immune checkpoint inhibitors were conducted in an endemic area. But then can we translate these results to a non-endemic setting such as Europe? And a similar question can be posed with different settings. Can we assume the biology of oral cavity cancer being identical in Italy, in the Indian regions, and also in Brazil, for instance, and in the US, and so on? We don't have a specific reply to that question. But again, transcriptomics can help us answering this question. And using the NPC as a paradigm, we tried to answer this question. And we saw that the unsupervised clustering meta-analysis of, again, public data set, but of NPC, these were just Chinese NPC data set, where, again, it is endemic, this disease, has led our group to the identification of 4 clusters with specific biological features. And these groups, and why can I go on?
You are audible, Dr. Stefano, and your slides are visible.
Okay, but okay, I don't know what happened, but then, okay. Here we are. Okay, and sorry for some technical issues, but can you see the prognostic values, right? The Kaplan-Meier curves now. I guess so.
Yeah,
okay, great. Sorry for the technical inconvenience. So these groups, as you may see, show different survivals, with the proliferation cluster having the worst prognosis, essentially. and in silico. So this is something that was predicted on the desk with a PC, not treating real patients. So the in silico prediction of sensitivity of two immune checkpoint inhibitors significantly varies across clusters. And the highest benefit was for cluster 1, which was the immune reactive, the lowest for cluster related to proliferation, and the intermediate features for cluster 2, which is the defense response. And cluster 4, which is the EBV exhausted, is an outlier, which is more similar to the normal tissue. Again, please note that these clusters are different from the one of the HNSCC because it is related just to nasopharyngeal cancer. And an opposite behavior was observed while looking at the in silico prediction of the sensitivity, not to immune checkpoint inhibitors, but to chemo, to cisplatin and gemcitabine, which is again the chemotherapy backbone of the NPC. And clusters with better prognosis and higher immune sensitivity are those which are consistently chemo-resistant, and conversely, the proliferation cluster, which has the worst prognosis and it is immune-resistant, was expected at least in silico to be more chemo-sensitive. And these findings suggest that these patients who have a worse prognosis, who are predicted to have a worse prognosis, might benefit from intensified treatments, especially in the curative setting, for instance. And again, the previous slides refer to the endemic area, and what about gene expression in non-endemic areas? And we applied the same cluster-based classification to a cohort of 47 Italian patients, and we observed that the fourth cluster, which was the outlying group observed in the endemic area, is essentially absent in this context. And the same patterns of prediction of chemo and immune sensitivity in the endemic population were confirmed in the non-endemic area. And therefore, again, when we ask ourselves, can we translate the results of this disease from the endemic to the non-endemic setting? The answer should be partly no, if we consider the biology of the disease, and partly yes, if we consider the treatment, the expected treatment sensitivity at least. And again, in the field of virus-related head and neck cancers, a more frequent entity in several geographic areas is HPV-related oropharyngeal squamous cell carcinoma, so the disease related to human papillomavirus. And this malignancy has a well-known better prognosis than its HPV-negative counterpart. However, this is not always true because a fraction of HPV-positive oropharyngeal cancer patients suffer from disease relapse. And in this context, we don't know who will have a worse prognosis, but again, through a meta-gene approach, meta-analysis, our lab group identified the 3 different clusters with specific biological and prognostic characteristics. The cluster 1, which is an immune activated one has the best prognosis, and cluster 2 with epithelial mesenchymal transition aspects and the worst prognosis again, and cluster 3 which is the proliferation related and who had intermediate features between the other 2. And within the context, again, of HPV-related disease, a collaborative effort between North America and Europe led to the publication of an immune-based classification, which was different from the previous one, which has potential, at least, implications for a biomarker-driven treatment de-intensification studies. As most of you know, many de-intensification approaches have failed in this context, and so we need a better patient selection, and biology could help us in this setting. And what is relevant is that most of the gene signatures which I described so far are either prognostic, so they are able to predict the survival, or they are predictive of response to systemic treatments. But as shown by the comprehensive speech before mine, the vast majority of head and neck cancer patients receive radiotherapy, and it is critical then to identify those tumors and those patients who may be predictive to be radioresistant. And in this context, again, transcriptomics might help to estimate radiosensitivity. And one of the published signatures is the radiosensitivity index. The RSI was defined and published by an American group and is a gene expression model made of a combination of 10 hub genes. And it was validated in gastrointestinal and breast cancer patients and is of potential interest, again, in head and neck as well, of course. And in this scenario, I still find some difficulty, okay? And in this scenario, we tested the RSI in a cohort of patients treated in 3 Italian institutions and made 2 observations, essentially. First, the signature is significantly lower in the HPV positive disease than in the HPV negative one. And second, the distribution in the negative HPV negative cohort is wider than the one observed in the HPV positive one. And given that a high RSI, a high number of the RSI implies a radio-resistant disease, these findings in this graph suggest a better radiosensitivity of the HPV positive disease than the HPV negative counterpart, and also that the HPV negative cohort is made of a significantly heterogeneous group of diseases. And both observations are not something new, essentially, but that they are consistent with what we would expect in clinical practice and demonstrate again that transcriptomics gene expression can provide precious insights in better deciphering the complexity of head and neck cancers, including oral cavity cancers. And in the same Italian cohorts, we tested 2 of the previously cited transcriptomic signatures in these figures. And in the HPV negative group, including the vast majority of these tumors were oral cavity tumors, the 172 gene signatures published in Annals of Oncology 11 years ago shown to have a relevant prognostic significance, which was even better than the TNM. And consistently, in the HPV positive group, the survival split described by the 3 gene expression cluster performed better than the TNM staging system, which is, again, the current gold standard for prognostic forecasting in clinical practice. And apart from prognosis, a crucial point in translating the applicability of transcriptomic models in clinical research and in the clinic, ultimately, is the opportunity to adapt curative treatments based on the biological information. And in this field, the researchers who developed the radiosensitivity index further refined the model, adding information about the number of radiotherapy fractions and the dose per fraction. And this led to the development of the GARD, which is the genomic adjusted radiation dose. And this model was validated in several malignancies, solid tumors essentially, including the head and neck, and may be helpful in designing new clinical trials on radiotherapy escalation or de-escalation. And the last point of my talk is the acceptability by patients and clinicians of the use of these approaches and their implementation in clinical practice. Everything is very interesting, but it is, of course, not used anywhere in the world as clinical routine. So this is just a matter of research. And in this context, I would like to bring this scenario to your attention. Let's assume you have a head and neck cancer that might be cured with a single modality approach. For instance, early stage laryngeal cancer, but even a small oral cavity cancer, which can be cured with a radical excision or with brachytherapy, for instance, which may receive either radiation or surgery. Let's assume a hypothetical scenario. And now I ask physicians, if you knew that patient, that specific patient has a radiosensitive disease based on the transcriptomic modeling that I mentioned before, would you go for radiotherapy instead of surgery, sparing all the surgical complications and so on? And the same question is posed to patients. If you are a patient, would you accept a similar strategy and similar approach for you? And if so, the next step is to define how to show the estimated results to the end users. Of course, it can be quite difficult to show Kaplan-Meier curves to patients and while informing them, and also dealing with the information during our speech to our patient can be difficult. So the clinician who needs to make the decision and the patient who will receive the treatment should have an easy way to see the outcome, which is predicted by these signatures. And the optimal way can be an optimal way. One of the possibility can be a clinical decision support system, which is the CDSS in the literature, which is of course nowadays computerized, or at least shown in a graphical way. An international collaborative effort was performed with some European cancer centers, and we have run a pilot study just to assess the understandability of the prognostic information provided by a CDSS, a clinical decision support system, for head and neck cancer patients, which was fed by the aforementioned transcriptomic data. And the same information, as you may see, can be given either textually or with, as you may see, you say that you have a 98% of 2 years of survival, or even it can be given with graphic tools, such as with bar charts or pictograms. All these, in these slides, we are seeing just the same information given in 3 different ways, a 2-year survival of 98%. However, showing these different outputs to even literate patient can make the information less smooth and quite difficult to be discussed. And another issue in this context is how can we trust the findings generated by big data, real-world data, and artificial intelligence? And following the classical pyramid of evidence-based medicine, which is the most reliable attitude in evidence-based medicine nowadays, it lies on strict methodological rules. And would you trust the prognostic information coming from transcriptomic signatures, which was developed through a metagene approach, one of the aforementioned ones, for instance, and then externally validated on thousands and thousands of patients in real-world setting? I would, because I trust the methodology of this approach. However, formally and correctly, the scientific community may have some problems with that, because they would ask for further validation studies before stating that a transcriptomic signatures may influence treatment. And especially this is true for the curative setting. This might be more accepted, for instance, in the palliative one. And however, if you have any solid tumor with a specific, let's say, actionable molecular alteration for which we have a drug, a specific drug, no one from a theoretical point of view and unlimited resources would have any doubt in prescribing that specific drug, even if it's not standard of care in that setting, because we lack maybe therapeutic alternatives. And so why the same scientific community that routinely accept what is bottom right in this figure, so the evidence coming from in vitro studies, is so reluctant while dealing with computational data. So why is let's say, the blackboard to bedside approach usually less trusted than the well-known bench to bedside one? And do we really need randomized control trials to be confident in this setting? And is it ethical? Is it cost effective? Because RCTs, that take years to be conducted. They are very expensive and requires dozens and dozens, if not hundreds of patients to be treated. And isn't there any way to overcome these hurdles? And one way out could be something that was proposed in this paper, where the authors suggest some study designs with external cohorts to evaluate the treatment outcomes in precision oncology trials. And of course, we should take advantage of the data from thousands of patients who have been treated in real-world context, which are already available. We don't need to treat further patients to demonstrate what we already know in some settings. And so these are my very brief take-home messages. And they are essentially, should we pursue transcriptomics in head and neck cancer? Of course, it is expensive. Of course, it is not currently standard of care anywhere. But my answer is Ideally, yes, because I think it is currently the best way to comprehensively decode the complexity of head and neck cancer biology, as we saw that it is even better in some cases of the TNM, and the feasibility, at least in predicting the survival, and the feasibility, however, and the integration in clinical practice are yet to be defined, of course, as I mentioned, both in the curative and palliative settings, but the scientific community should not neglect at least to discuss this application. And this was my last slides, and thank you very much for your attention. And again, thank you very much for your very kind invitation. It was an honor for me to be here with you today. If you have any question and whatever, I will be happy to reply. And these are my personal contacts.
Thanks, Dr. Stefano, for giving your insight of this prognostic gene signatures. And it's very important. I think it's you said that it is being introduced a decade back, and multiple gene signatures already being identified, but is still clinicians are not taking more attention and forecasting the patient outcome and prognosis. So it is the area of actually work that you should guys work with clinician and let them know that how it is easy for the patient, or even the onco surgeons who are taking the patient to surgery, that what would be the outcome and all. So this is a innovation upcoming thing and all, and it is the awareness with this physicians and onco surgeons that they take advantage of this oncogene signatures and all. Any audience want to ask any question, they can ask question right away. So very innovative and newer technologies are coming for forecasting and letting us know the prognosis of the cases and all. Anybody if want to ask question, they can put on the chat box. So I think there is because yeah, very informative talk. One of our audience, Dr. Eswaran, is saying it's a very new actually. So it's out of curiosity. They will first we have to understand. We have learned this, and then it's a just eye opener actually. Then when we deal with it, we studied it, and then when slowly and gradually our the people who are starting application of this for forecasting the cases and all. So nice presentation you, and it's because we have this a fourth edition. It's the first time someone is talking about this prognostic gene signature actually. So it's a new topic added in our IOCCON. So it's good to our audience would have understanding that what upcoming latest trends in diagnosis and management. Yeah, with your permission, should we can we move
yes,
to the next speaker?
Thank you very much again.
Yeah, so nice of you, Dr. Stefano. Yeah, for joining across from Italy. So with this note, we are moving to our next speaker, Dr. Sonal Shah. Dr. Sonal, are you there?
Yes, hello.
Yeah, hello. So your place is say early morning, I think.
Very early morning. I'm half asleep.
Okay. So let me introduce you formally, and I think your origin is from Indian subcontinent, if I missed actually. So your relatives are here in India with the name Dr. Sonal S. Shah is a US board certified and oral pathologist and active oral medicine clinician. She worked previously in New York City at NYU, New York University, where she served as a faculty, signed out cases in the oral pathology biopsy service, and was appointed as a director of the busy New York University Oral Medicine Clinic. She is currently an associate professor of oral pathology and oral medicine at the University of Nevada, Las Vegas, where she teaches all levels of student and residents, sign out cases and pathology consults, and maintains a very busy oral medicine clinical practice. She holds key leadership position in the American Academy of Oral Medicine and has been appointed as section head of the World Workshop of Oral Medicine. She has several publications, and numerous posters and abstracts and review manuscripts for several prominent journals in US. She is regularly invited speaker at national dental and specialty meetings. Dr. Shah is also a clinical researcher, consultant, and advisory board member for several private companies that are involved with early oral cancer detection devices and technologies. So with this brief introduction, if I missed anything relevant point, Dr. Sonal, you can remind, and then you can start your presentation.
Okay, everyone, can you see my presentation and hear me?
Your presentation is visible.
Okay, wonderful. Okay, well, good evening to you all, and very good early morning to me. Thank you for inviting me to this. I am happy to speak for your group. I will be talking about utilization of Velscope and advanced technologies for the early detection of oral precancers and cancers. And I thank you for the kind introduction. I just want to mention that I do oral pathology and oral medicine. And in the United States, oral pathology is very clinical here. So it isn't like in India where it's mainly microscopic. Here we do see patients, we do biopsies, and quite a bit of activity. So I'm an oral medicine clinician, I'm a speaker and a consultant. Okay, so let me get started. Okay. So I have some disclosures here. As Dr. Anwar mentioned, I am a consultant and advisory board member of some companies that are doing early oral cancer detection products. So these are two companies, Velscope, which I've been asked to speak about today, and Vigilant Biosciences, which does a salivary biomarker early oral cancer exam. So both of these companies, I have an interest in and a part of, and so I'm revealing that disclosure. Okay, let's see. So, couple of comments first. I don't think I'm saying anything new to anyone that's listening here, but this is the current state of oral cancer and the problem. You can see that there's some statistics here of 700,000 new reported cases throughout the world, and then of course the most new cases occur in India, as you all know. And it is projected to be, but I'm going to give you some US statistics too, that it's projected to be the third most prevalent cancer among men in the United States in 20 years. Also, as you all know, many of these cancers are detected late stage, and that's why we're always looking for devices, techniques, adjuncts, things that will help us to make an earlier diagnosis. Also, because of the late diagnosis, the 5-year survival rate is around 50%. And if this was discovered earlier, early oral cancer detection, then the survival rate is greater than 80%. And then one other thing I want to mention that is of concern is, here in the United States, there are lawsuits and dentists get sued by patients. And one of the most common reasons, the number 2 reason, is because of misdiagnosis for oral cancer. And the payouts for the patients are a lot, over $2.5 million. So it's important ethically, legally, but also financially for dentists to be able to detect oral cancer appropriately and early. Okay, so there's a diagram here from the MD Anderson Cancer Center that you should see that's showing projections of cancer rates. And here you can see that, this where I'm pointing, I hope you can see my arrow in the circle. Oral and oropharyngeal, mainly oropharyngeal cancers are on the rise and will continue to increase for the next 20 years. Okay, so let me continue. Okay, so here's another statistic. The actual number of oral cancer cases continues to increase. If you look at this number, this is the projection in the United States, actually, from 2007 to 2030. And you can see there's just a continued increase of new oral cancer cases. In fact, 35% increase in the last 10 years. Okay, so I'm just giving a little background before I talk about the diagnostic adjuncts here. So everyone probably knows the oral cancer risk factors. Generally, it's said to occur in older patients, but I think, again, you all know that all cancers are increasing in younger patients, including oral and oropharyngeal cancers. Okay, and then also not the usual risk sites. In the past, we always taught our students that oral cancers, the sides and the bottom of the tongue, the floor of the mouth, the soft palate. But now we see more gingival and buccal mucosal cancers, which you may be seeing in India anyway with the betel quid habit. But this is something that's on the rise and new here. Tobacco use, smoking, chewing. We're wondering about the vaping habit, which is happening a lot here in the United States. But of course, for you all in India, the betel quid is an areca nut and pan is the very big risk factor. Alcohol by itself, not really a risk factor, but heavy drinking and in combination with smoking. Diet is important. Okay, so people that are deficient in fresh fruit and vegetables and certain vitamins are also more prone to developing oral cancers. And of course, for lip cancer, sun exposure. And then there's always a question about chronic inflammatory conditions. Everyone, it's always controversial whether lichen planus and other inflammatory conditions increase the risk for oral cancer. And then, of course, HPV 16 and 18 linked to oral pharyngeal cancers, base of tongue, palate, and tonsillar pillars. Okay, one more background. So all of this diagram here is supposed to show you how important early detection of oral cancer is and how critical it is to the survival rate of patients. So if you look to the left, you can see that, without diagnostic adjuncts, a lot of patients are diagnosed in stages 3 or 4. And then their 5-year survival rate is 5 of 10, so 50%. Okay. But the goal is with new technologies, adjuncts, earlier detections, that the diagnoses will be made in stages 1 or 2, and then there will be a much higher survival rate, aiming for about 9 of 10 or 90% of patients. All right, so now I'm going to move to these diagnostic adjuncts or devices or techniques that are being developed or in the market for early oral cancer detection. So a little definition first of diagnostic adjunct. It's a technique or device applied to an identified lesion, which aids in the characterization of the lesion. So most of these tests are not just based, blind screening. They're for when a lesion is detected, and then these devices are applied. Okay, they can also help with identifying higher risk lesions and biopsy sites. Okay, and improved diagnostic accuracy, and the goal is to reduce false negatives as well with these diagnostic adjuncts. Okay, so this is an overview of the adjuncts that I'm going to be talking about in the next few minutes. So I want to spend a lot of my time on the light-based adjuncts, like Velscope. I will talk a little bit about vital staining and toluidine blue, a little bit about cytopathology. We have a system here or a test here called oral CDX. Maybe I'm not sure about its availability in India or some equivalent of it. Also salivary biomarker tests, including the one that I mentioned at the beginning. I'm a consultant for Vigilant or a Fusion platform. There's also a Viome salivary home test for oral cancer and oropharyngeal cancer. Then I want to just touch upon a test that's tissue-based proteomic assay, and it's called the Stratocyte test. And then there's an oral pharyngeal HPV swab test made by a company here called Omnipathology. And then the last thing I want to talk about is this thing that I just started getting involved with. It's in development where there's a newer intraoral camera and phone-based artificial intelligence test for the detection, early detection of oral cancer. Okay, so starting with light-based adjuncts, we have, a bunch of diagrams here showing you different light-based adjuncts that are in the market. This is the Velscope. You're looking, at what the patient sees. I'll show you another image of Velscope if you haven't seen one or used one. We also have another product called Oral ID. The patients need to wear glasses, and then you also have this fluorescent light that comes out of this. We have VisiLight, Oroscoptic, and other products here that fall into light-based adjuncts. Okay, so this is what the Velscope looks like. Okay, you can see that it's like it looks like a little, almost like a gun. I hate to say that, but that's kind of what it looks like. And the viewer looks in from, the clinician looks in from this side, and the light comes out from this side, and here's the button. Okay, and there are also connections that you can use to take pictures with your iPod or iPhone at the same time that you're looking at it through the green light. Okay, so this is the basic mechanism of how autofluorescence and Velscope works. Okay, and fluorescence intensity decreases with dysplastic progression. So as tissue becomes and cells become more dysplastic, they fluoresce less, and then you have a loss of fluorescence, and you'll see a black or dark color when you look through the viewer. Okay, so you can see here that normal epithelial cells do fluoresce, but as there is abnormality in dysplastic changes and disruption in the collagen matrix, the fluorescence pattern changes. And you can see that there's certain other specific things that are affected and disrupted that affect the fluorescence. Okay, here's an example of a clinician seeing a patient with the Velscope. So you can see here how the clinician looks in here, and then the light comes out here, and they retract the tissue, and the patient has glasses on, and you can see kind of a fluorescence appearance here. It's recommended to do this test in a darker environment or to dim the surrounding lights for best visibility. It's not always easy to do, especially if there's other patients in the clinic. So just do the best and don't shine the chair light or loops light on when you're doing this. Okay, so what do we see using light fluorescence? Okay, so there are fluorescent molecules in tissue, collagen, keratin. You'll also notice that bacteria will fluoresce when you use the Velscope, and that's due to the porphyrin that's associated with their metabolism. And I'll show you pictures of this. Fibrin. Okay, and then there are certain components that do not fluoresce and can lead to false positive results. Okay, and so melanin and pigmented lesions and hemoglobin and vascular lesions. Okay, so these will not fluoresce. They will show loss of fluorescence, and they may present as false positives if you are not aware of these properties. Okay, so here are some examples, clinical pictures of, with regular white light imaging and vision, and the Velscope green light. So you can see here, this is healthy tissue. It has a bright, homogeneous green color. Okay, so this is floor of mouth. Everything is bright and homogeneous green here. We're looking at the buccal mucosa, and this is the lateral border of the tongue. So no abnormality here. This is showing you normal, healthy tissue with the Velscope. Okay. Then here is another example. And over here, you see normal tissue that has alternating patterns of bright and dark fluorescence. Okay, so for example, on the tongue, you can see that, you have this green fluorescence, but the papillae, the fungiform and filiform papillae, show up with a little bit of loss of fluorescence. So you can see some kind of darker spots, darker or black spots here. Over here in the palatine tonsil area, lymphoid aggregates can present with a dark pattern or loss of fluorescence and a false positive. Okay, and here's another image of a normal tissue with alternating bright and dark fluorescence pattern. Okay, so here we have bacteria and the porphyrin response. So you can see that when you use the Velscope and you look at areas that have bacteria, such as the tongue, you might appreciate kind of an orange or a reddish color. And this is coming from, again, the porphyrins that are a byproduct of bacteria. So you'll usually see this in areas where bacteria can colonize, such as the tongue fissures or papillae, maybe some rough keratotic areas, and the palatine tonsils. Okay, here we're looking at hyperkeratosis with Velscope with minimal inflammation. So in these cases, you actually see more of a keratotic presence. It's not a loss of fluorescence, and it's not, you can actually appreciate the white change, and it's not, just a normal homogeneous green. So for example, this patient has a mild hyperkeratosis with no inflammation. You can see this kind of white change here, this linear white appearance. And so when you look at it with the Velscope, you can still see the white keratotic change, and the keratin is fluorescing here. Okay, and so there is no loss of fluorescence. Here's another example. This is on the lateral tongue. There was a white keratotic change. When you look at it with the Velscope, again, no loss of fluorescence, and you can also see the keratin fluorescing. Okay, so these are pigmented areas that show loss of fluorescence and false positives here. Okay, so this patient had melanin pigmentation on the gingiva. It could be racial, it could be, it's likely to be racial, maybe smoker's melanosis, but anyway, there's pigmentation on the gums. And when you look at it with the Velscope, you see a distinctive loss of fluorescence and dark change here. And that is a false positive. Okay, and then here's an example of an amalgam tattoo on the maxillary gingiva that also shows loss of fluorescence and false positive. Okay. These are more false positives. Chronic irritation of the cheek from the teeth has led to 2 dark patches. Okay, so if you look over here, you can appreciate, 2 dark patches here. All right, and so the important thing to note here is that these are very diffuse and not well defined. And under the Velscope, that may be typical of an inflammatory response as opposed to something that's actually precancerous or cancerous that tends to be more well defined with the Velscope. Okay, and the fluorescence pattern of abnormal oral mucosa, we will move to next. So I just want to point out that Velscope is a great tool to help, but you have to know what the false positives and false negatives are before really heavily relying on this. Okay, so now I want to talk about, its use in looking at abnormal oral mucosa. So it's good to look for tissue that has a reduction of normal green fluorescence compared to surrounding tissue. Particularly worrisome things are when you see a unilateral as opposed to bilateral presentation. So we always talk about the importance of symmetry for pathology or oral medicine findings. If you see something, what does it look like on the opposite side of the mouth? And if you see something similar, it could be a variant of normal and you're less worried. Okay, but unilateral presentation is more worrisome. Also, a non-symmetrical shape. And then well demarcated borders are said to be a feature of leukoplakias that are precancerous or cancerous, mainly precancerous. Okay, so here's some examples. This is showing you a lesion in the soft palate, a rough surfaced granular, a little bit red. It's not that easy to see. It's very subtle, actually. Okay, but when you look at it with the Velscope, there's definite dark change and loss of fluorescence. And upon biopsy, this was found to be carcinoma in situ. Okay, here's some more examples. So if we look over here, again, this is a very light white change here on the ventral tongue. It could be missed. It could be dismissed as biting or keratosis. Okay, and the arrows point to some margins here. And when we look at it with the Velscope, there is a definitive loss of fluorescence. And again, the arrows point very nicely at how the margins are outlined by the Velscope. And on biopsy, this was found to be a severe dysplasia. So oral precancerous lesions may show as irregular dark areas. Okay, here's another example. This was an interesting case. This patient was referred for this lip lesion here. But, doing a complete intra and extraoral examination on every patient, we happened to notice that there was an asymmetrical finding here in the right floor of the mouth. So if you look at this closely, you can see kind of a slightly raised, pebbly red change here in the right floor of mouth. So when you look at it with the Velscope, there is a loss of fluorescence for sure. And on biopsy, this was a squamous cell carcinoma. Okay, here's another example. Very subtle, easy to miss. There's some red changes here in the very back of the tongue and the junction with the floor of the mouth. And when you look at it with the Velscope, you can see some loss of fluorescence here that follows the outline of this. And upon biopsy, there was found to be a moderate dysplasia here. Okay, this was interesting too. This was a case of an incidental Velscope screening discovery. So over here, there was just a very slight swelling here. Okay, just a very slight swelling here. And interestingly, the Velscope also showed loss of fluorescence here. And this was actually found to be a low-grade mucoepidermoid carcinoma, which is a salivary gland malignancy. And as you know, Velscope is typically for epithelial changes and carcinomas and epithelial malignancies. But in a mucoepidermoid carcinoma, although it's salivary gland, obviously there's an epithelial component as well. So you can appreciate the change here. Okay, here's more examples. Leukoplakias with true positive loss of fluorescence. So if you look here, there's a small white change on the tongue. And then with the Velscope, there was a true positive loss of fluorescence. You can see the dark change. And upon biopsy, this was a severe dysplasia. Okay, here's another example. This was really hard to see, but if you look closely, and this is a nice higher power view. And this is a picture from one of my colleagues. When I was at NYU, I had the pleasure of working with a top oral cancer expert. Maybe some of you have heard of him, named Dr. Ross Kerr. So him and I worked very closely together, and we shared pictures and patients. So this one was from him. And there was, he was a great photographer too, but you can see that when you look really closely, there are red changes in ulceration. And then when you look at it with the Velscope, there is definitive loss of fluorescence, true positive, and the Velscope was useful here to define margins. Okay, now I want to talk about a couple of false negatives with Velscope. So over here, we have a white change on the tongue. We look with the Velscope and, it's equivocal. It's not a clear loss of fluorescence. So, it almost looks, of normal fluorescence, maybe just a little bit of a change. So, so this could be a false negative. And it seems that Velscope may show false negatives for lower grade dysplasias. It works better for higher grade dysplasias and cancers. Okay, so that there's an example there of a possible false negative. Okay, and then here is another one. This is a patient that had a rough white granular change on the ventral tongue. Okay, and actually upon biopsy, it was a squamous cell carcinoma. And this is a nice high power look at the red-white granular change on the ventral tongue. When the Velscope was used, it really did not show much loss of fluorescence. So this could be another false negative. Here is a false positive from an inflammatory process. Okay, so this was actually erythematous candidiasis. Okay, and it showed a false positive here on Velscope use. Okay, and then here's a nice example. This is a squamous cell carcinoma as on the posterior tongue here. But when you look at it with the Velscope, you do see the loss of fluorescence, but you also see orange bacterial porphyrin fluorescence. This is so true positive. Okay, and so the last thing that I want to say about Velscope is that this is a very recent update that a new model is coming out in March. Okay, and it's going to be called Mantis, and it's going to have a different configuration and a sliding filter, better resolution, integrated device for picture taking. And also, if you've used this current version of the Velscope, it's a little heavy and it has a cooling fan built in because it generates heat and there's noise that comes from the fan. So this is going to be changed in the new Velscope. And there is also going to be a longer lasting battery, so it doesn't have to be charged like all the time. So this is a very new development, and I know this as a consultant for Velscope. I do want to point out, and I was told by one of my contacts, I asked how clinicians can get the Velscope in India. Maybe some of you know, but this was the contact that he gave me in case anyone is interested in looking for Velscope in India. Okay, I want to talk about a few more things. I just want to try and keep track of my time. I think I probably only have 20 more minutes, so I'm going to move a little bit faster. This is T-Blue. I've used this a bit in the past. Okay, it's a marking system and it stains the nuclei. Okay, and so here is another name, Blue, and then Lugol solution. And there's a specific, this is a slide has a lot of words on it, so I'm really not going to say it, but there's a specific way to use toluidine blue where you have to use acetic acid, 1%, and you also have to use water rinse, and then you use a swab to apply the T-Blue to the lesion. Okay, so there's a process for it. Now, so positive finding is marked by blue, and the darker the blue, there's more a correlation with the higher grade dysplasia or cancer. So here's an example of a cancer that was sort of on the ventral tongue floor of mouth area, and you can see it's stained very strongly with the T-Blue, true positive. This is that case I showed you earlier, same case, ventral tongue, kind of granular change. It was Velscope negative, but it's T-Blue positive. So sometimes using multiple adjuncts really helps. Okay, this is a nice example of a T-Blue true positive severe dysplasia in a 68-year-old female habitual ponture. So this patient had red-white changes on the cheek. This was a ponture, and you can see that there's quite a bit of T-Blue positivity that correlates really with the red areas. Okay, and on biopsy, there was severe dysplasia in this patient. So it's a true positive. This is a false negative for T-Blue. Here you had a leukoplakia and it did not stain with T-Blue. False negative. And it turns out upon biopsy, this was a mild epithelial dysplasia. And once again, it seems that the Velscope and the T-Blue work better for higher grade dysplasias and cancers. And you can get false negatives with lower grade dysplasias. Okay, and these are some false positives. An ulcer can stain with T-blue, and any rough surface, such as the papilla, can stain. And this is just due to mechanical retention of the dye, and those are false positives. So you have to be aware of these false positives. Okay, and then I just want to mention one thing where T-blue and Velscope could be used together for biopsy site selection. So there's a patient here, they have a white lesion, but behind it there's also some speckled lesion and red changes, and there's something white over here. So we're trying to decide where to biopsy this. Okay, and this is a higher power view of it. You can see that there's more behind the white lesion, red and white speckled changes. So we're trying to decide where. We do a lot of punch biopsies. I myself in my practice do these punch biopsies where you get these nice round circles. And then we use the where to do our punch biopsy. So this is what it looked like. You can see that behind the white and where the speckled red is where the loss of fluorescence was. And you can see where the T-blue marked in the most red areas. So this is where we decided to biopsy, and this came out as a severe epithelial dysplasia. Okay, I want to talk just briefly about cytopathologic adjuncts. Okay, this is where you can do a scraping with a brush and a computer reads and looks at the size of the nuclei. So we have a test called oral CDX brush biopsy here in the US. So you scrape a lesion, and then you spread it on a slide and you fix it and you send it to this lab. It's located in New York, and they have a computer set up and cytopathologists, and they're looking at individual cells and the size of the nuclei and making a decision. I am not a real fan of this. It's much better to do an actual tissue or scalpel biopsy and see the whole architecture. Most pathologists, oral pathologists, maybe not cytopathologists, but do not really like this. And then the results that come from this, the report is either benign, dysplasia, which means there's some evidence of epithelial changes and larger nuclei, or atypical, which falls in between and says warrants further investigation. So you really get no definitive answer, and you have to do more work or take another biopsy. Okay, and so this is what a report looks like. They give you pictures, these nice color pictures of some cells and the size of their nuclei. And then here, I know this is small, but this was from the right lateral tongue, and it ended up saying atypical cells, please see note. And the note says to follow or do another biopsy. Okay, so here's an example. A patient had some changes here, as you can see, in the floor of the mouth. They did a brush biopsy, which is probably not a good idea, especially considering that this is a high-risk site. And then this is the report with the size of and pictures of the nuclei. But look and see that again, you had atypical cells warranting further investigation diagnosis, which again means that another biopsy or more investigation is necessary. So I am not a huge fan of this, but I just wanted to show, briefly mention it. There can also be sampling error, by the way, and brush biopsy is technique sensitive. Okay, now I want to touch upon a few other things. I want to talk about this salivary biomarker test. One system here in particular that I'm working with. It's called the Be Vigilant Aura Fusion platform. This is currently in the process of FDA approval here in the United States. It has been approved in Europe and Asia, but it's still waiting final approval here. Okay, and so the product essentially collects saliva. There's a saliva collection device here. Okay, and then the saliva is dropped into a cassette, a lateral flow cassette, almost like a pregnancy test or the COVID test that everyone had to unfortunately take, with the pandemic. And then this is put into a reader along with an algorithm, and they're through, with risk factors and an artificial intelligence algorithm, and then risk is calculated. Okay. So this is the current standard workflow. Really, you see a patient. If there's an abnormality, either you do, the clinician does nothing or refers to a specialist. So having a test like this, which is chair side and gauges risk, could really be helpful. Okay, so here are examples of lesions that may be misdiagnosed and benefit from the vigilant biomarker test. So these are very early cancers or things that mimic cancer. So for example, a small traumatic ulcer. And then this is that picture again of that squamous cell carcinoma that I showed you in Bellscope and T-Blue. So this vigilant test, collecting saliva and entering the risk factors would really help with making the diagnosis here, engaging the risk. These are more examples of early cancers that would benefit from this vigilant chair-side salivary biomarker test. So over here, you may not even see it. It's so subtle, but there's a rough red and white change right here. Okay, and then this is the gingiva. The gingiva is red and friable here, and on biopsy this was also early squamous cell carcinoma. So how does the vigilant salivary biomarker test work? So essentially, there are two salivary biomarkers. These are proprietary, so I cannot really mention them. But one is a biomarker for cancer cell reproduction, and another is for the tumor suppressor response. Okay, so these biomarkers, along with what their exact concentration is, what their relationship is, and then the enter of the clinical patient's risk factors, age, gender, alcohol use, tobacco use, leads to a patient decision through an AI algorithm. Okay, and then the patient gets a report gauging risk as high, moderate, or low. Okay, and this test seems to have pretty good accuracy, sensitivity, and specificity. This is what the lateral flow test cassette looks like. Okay, so point of care, inexpensive, repeatable, predictable. And then essentially, once the saliva is dropped into the cassette, it's put into a reader, and then information and risk factors are entered in here. And the reader allows for precise biomarker concentration detection. It sees how the biomarkers correlate to each other and also how quickly. And all of that aids with understanding and gauging risk. And this is over here just to show you the distribution of the Vigilant product. So the main offices are in Texas, USA, but also in Germany for this product. And I just wanted to point out there is an Indian partnership here with the Apollo Hospital and HCG and whatever is down here that I can't see right now. So there are some India partnerships here. So you could look into this product. There's also an at-home saliva-based test that's offered here in the United States. Okay, it's from a company called Viome. And the patient can themselves collect saliva and mail it to the company. And the company will mail back a report, and they're also looking for biomarkers. I have something marked here that it's not FDA approved, and it has a pretty high cost as well, $599 US. Okay, and this is what the kit looks like, the at-home saliva-based test. It comes with a manual, it comes with a funnel, collection tube, and cap for saliva collection. Then the patient puts it in this bag and in this mailer, and then sends it to the company. And then the company does its salivary biomarker interpretation. Okay, and this is just, I'm not going to go over this, but these are the steps for the patient to follow for this test. And these are references that I wanted to put in as well. Okay, the next thing I want to talk about, this is really interesting, I think. I'm not sure if you've heard of it or not, but it's called Stratocyte. And this is a personalized signature-based proteome cancer detection assay for oral cancer. Okay, and what this does is it's going to gauge the level of a particular marker, S100A7, and along with risk factors and an AI algorithm to come up with an individualized 5-year risk of progression of an OPMD, a premalignant lesion, to oral cancer. So this is an interesting test because it seems that dysplasia grading is not enough. We're not able to tell, under the microscope or by grading these lesions, mild, moderate, severe, will they continue to progress? Which ones will go to cancer? Which ones will stabilize? Will some of the mild dysplasias regress? So it's not enough. And in fact, in a large study, by Chaturvedi et al. Of leukoplakia patients, it turns out that about almost 40% of patients that had a leukoplakia that progressed to cancer did not even have any dysplasia diagnosed. Okay, so it's hard to know which white lesions will make it or transform to oral cancer. So this could be a very useful test here. Okay, and then there's also variability among pathologists. Two pathologists can look at the same slide and have different diagnosis. One might call it the specimen dysplasia, and the other may not, or one may say mild, one may say moderate in a borderline case. So there's discrepancies there too. So looking for a way to kind of make this more objective. Okay, so this company looked at a lot of different potential bioproteins, 811 as a matter of fact. And then they decided that S100A7 was one of the best bioproteins for oral cancer detection. Okay, and why? Because S100A7 is important in cancer cell growth, migration, and invasion. And it's been found that oral precancerous lesions with S100A7 biomarker expression are more likely to become squamous cell carcinoma. And this can help physicians and oral healthcare providers and clinicians to stratify patient risk. Okay, the Straticyte test, is the S100A7, it's artificially intelligence, and the patient gets a risk score. Okay, and this is just showing you the workflow, the steps, the biopsy. And interestingly, not too much else has to be done here. Usually if the pathologist looks at the slide and finds an OPMD or a dysplasia, then unstained slides can be sent for S100A7 testing and then read by a computer and comes up with a 5-year risk score. So there's simple integration. There's no need for any additional biopsy. The original biopsy tissue and unstained slides are used. Okay, and this is just the workflow. I'm not really going to go over this right now. And then a report comes out like this showing you a 5-year progression probability, as you can see, and then stratification of low risk and elevated risk. And there's kind of a guideline of follow-up or what you should do based on this number. So it really helps guide the clinician and kind of stratify risk for these OPMDs and personalized management to the patient. Okay, and these are some reference papers for this. Okay, and I just want to show you that it's currently in the process of trying to get reimbursement here in US insurance companies. This is ordering information. You can go to the website for proteocyte.com, and then there's a QR code here and see if you're interested in this test, or it may be available to you or not. Okay, and then there's just bear with me for a few more minutes. I think I'm low on my time, but this is a test for dentists, a swab that they can do, oropharyngeal, and then send it off to look for HPV. And this is designed by Omni Pathology. I just wanted to mention this. Oropharyngeal HPV testing for dentists. These are screenshots taken from the website, and this company is based in Pasadena, California. Okay, and then the very last thing that I wanted to talk about is there's I recently became involved in this project where there's an intraoral camera that's connected to a mobile device that has an artificial intelligence algorithm to help with oral cancer and precancer detection. Okay, this is the introductory paper here. There's a number of people from India on this, from Kerala and Bangalore. Okay, the paper basically says 81% accuracy here, and shows that this is a good idea for oral cancer screening in low resource setting or areas. So I just want to get through this. I just want to show you the basic setup of the system before I run out of time. Some kind of smartphone, an intraoral imaging probe camera, a LED, a battery, and then a mobile application, which is on this smartphone. Okay, and then the intraoral imaging from the probe, there's autofluorescence imaging and polarized white light imaging. Okay, and this generates double images that connect to the smartphone and an algorithm. Okay. So this is what the setup looks like. This is what the phone looks like. This is what the probe and the camera looks like. This is the back view, and this is the front view of this. And these are some examples of images and how this is used. Okay. So one really good thing about this is intraoral, and there's a flexible tip. So you can make it all the way to the oral pharynx and base of tongue. So this is, although this is also autofluorescence based, the good thing is that this is different from Velscope, because Velscope is completely extraoral. So sometimes it's very difficult to see things or get images of things in the very back of the mouth. So with this camera and probe having a flexible long tip and being intraoral, I think this could be a really, really good system here. And this is a clinician using it. And you see how it's, the probe goes in and how it's connected to a phone here. Okay, and then this is kind of a workflow. If there's an internet connection and it's not a remote area, then the images, the white light image and the autofluorescence image can be sent to a cloud and then eventually to specialists to do remote consults of those images. Okay, if there is not an internet connection, then there is a built-in some type of deep learning model here in the device that's supposed to look at the dual images and give some type of risk here or assessment. So these are some screenshots of the application. Okay, so this is what you would see. Oral image classification. You would see these two pictures here with Velscope and white light, and on mobile diagnosis normal, and this is suspicious. You can see there's a dark area here. So the advantage of this is it's intraoral and it can be immediate right there, the interpretation by the AI platform. And I think that really brings me to the end. I just wanted to give you all a nice overview, and I want to end with two nice pictures here of Las Vegas. I don't know if any of you have visited, but we have beautiful sunsets here, sunsets and sunrises. And I think I'm about to have a sunrise right now. It's very early in the morning. And this is a night view of the beautiful Las Vegas Strip with, the fountains and the casinos and the lights. So this is my email address here if you have any questions for me. And thank you so much. So are there any questions for me?
Good evening, madam. Hello.
Hello.
Am I audible to you?
I can hear you, yes.
Yeah. Actually, first of all, thank you very much for enlightening all the clinical aspects and all the information and newer advances you had given. It was a very nice presentation. I must appreciate for that. And I just wanted to have one question. You told about Velscope, no? Do we need to combine it with, suppose, exfoliative cytology or smear of the lesion so that we can have some more reliable findings? What is your opinion regarding that?
So I lost you a little.
Hello.
The connection was a little bad. I lost you. Can you hear me?
Dr. Kulkarni, can you ask once again? Can you brief your question and ask again?
Yeah. The thing is that I hope I am audible. Just tell me when I'm not audible in
You are
between.
audible. Yeah, you're audible now.
Yeah. The thing is that the Veloscope, what you have told, if it has to be combined, if it is combined with exfoliative smear at the same time, do you think we will be getting the positive and more reliable results?
So typically that's usually not done. Okay, so essentially you use a Velscope and you know the false positive and the false negatives, and as long as you know those, typically based on those, you go straight to a scalpel biopsy. That's what we typically do. Now, I showed you an image where there was combination with T blue, the toluidine blue. So, these things are more, chair side, right? Velscope and toluidine blue. If you do a exfoliative cytology, then, you have to send that off and wait. It's not point of care and chair side anymore. So,
Okay.
so I'm not really recommending that. Yeah.
Okay. Dr. Sonal, there is one question from Dr. Ahelia. She is asking that what is the cost of a site kit? Stat site kit is the cost. I think her connection is again gone.
What is the cost of the Stratasite kit?
Yeah.
Yeah, so it's not, I will say right now it's not the most cost effective. Okay. I mean, this is still a young company. They're still working on developing the test and getting insurance coverage here. I know for us, I don't know exactly what it would be for India, to be honest. Okay. And the company is Canadian as well. The Stratasite company is from Canada. Okay. And so the cost for US right now, with no insurance coverage, is $500. So, and I don't know if it would be a similar equivalent, in Indian rupees. I don't know the answer to that. You'd have to go to the site and see.
And there's one more question. She asked that how routinely you are using Wellscope for diagnosing the patients and all. How often would you use Wellscope during routine examination?
Yeah, so that's a good question. I'll tell you, as a specialist myself, I don't use it for screening, right? I mean, if you're an oral medicine specialist or clinical oral pathologist, or you don't use it for screening. You use it when you find a lesion and you think it might be suspicious. You want to find a biopsy site or something like that. But I get referrals from many general dentists who are using it as screening devices, and they just are sweeping it throughout the mouth, and anything where they see loss of fluorescence, they're sending it to me to look at. So I don't really recommend it for routine screening. It's really if you see a lesion, an identified lesion, then you should look at it, knowing the false positives and negatives. So I hope that answers that question. But I will say there are general dentists, at least here in US, that are using it just screening. And patients like to see it. Patients like to see this technology. So that's how
Patients
that
are
is.
satisfied that something new is being used upon them actually.
Yeah. They don't really know that what it's really doing, but they look at it and they say
The
this
light
looks
is
good.
attractive. No, the lights are attractive because they are thinking that something is, they are doing. And I'm a
Yeah,
and yeah.
exactly right. So that's it.
Anybody who want to ask question? Otherwise, any question, Dr. Sonal has given her mail ID sonal.s.shah73@gmail.com. So if you have any query, you can write an email to her and wait for the answer. If she gets the time, definitely she will get back to you. So nice presentation of this all diagnostic adjuncts, and you have given in depth. You have nice presentation with good images and photographs and all. So it's like a live actually. It's not bland words only. There are a lot of images you have used in your presentation and make it further live and more knowledgeable and all. So thanks, Dr. Sonal, for you have to get up early today for us, and you have taken a pain to present with present your topic actually. So we definitely thankful. My whole organizing team is thankful to you for giving your talk, and it's a long talk, say 40 minutes, and but you are spellbound, so everybody is watching it attentively. So with this note, with your permission, Dr. Shah, we are signing off for the day. We are closing for the day. This is the last presentation, and tomorrow we'll joining again at 10:20, and you
One more nice day.
yeah. And tomorrow there is an announcement that the first we are not starting by 9:30 because Dr. Ramya has already given her presentation. So we would be joining by 10:20 with the first speaker, Dr. Asim Mishra. So I will be, putting the notice board on our website. So we would be starting 50 minute late as a scheduled actually, because Dr. Ramya is already presented today. She said that she has some, something actually with the personal occupancy. So she said that, could you please take a day earlier? So we have taken her today. So with this information, tomorrow we will start by 10:20. We have a good, what I would say, speakers joining from Dr. Asim Mishra, Dr. Srinivasan, Dr. Tiwari. Then Dr. Efsun will join. Dr. Ruwan Jaisinghe will be joining from Sri Lanka. Dr. Saidul Islam is a known person in a reconstructive surgery in India. He would be also joining. Then Dr. Rasika will be joining from Sri Lanka. Then Dr. Vishal Rao, Dr. Manjula. So there are many speakers who are coming today, tomorrow, and they will discussing. And there is a one more speaker who is joining late evening, just like Dr. Sonal, Dr. Snehal Patel. He would be talking about novel technology for early diagnosis of oral cancer. So with this note, we are closing for the day.
Thank you. Thank you
Thanks
so
for-
much for your attention and invitation. Good night.
Good
Now
night.
I'm going to go to sleep. Okay.
Yes. Okay.
Okay, goodbye.
Goodbye.